interest to disclose. And over my presentation, I'll talk about these things, the bone marrow types, the product management, graft management, and some of the cases or complicated scenarios that we encounter. And as I said, transfusion medicine is very vital for the success of bone marrow transplant. It supports patients through the whole phases of bone marrow transplant from before, even before the decision of transplant until after. And there are many challenges that we face, not the least maybe is ABO compatibility, but other complications due to the long transfusion history and infection risk. And we ensure that all blood components are safe and irradiated and free of diseases as much as possible. And recently, as you all many centers are having CAR T cell therapy introduced into the surface in the big cities, and this is another challenge that we are facing. Maybe one CAR T have the workload and volume is very huge for from blood transfusion support from the apheresis until the discharge of the patient. And I'll start with having this case, 23 years old male who he has been diagnosed with AML and he was conditioned. He's going for a transplant. His blood group is A positive and the donor blood group is B negative. So different blood groups at the ABO blood group and in the RH. So what type of ABO incompatibility this patient has? And I will, maybe you all know and aware of this type of transplant. The transplant that can be autologous or allogenic, and the donor can be fully HLA matched or matched unrelated or matched mismatched family members. And the source can be from umbilical cord, and all of these can be ABO matched or ABO mismatched. And the source of bone marrow can be either from bone marrow or peripheral stem cell, and mostly coming from peripheral stem cell collection. And part of the workup that we have from transfusion point of view, the blood group, maybe a blood screen, antibody screen, we want to have extended red cell phenotype for the proper selection, antibody titer, Coombs, and other tests. Also, the products before transplant, we have all of the blood products are irradiated and leukoreduced. And the definition, the peri-transplant phase from the time of immunosuppression to engraftment, as you know that HLA and ABO antigens are expressed on two different chromosomes. So the HLA matched and the ABO, they are not, sometimes you have HLA matched and ABO mismatched. And the 25 to 50% of HLA matched allo transplants, they are ABO incompatible. From that point of view, the bone marrow from ABO point of view, they can be ABO compatible or major ABO incompatible. The major ABO incompatible when the recipient having a new antigen, the donor has a new antigen to the recipient. Minor ABO incompatibility is the new antibody is introduced. For example, the recipient is AB or AB and the donor is O. Bidirectional when the antigens and the antibodies are different. And this is a table showing the compatibility between the two, all blood groups. The issues we encounter in major ABO incompatibility that the recipient lymphocytes, they continue to produce the antibodies against the newly transfused bone marrow antigens. So this will continue for up to 3-4 months. And because of that, the hemolysis of red cells at the time can be at the time of graft infusion, and it will continue thereafter because antibodies will stay for some times and they will continue to destroy red cell precursors, transfused or precursors. And this will delay the RBC engraftment, and this may not impact platelet or neutrophil recovery. But RBC chimerism may exist for weeks to months, and this is potential for delayed hemolysis also. And because of the damage of pure red cell, because damage of precursors, one of the complications that can occur is the pure red cell aplasia. However, with minor AB incompatibility, where the new antibodies are infused in a donor, an A or B recipient and donor is O, there will be some hemolysis that occur later on, 7 to 14 days post transfusion. And in this patient in particular, the production of antibodies in donor graft uh, will continue. So we have to remove this antibodies from the graft at the time of infusion. There might be some clinical signs of hemolysis in 10 to 15% of the cases. And might be chance of delayed hemolysis due to passenger lymphocytes. Passenger lymphocyte syndrome is a known complication. It's manifested by hemolysis that occur 5 to 15 days post transplant. It can be rare after 6 weeks. So we have to measure antibodies against the recipient red cell antigens. The infused lymphocytes, they have the memory cells of infused lymphocytes. They will start to produce antibodies, for example, anti-kill, and the graft already have kill antigens, so they will hemolyze those kill positive cells. The issues with ABO-incompatible bone marrow transplant, it can impact, it has some impact on on the outcome. However, there is inconsistent data. The reports of the overall that there is inconsistent reports of this impact on survival. But there is increased transfusion needs. Patients with major ABO incompatibility often have higher red cell transfusion requirements and may need prolonged transfusion support. However, the mismatch does not typically affect the engraftment of neutrophils or platelets, or doesn't increase the risk of GVHD. Back to our case, by definition, or after having all this now, it's considered a bidirectional ABO and RH incompatibility because of the differences in the both have a new antigen and a new antibodies. At this case in particular, he started as A positive. The first column is this is the antigen, the forward grouping, and he is A positive, and he start gradually as you go down. He started to lose the antigen expression gradually from 4 plus until mixed field and almost negative after 3 months. And the D antigen, it was positive in the beginning, anti-D, it was positive, and gradually losing the RH antigen, and the new B negative cell starts to be expressed gradually. The ABO type post-transplant, over weeks to months, the recipient still develop donor hematopoiesis and immune function, and the graft may contain some anti-A or anti-B from the donor, and these antibodies are increasing with time as the graft start to produce hematopoiesis. The recipient red cells, they slowly disappear and transition to the donor type. Of course, this can be impacted or obscured by regular transfusions. We have to monitor the patient post-transplant with retics and hemoglobin and see the degree of hemolysis in those types in particular. And also we have to monitor the antibodies, the isohemagglutinins, the anti-A or anti-B. And if we have the ability to differentiate between IgG and IgM, that will be even better. And before transplant, if the titer is very high for the isohemagglutinin, if the titer exceeds 1 to 128, it's better to intensify the monitoring more than weekly to see the degree of hemolysis. This is the recommended transfusion strategy for bone marrow transplant patients, especially in the peri-transplant phase. For major, it is advised to have recipient type in the beginning, and for minor, donor type, backed RBC support, and the platelet and FFB, the opposite. In the bidirectional, we always like to have O backed RBC and universal backed RBC or plasma. So when to switch and label the graft or the patient with the new graft. Only if you have only the donor type without mixed field and no transfusion for 90 days minimum. And there is no forward and reverse are matched in two consecutive blood samples and supported by 100% donor type by molecular studies. And of course, negative that. Post transplant or post engraftment, we treat the patient with like a normal patient, give him same blood group. In summary, ABO transfusion support, ABO incompatibility in transplant is a big challenge for transfusion and require significant support, and sometimes it is significant risk. So what is the role? Now we have ABO incompatible graft, so we can help in the blood bank and cellular therapy. We can help from irradiation point of view. We have to irradiate an autologous transplant. The irradiation starts 7 days before stem cell collection in order to prevent any collection of allo of potentially viable lymphocytes that can cause TAGVT in the future. Allo bone marrow transplant and recipient, we irradiate blood products right from beginning pre-transplant until even post engraftment, even would continue, even with the presence of GVHD. Donors for allo bone marrow transplant, before collection, we irradiate any blood that will be given to them just 7 days prior to collection. What about the graft? Major ABO incompatibility, we have major backyard, if we have a big amount of red cells, especially in the bone marrow, up to 500 cc of red cells are present. So we have to remove these in order to minimize the degree of hemolysis during the infusion and after. And while in stem cell collection, the amount of red cells is very small, less than 20 ml, and as long as the hematocrit is less than 2%, no need to do any intervention. And of course, sometimes in patients, we have to do, in recipients who have high titer anti-A or anti-B, we have to remove those antibodies by plasma exchange. So, some cases we have, due to long-term therapy, they became refractory to platelet transfusion, and these patients also a major challenge for transfusion. What is the definition of refractoriness? When patients fail to respond to the platelet transfusion, and it is by definition, when the corrected count increment is less than 7,500 by count with 1 hour post infusion. And this can be due to primary or secondary causes. Most of the causes, 80% are non-immune, due to splenomegaly fever or the IC and others. And 20% are immune due to HLA antibodies or anti-platelet antibodies. Shukran. And from support point of view, these are the available products. They can be cross-matched or HLA matched or HLA antigen matched or ABO matched. The cross-matched platelets are physically cross-matched platelets. It is not widely available. It is much faster to provide for those patients. HLA match require the presence of HLA registry, donor registry that have all the epitopes and HLA profile for many thousands of donors. But also for antigen negative match, when we know the HLA profile for the patients, and we know that he has this antibody, so we ask the donor registry to give us specific antigen mismatch, antigen negative HLA negative platelets. Some also complicated cases is the neutropenic patients, and these patients require granulocyte support, and the blood bank provide these granulocyte to those patients. Patients usually they have severe neutropenia, less than 500 ANC, and they are failing to respond to antibiotics, and they are waiting for a transplant, and they have invasive infections. In these types of patients, we collect granulocytes from either family or acceptable donors to collect by apheresis. Some centers they collect by buffy coat. We don't do that here. And these sometimes they provide good. The problem is availability of donors and the dose, usually not available. Of course, the donor need to be mobilized with GCSF or dexamethasone, both or either. The response is can be favorable or sometimes unfavorable due to the logistics, not availability of donors, dose is not high. Now we'll talk, as I said, we have now CAR T cell therapy is available in many big centers, and transfusion medicine plays very big role in the support of those patients. We are collecting the CAR T, the raw material, the lymphocytes to send to the manufacturing companies to CAR T provide, and also provide blood support for all those cases and cellular therapy. As you are aware that the journey of CAR-T started from collection, patient selection, collection, and sending the graft collected by the apheresis center to the private company for CAR-T manufacturing, and then ship it back to the transplant center. And in between, the conditioning and the bridging therapy and the chemotherapy, patients still continue under the oncology support, requiring a lot of the transfusion support. Some of the challenges we face in these cases is that the number of lymphocytes we collect is small, and in these particular some companies require that you, before you send the graft to the manufacturer, you check the lymphocytes and make it adequate. And maybe the company will do some processing to augment the lymphocytes. Some of the studies have found that there is inferior outcome in some between EU versus American patients, and they found that those who were treated with CAR-T therapy, the longer the waiting time between the collection and the infusion, the higher the survival was more in those who have short waiting time or bridging interval between collection and infusion. So also, I'd like to mention that cytopenias following CAR-T therapy is increasingly studied and became well known to the experts, and they can be, and these cytopenias require a lot of transfusion support from all the granulocyte, the platelets, anemia, and they are divided into phases early within 30 days, and they are due to either chemotherapy or cytokine release syndrome driven, or prolonged, or late due to bone marrow failure or due to clonal evolution or relapse. And this study look at the degrees of cytopenias for both the hemoglobin, platelet, and neutrophils over time. The good thing is that this degree of cytopenias is decreasing with time. The first is the early phase before transplant toward post-transplant phase. So they found that the anemia following CAR-T therapy peak around day 30 to 60. They start high, but gradually they decrease. The thing here is that the patient, the sample size decrease over time. While thrombocytopenia following CAR-T therapy, they continue further from day 30 until day 180. And of course, for both, there is increased demand of platelet and backed RBC support. This is one of the largest study who have looked at transfusion needs and CAR-T cell therapy only in large B-cell lymphoma, and we are hoping that there will be more studies that will come. And in this study, large cell lymphoma, the peak of there's an increase in transfusion needs, both platelet and backed RBC and platelet, and they peak just after transplant infusion. But the good thing that they decrease later on. 2 minutes, please. Transfusion, and there is some predictors of transfusion in this study. One of the predictors are this is early and late, and for both platelet and backed RBC. In the early phase, one of the predictors who's statistically significant in the early phase, age more than 60, increase in transfusion within any transfusion, more than one transfusion within 6 months before CAR T therapy. Hematox score is the detail in the other side. It is platelet count and hemoglobin, interferon, serum ferritin. Those who have more than two, they have increased. In the late, the same thing with transfusion and high hematox score, CAR hematox score, and the use of one CAR T versus the other in the early phase. So, does this have any impact on survival? Early and late transfusion are associated with poor progression-free survival, overall survival, and increased mortality after CAR T cell therapy. This is the summary of the last thing, and thank you very much.
Yeah, thank you, Dr. Ammar, for the nice presentation. Discussion will be at the end of the session. Our next speaker will be introduced by Dr. Jamal.
السلام عليكم يعطيكم العافية جميعا. It's my pleasure to share moderation of benign hematology session with dear colleague Dr. Ahmed Al-Bahrani. Now our next distinguished speaker will be Professor Dr. Mansour Al-Jabri. Dr. Mansour Al-Jabri is a consultant of hematology, blood transfusion medicine, chairperson of pathology department at King Saud University, also director of blood transfusion services of Dalla Health Group. Professor Dr. Al-Jabri will give an overview over hemoglobinopathies. Let's welcome Dr. Mansour.
Hey, Assalamu alaikum. Good morning, everybody. It's my pleasure to be with you today to talk about hemoglobinopathies, and I'd like to thank the organizing committee. And actually, they asked me to make it like an interactive session because they know that the most important issue all the time to me is to enjoy my lecture. Because I'm sure if you enjoy it, you'll get benefit of it. But if you don't enjoy it, you will be busy with your phone. So how can I move it? اللي وين؟ Okay, this one? Yeah. This one, okay. So, as you know, hemoglobinopathies are a group of inherited hemolytic disorder caused by either quantitative or qualitative abnormality of hemoglobin. It might be related to thalassemia, in which we have reduction of production of normal globin chain, or it might be related to structural variants, in which we have normal production of abnormal hemoglobin, in which the clinical manifestation of the disease result from the physical property of each hemoglobin, like in hemoglobin C or hemoglobin S, in which we have reduced solubility. Otherwise, hemoglobin is produced in normal amount, and this is why we don't have hypochromic microcytosis, by the way, in sickle cell disease. Combined hemoglobinopathies, in which we have a co-inheritance or double heterozygous for thalassemia versus and structural variant, or we might have like double heterozygous for two structural variants hemoglobin. Again, it is like globin diseases. So, you know, since 20 years, I keep asking myself, is it really challenging? Because in the majority of cases, the diagnosis and the management is straightforward. However, in some occasions, it might be very challenging, in which you celebrate once you reach the diagnosis. And to address this issue, actually, I brought those two examples from CAB proficiency test, which I think you are familiar with. If you see the first case, It was for 20 years old patient from Greece presented with recurrent gallstone and mild anemia. And he's having what? If you see that he's having abnormal variant and he has splitting of hemoglobin A2. While the other patient is 36 years old man without any relevant clinical features, he does not have any symptoms, and he's originally from China, and he's having abnormal variant while hemoglobin A2 is normal in normal shape. So the classical question for CAB proficiency test is whether you have alpha variant, alpha and beta variant, or there's no variant. Actually, if you see, last week, the CAB team released their report. They do 18 years actually, retrospective analysis for all the results that generated from CAB since 2005 to 2022 with almost 7,000 lab participant lab, CAB accredited lab. And the lab task was to identify affected globin chain and to diagnose hemoglobinopathy. And the analysis was directed toward the error generated and actually the percentage of error among the responder and the outcome performance evaluation and error trend identification. And actually for 18 years, they sent more than 240 cases, and the majority were like beta variant, alpha variant, it might be delta variant, common variants, rare or uncommon variants. So when they analyze it, actually, they discovered that, for example, in 2007, the error rate was reaching 86.5 in hemoglobin New York. And yeah, and in 2021, the lab actually, about 25% of participants, they failed to recognize hemoglobin C, beta and beta thalassemia. And the majority of the error actually is generated because of combination of alpha and beta globin chain, and around 20% for both alpha and beta variant. So what is the stepwise approach to reach the diagnosis of hemoglobinopathy, taking an example here as CAB proficiency testing? If you see, this is the result of their study, and in 2005 or 2007, actually, 86.5, they failed to detect the hemoglobin New York, and even in 2022, 23% of the participants, they failed to detect hemoglobin E. So why is that? And what is the systematic approach to reach the diagnosis? First of all, let me to start, actually, as I said, it's interactive session. So I will start with the most simple case. So what do you think here? This is normal, huh? But if you ask me about my interpretation, it will be all this. And the message here, please don't interpret the hemoglobin electrophoresis without integrating clinical data, CBC parameters, and iron profile. And at one day, I was called by MOH to investigate a case related to premarital screening program for a couple who was considered as compatible at the marriage approval. But unfortunately, they had beta thalassemia major baby. And when I investigated that issue, I discovered that the husband was having beta thalassemia trait, which was discovered at the time of the marriage approval, but the mother was a missed case of delta beta thalassemia, which normalized the hemoglobin A2. And unfortunately, they don't integrate the CB parameter, which was clearly thalassaemic picture. So delta beta thalassemia might give you the same picture of normal hemoglobin electrophoresis. And this is why you need to integrate everything. You know, I draw this picture myself just to highlight the importance of clinical CBC and iron study before interpretation of hemoglobin ectophoresis. Yes, hemoglobin ectophoresis is the mainstay of diagnosis of hemoglobin ectophoresis, but you have to include set of technology, and also you have to do clinical pathological correlation. Clinically, you have to look at for transfusion, you have to look at for family history, and you have to see if there is any sign of hemolysis. CBC parameters, you have to check if there is any thalassemia picture, because alpha thalassemia, combined alpha and beta thalassemia might normalize hemoglobin A2. And without integrating CBC parameters, you will not reach the diagnosis. Definitely, in some cases, you need to do molecular study, skill solubility test, and preference meet. And you are also familiar with all these cases, like the upper case here. It is a crystal of hemoglobin C. This is a beta thalassemia major, and this is beta thalassemia trait, and this is positive sickle solubility test. So the message here, please didn't interpret hemoglobin ectophoresis without integration of CBC parameters and clinical pathological correlation. Both capillary ectophoresis and HPLC are fast and reliable and automated, highly can be automated easily. But again, in some cases, you need to do them both. And in some hemoglobins, they cannot be detected because they co-migrate at the same rotation time or the same zone, because either they have the same charge, the same size, or they might be neutral species. They don't migrate and they stay at the origin. So now the first case actually is for 12 years old, a symptomatic female who's having actually low hemoglobin A2. So we have now three scenarios. The first scenario with low hemoglobin and low MCV, low MCH, and high RDW, and iron profile is low. So this is a straightforward case of iron deficiency anemia. But look at the second case in which you have low hemoglobin and very low MCV, MCH, so it does not correlate with the reduction of hemoglobin, and RDW is normal. So this is, again, straightforward case of thalassemia, most likely alpha thalassemia. But look at the second case, the third case, I mean. Everything is normal. Iron profile is normal, despite the hemoglobin A2 is low. So this is delta thalassemia. This is an example of delta thalassemia because of reduction of, yeah. Okay, so now the second case, hemoglobin A2 is 5, and we have clear thalassemic picture, so, and iron profile is normal. So this is a classical case of beta thalassemia trait. Now, again, if we ask to generate the genotype or to expect the genotype for this case, which is sickle cell trait. So this is the genotype of sickle cell trait. But now look at the hemoglobin S level for the second case now. Hemoglobin S is lower than expected for the trait, and we have clear thalassemic picture. So clearly that we are dealing with sickle alpha, which leads to reduction of hemoglobin S, by the way, and it gives us a clear thalassemic picture. Now, we have two case scenario. For the first case, hemoglobin A is 28, and hemoglobin S is 59, and hemoglobin A2 is 3, and hemoglobin F is 10%. So what are the two possibilities here? Yeah, first it might be sickle cell anemia post-transfusion. So, yeah, and if you see the hemoglobin, if you see the CBC parameters, clearly that we are having thalassemic picture, high RBC count, low hemoglobin, low MCV, low MCH. So what do you think here? So this is sickle beta plus there. in which we have a variable reduction of beta globin chain leading to a picture of sickle beta thal. And actually the clinical manifestation, that is according to the residual level of beta globin chain. Now, the second case, hemoglobin A is almost zero, and hemoglobin S is 66, and hemoglobin A2 is normal, and hemoglobin F is high. So we have two case scenarios here. And if you see, the first one is clearly thalassaemic, and the other is normal. So this is how to differentiate between sickle beta plus thal and sickle cell anemia. Please, if you see any patient with low MCV, low MCH, without any hemoglobin A, you have to send him for molecular to exclude or to include the possibility of sickle beta plus thal. Now, actually, this is one of my patients, and interestingly, he was from Al-Baha. And when we do a premarital screening program, when we study the premarital screening program data and we published in Journal of Epidemiology, we discovered that in the same village of this patient, there is a cluster of this abnormal variant. So if you see that we have here hemoglobin abnormal variant with 22, but we have low MCV, low MCH, we have clearly thalassaemic picture. So this is one of the exceptions in which we have a structural hemoglobinopathy, but we have thalassaemic structural hemoglobinopathy, which was hemoglobin E, and he was hemoglobin E trait. And actually, if you see the data that has been published by our team in Epidemiology, Journal of Epidemiology, there's a cluster in Al-Mukhwa with hemoglobin E. It's run in families, actually. And again, another example here, for 32 years, Indonesian female, she was having mild splenomegaly and sign of hemolysis, and she's having abnormal variant, and again, low MCV, low MCH. So this is the second example of structural thalassaemic hemoglobinopathy in which we have an abnormal variant and thalassaemic picture, which is hemoglobin report that result from fused delta beta because of misequal crossover of delta beta in chromosome 11. Now, actually, I remember when we revised the guidelines and policy procedure for premarital screening program in MOH, we have a long debate between scientific professionals and politicians, whether to include, politicians, I mean the administrative who care more about cost effectiveness, about affordability of the test, whether to include the molecular or not to include the molecular. Because once we include the molecular, we have to provide it for our patients. And we know that premarital center that distributed all over the kingdom, we have now more than 250 premarital center in Saudi Arabia. So if we put it in the policy and procedure, we have to provide it for our patients. We have a long debate, actually. And to convince them, I brought this example. If you see here, actually, we have the same scenario, same clinical scenario, and the same hemoglobin level. But so what is the difference here now? The diagnosis are both, they have alpha thalassemia, but those couples, they have it in trans. So they have a possibility of having alpha thalassemia trait. Whereas here, we have the same clinical manifestation, the same laboratory features, but the consequences are totally different. And we have now 25% possibility of having hydrops fetalis, which is the worst type of thalassemia ever. It is worse than beta thalassemia major, as you know, because it's incompatible with life, with major burden to the maternal health. So I managed to convince them, and this is why you could see this algorithm in the new guidelines. It created some problems, like at least we make it optional, and we increase the awareness about the importance of molecular for premarital screening program, especially if we have a possibility of beta thalassemia minor with normal hemoglobin A2, and we know that certain population, especially in Pakistan, in Punjab, they have beta thalassemia with with normal or mildly elevated hemoglobin A2, and it might be combination of alpha and beta thalassemia or delta beta thalassemia. So molecular testing is the right for any couples who want to be sure that he's not having any possibility of delta beta or, and currently there are some cases actually it's been taken to the court because it's been considered as normal, and we discover that we are dealing with delta beta thalassemia or we are dealing with alpha beta thalassemia, which is very common, by the way, especially in JZA. Now, let me to continue because, I know the time is not. This is a straightforward case. You could see that hemoglobin, the potential husband is having hemoglobin S, and the potential wife is having hemoglobin C. So clearly that they are not compatible because they have 25% possibility of having hemoglobin SC disease. And you could see how it appear in HBLC, in which we have two abnormal peaks and we don't have any hemoglobin A1. Back to our cases now, which we start with. Now, in order to address those cases, how to reach the diagnosis and especially in proficiency test, because actually they might have some case reports or sometimes they might simulate a difficult case. And this is why around 50% of their cases are rare or uncommon variant generated from a case report. So first of all, you have to correlate you have to do clinical and ethnic correlation. If you have an abnormal variant that you do not know what to call it, first of all, you have to do clinical and ethnic correlation. For ethnic correlation, look at this map. Actually, this is the classical clustering of hemoglobin C. And there is a hot spot in Burkina Faso in which 25% of the population is having hemoglobin C trait, and 5% is having hemoglobin C. And if you see the wider circle, it reach in Egypt 1%, in Algeria is 1 Egypt, and in Saudi Arabia we actually reported 700 cases, and we discovered that the prevalence is 0.04. However, it's very common in Medina and in Jeddah because of two ethnic groups, especially Hausawi and Fallata, in which it reached to 5% trait. And this is why sometimes we have to tailor our public intervention and premarital screening program for those ethnic groups. For clinical correlation, you have to ask yourself whether you are dealing with hemolysis, any sign of hemolysis, jaundice, splenomegaly, high LDH, high bilirubin. There are many examples like hemoglobin Hashirone, in which we have unstable hemoglobin, high affinity hemoglobin, in which we have polycythemia, and low affinity hemoglobin, in which we have cyanosis. So CBC correlation, I do not need to repeat because I see Dr. Bahrani catching the mic. So he want to say something. So CBC correlation, you are familiar with. Now, I think this is one of the most important steps that you need to understand. You have to ask yourself, once you do clinical and ethnic correlation and you do CBC correlation, whether you are dealing with alpha versus beta versus delta variant. If you see the first example here, we have normal hemoglobin A2, but we have splitting of hemoglobin normal hemoglobin A1, I mean, and there is no abnormal variant. And all what we have is splitting of hemoglobin A2. So this is indicating that we have delta variant. if you see, and actually, if you see the second example here, we have abnormal variant and we have splitting of hemoglobin A2. This is at the last of my slides. Thank you. Yeah, okay. Okay. So if you see here, this is splitting of hemoglobin A2, and we have abnormal variant here. Here we don't have abnormal variant. So clearly that we are dealing with alpha variant. So you could go to check your library to reach. Did they have? Go back. Okay. So, but what if you have an ECG like capillary electrophoresis or HBLs? If you have multiple peaks here, we have to check. Just I want to go back. I mean, yes, this is a hemoglobin S. This is the combined variants of alpha and beta because we have, this is the trait. We have normal hemoglobin A and we have hemoglobin S plus hemoglobin S and G, the hybrid hemoglobin, the hybrid variant of S and G, and we have also hemoglobin G trait, which also including the level of hemoglobin A2. So in general, if you see capillary electrophoresis or HBLC and ECG like, this is most likely combined variant, and you need to double check each provided hemoglobin to know whether they are alpha variant or delta variant or beta variant. I think with this molecular conformation, of course, you have to do it, and also you have to do you have to follow the standardized nomenclature. For example, hemoglobin D is not enough. Hemoglobin G is not enough because there are many, many Ds and many, many Gs. So you have to follow the WHO precise naming, and also you have to do continuous CME hours and case-based discussion. And with this, I conclude before Dr. Ahmed ordered me to conclude.
Thank you, Dr. Mansour. Thank you very
Thank
much.
you.
Thank you. Very interesting cases about hemoglobinopathies and the premarital screening program, which is very important in our community. Thank you, Mansour. Our third speaker is Dr. Rahaf Al-Tahan. Dr. Rahaf is a consultant hematopathologist at King Fahd Medical City. She completed her hematopathology residency program from King Saud University, and also she had clinical fellowship from McMaster University in Canada in coagulation and thrombosis.
But show me that.
Dr. Rahaf, you are welcome. You have 20 minutes about cases and coagulations.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everyone. Thank you, Dr. Ahmed, for your kind introduction. I would also like to thank the organizing committee for this beautiful educational event. Let me just get familiar with this. Okay, so my objectives for today is to share selected challenging cases in coagulation that highlight diagnostic difficulties and to illustrate how laboratory interferences can impact test interpretation, and to finally encourage a case-based approach linking laboratory results with a clinical context. So the first challenge is for a 42-year-old woman who is known to have chronic immune thrombocytopenia, and she's currently planned for an elective surgery. So she has had this diagnosis since she was a child, and she always complained of easy bruising and heavy menstrual bleeding. She had exacerbations of her condition during previous pregnancies. So previous interventions included some supportive measures, IVIG, and some corticosteroids that caused a modest improvement of her condition. So at this time point, her platelets are 123. And as we know that for an ITP patient, 123 is really perfect. It's the definition of complete remission. So she's doing well today. And her mean platelet volume is 12.3, so it's just a bit higher than normal. So the treating physician actually elected to do something that we don't usually do for the ITP patient. They sent for a platelet function assay. Simply, this is a screening tool. We test the primary hemostasis pathway. So for an ITP patient who is really uncontrolled or her condition is controlled, we don't expect a grossly abnormal a result for the PFA 100. So that was really unexpected and it got our attention. So briefly about immune thrombocytopenia, this is an autoimmune condition that is characterized by isolated thrombocytopenia with increased risk of mucocutaneous bleeding, and it's really a diagnosis of exclusion. The pathophysiology is not fully understood. However, we do know that there is a complex immune dysregulation with multiple components being dysregulated in the immune system. However, the highlight or the key are actually autoantibodies that coat the platelets and cause increased destruction by phagocytes, either in the spleen, liver, or both. So that leads to peripheral destruction, and we know that there is growing evidence that there is a central component that causes also defective megakaryopoiesis. So for an ITP patient, the disease severity generally correlates with a degree of thrombocytopenia. Actually, thrombocytopenia is the single most or the strongest predictor of bleeding in ITP patients. So if you're dealing with such a case, like an ITP with an unexplained significant platelet defect, think about re-challenging or reconsidering the diagnosis, and you might think of acquired Glanzmann or Bernard-Soulier syndrome. However, in clinical practice, like the majority of such patients will fall into this, where you really need to re-challenge or reconsider the diagnosis. However, the acquired Glanzmann and Bernard-Soulier are really way less frequently encountered. Briefly, these are two rare autoimmune conditions, and again, they are caused by antiplatelet antibodies. However, they do cause a functional inhibitory effect, and they cause a moderate to severe bleeding. That does not correlate with a platelet count. They can occur at the background of autoimmune conditions. They can complicate an ITP course. They can happen like idiopathic or in a background or of hematologic malignancies. So this is a case of acquired Glanzmann thrombasthenia. As you can see, this is the light transmission aggregometry. So the patient aggregation responses are highlighted in gray. There is really suppressed aggregation with ADP and collagen, minimal response with arachidonic acid, and a normal to near normal ristocetin response in the patient's platelets and the patient plasma. However, when we look at quantification of the, in case of Glanzmann thrombasthenia, the alpha-2b beta-3 is usually deficient. So in flow cytometry, we enumerate these surface glycoproteins. The platelet is actually the open blue histogram and compared to the normal control, which is the red histogram. So the patient has a normal expression of the antigen, but with a defective function. So going back to our patient, the thrombocytopenia, or at this point, it's a mild thrombocytopenia, was confirmed. And we did some additional testing that included a coagulation screening that were normal. And then we did von Willebrand testing. And as you can see, the antigen is just below the reference range. However, there is really reduced activity with a low activity to antigen ratio. Furthermore, we did light transmission aggregometry. So the aggregation responses to these agonists were within normal limits. However, the patient has an abnormal response where there should be no response to the low dose of ristocetin. So our patient was diagnosed with von Willebrand disease type 2B. And just to tell you how frequent in clinical practice, individuals with congenital bleeding disorders are mislabeled with ITP. As you can see in the right column, like they did this registry on 180 women with confirmed inherited thrombocytopenias, the proportion of patients who were mislabeled or treated for an ITP and even got splenectomy is quite significant. So briefly about von Willebrand disease, it was described by a Finnish physician, Erik von Willebrand, for over a century ago. It is the most common bleeding disorder. Patients usually present with excessive mucocutaneous bleeding, and in the severe form, they can present with musculoskeletal bleeding. So it is broadly divided into the quantitative type 1 and 2, where there is either partial or virtual absence of the antigen, or the defective qualitative type 2. And for our patient, type 2 is really a rare form of von Willebrand, accounting for less than 5% of the cases. It has an autosomal dominant and is caused by increased von Willebrand binding to platelet due to a gain-of-function mutation with resultant decrease in high molecular weight and platelets. So there is moderate to severe bleeding, and I would like to point out that thrombocytopenia is not necessarily present in every patient. So just a pathway or roadmap for diagnosis of von Willebrand. These are actually the screening testing that we do for von Willebrand. If you get a low antigen with a discordantly lower activity resulting in a low ratio, think about type 2 von Willebrand. And then you can move to testing the high molecular weight von Willebrand by either collagen binding, which we might be using at King Fahd, or the traditional multimer assays. If there is evidence of loss of high molecular weight, you can confirm that the patient either has 2A or 2B, and that can be confirmed by genetic testing or RIPA, like I showed you for our patient. And as per the ISTH, they just prefer the RIPA, the genetic testing over RIPA. Why genetic testing? Because it's in fact restricted to a small proportion, so we can do that in the testing. So that was my first challenge. Moving to the second challenge, there are actually two cases. On the left, or the first patient, is a 36-year-old male with recent venous thromboembolism, and the second one is a 41-year-old woman with recurrent VTE. So I'll take you straight to the lupus anticoagulant testing, and I'll discuss on this in the coming slides. So you can see that the DRBVT screen, mix, and confirm are all elevated, whereas the APTT, there is elevation in the screen mix, but not the confirm. While the other patient, the DRBVT screen was normal, so we did not do the confirm or mix. The APTT screen was also elevated, but did not meet lupus criteria. So accordingly, the first patient had a positive LA testing, while the other had a negative. But looking more into the clinical background of the patient, the first one was having a really high hemoglobin, and he was diagnosed with JAK2 positive polycythemia vera. And interestingly, he was started on a DOAC, a direct oral anticoagulant, rivaroxaban, before testing. The second patient is actually an case of SLE with previously confirmed antiphospholipid. She's on few immunomodulation with enoxaparin, and interestingly, she is currently in her third trimester of pregnancy. So about antiphospholipid syndrome, this is a thromboinflammatory syndrome driven by these pathological antiphospholipid antibodies. It is associated with thrombosis, pregnancy morbidity, and other autoimmune manifestations. As for the lupus anticoagulant, and this is what I showed you in the previous slides, this is what we do in the hematology lab. These are, in fact, really heterogeneous antibodies that are mainly of the IgG or IgM, and they are directed against negatively charged phospholipid binding proteins. The LA is one of three laboratory criteria needed for the diagnosis. The other two are the solid phase, or the anticardiolipin, and anti-beta-2 glycoprotein 1b. And it is the best established risk factor for antiphospholipid-related clinical manifestation. So the ISTH recommendation is actually to go over two different assays for the testing. The most commonly or widely used are the dilute Russell Viper venom test and the activated partial thromboplastin time. So what we should do, both tests should be implicated. We should start with a screening test that is known to be sensitive for lupus with low phospholipid content. And if the screening is prolonged, we move ahead in parallel with both the mix and confirm. The mix is actually normal counts of a normal proportion of the patient and the normal pool plasma mixed together. And the confirm is where we add the phospholipid content and the reagent just to neutralize the lupus antibodies. So I'll make it as simple as if the screen is prolonged and the mix shows no correction, the confirm shows phospholipid dependence, the test is positive and should be repeated in a minimum of 12 weeks to confirm persistence. However, we still do have, there is lack of uniformity across labs due to local testing protocols, result interpretation, and most importantly, interferences. So going back to our patient where he was on rivaroxaban, which is a direct oral anticoagulant, they really cause significant interference in lupus testing as they cause prolongation of these phospholipid-dependent coagulation testing. However, we do know that it's not infrequent that we do get requests for testing those patients, either for deciding on the duration of anticoagulation or the type of anticoagulant. So just this is like a summary of several studies that looked at the interferences of these DOACs on the lupus testing. As you can see, the most sensitively affected is the DRBVT screen. However, these were really taking at the peak level of the drug. So how do we handle these patients? Ideally, as per the ISTH, the patient should be off anticoagulant just to remove this possible interference. If we cannot do that, we can interrupt the patient or the anticoagulation and test after 48 hours. Some common practice is like they test the lupus just before the next coming dose. What we can also use is the use of adsorbents like DOAC stop or DOAC remove. I know that in some centers in Riyadh we're doing this. Caution is really on the possible false positive or negative results, especially in those with borderline inhibitor level. We can also apply the tape and snake venom test over the Icarian time. These are two venoms that activate factor 2. It's not still widely available. However, it was recently validated in a multi-center study to be used hopefully accurately for patients on DOACs for the testing of lupus anticoagulant. The other thing is that we can use the solid phase antibodies to depend on. However, we do know that missing LA can miss triple positive patients, and this has a really important clinical implication. So the second patient that was actually tested while in her third pregnancy, it's important to know that either false positive or false negative LA test can be detected during pregnancy. And this is because the antiphospholipid titers can either increase or decrease during the course of pregnancy. In this study, they collected about 150 pregnant women who are known to have lupus. And as you can see, around 25% of them were tested negative by the end of pregnancy. So that's really a substantial proportion. And that's probably due to the physiological increase in factor VIII and its effect on the APTT. So revisiting those patients, this patient had a false positive LA testing because he was tested during DOAC therapy, while the other one was falsely tested negative because he was testing during pregnancy. So it's imperative, just as Prof. Mansour highlighted, to always put the clinical picture together, think of the patient as a whole, put significant interferences like DOACs, like pregnancy, acute phase, before you give a final diagnosis. So my key messages for today is that congenital or acquired bleeding disorders can masquerade ITP, as I showed you, and mislabeling leads to inappropriate management. Anticoagulant therapy is a major source of interference in LA testing, and results must be interpreted with caution. Fluctuations in antiphospholipid profile during pregnancy are common, and they don't confirm nor exclude a diagnosis of antiphospholipid syndrome. Thank you very much.
Thank you, Dr. Araf, for the time management. Yeah, thank you very much. So now we have time for discussion. I will ask the speaker, Dr. Mansour, Dr. Ammar, and Dr. Araf to come to the stage. Any question from the audience? Question, comment? I have a question for you, Dr. Ammar, regarding granulocyte transfusion. Do you think it is of benefit for patient, and how many patients did you have?
Well, the number of cases we encounter are requiring granulocytes are few, more in pediatrics than adults. I don't know what, pediatrics consultant, they believe on this more than the adults, probably because of dosing and donor availability. So this is on average, we are getting one per quarter every year. One patient requiring multiple granulocyte transfusions. For the practice still going on, all of them are pediatrics. Is it effective or not? Dose is very important in the granulocytes, and availability of donor limit the success. We encounter, some successful cases, especially in invasive infections. But many of them, they have lung infections that complicate the picture too. For this limit also its success. I like it to be present, even though, until we develop very good experience, all of us, and we accept these requests as much as possible. But their response, of course, is not not favorable all the time. It is not favorable all the time for factors related to the patient himself, or factors related to the donor availability and dosing availability.
Thank you. Any question?
Thank you to all the speakers for these amazing talks. I have an issue I want to discuss with Dr. Mansour. Until recently, we started receiving cases from the premarital center in Sharqiya for second opinion in our institute. After you told us about the first lawsuit, we are very nervous now, and we should not be interpreting these hemoglobinopathies, because we are a cancer center. We usually don't just do electrophoresis, to monitor patients, but not for diagnostics. So is there a way or a pathway to redirect these consultations to you or to the premarital center in Riyadh?
I think it reached the right person. It reached you, Dr. Arim Al-Rabi. Anyway, I think the interpretation of premarital screening results can be very easy, but it can be very difficult, especially if we don't follow the systematic approach. If you don't follow the rules and regulations, you might miss some cases. All what you need to do is to integrate the capillary and HbA1c result with clinical manifestation, if there is any clinical manifestation that's been mentioned, and also you have to integrate the CBC. Again, it's your right to request for molecular test to confirm the result. And actually, if you see the Sahha platform, we add a space to highlight the importance of confirmation through molecular testing. You know, now we have like increased public awareness about the importance of results of premarital screening program. And if you see the trend of high risk marriages from 2004 to 2022, you will see dramatic decline. It started from 89 high-risk marriages who proceed despite, against the medical advice. Now they are only reaching 15%. Still, they are high. But, you know, there are some social issues. We cannot play with it. Anyway, I think if you integrate the whole picture and if you do stepwise approach, you will be safe for the couples and you will be safe for your institute. And actually, there is like a steering committee for premarital screening program. I am part of that steering committee. Any difficult cases will be directed to that steering committee.
That's great.
Yeah, thank you.
Can I add a point to Dr. Reem, Prof. Mansour? We're actually working on a tertiary center with Ministry of Health. So I hear you, Dr. Reem. We get up to 1,000 testing for premarital. Like, I'm going to go back from today's lecture. I'm going to request more molecular. Patients will be upset. But like what you showed is really significant. Like, we're verifying borderline ones. So my colleague, Dr. Fatma's here. We're releasing a lot. So probably we're going to refer more to molecular where there is like a doubt, especially we don't see the other partner in the premarital.
One last question to Dr. Araf. So if you, for the diagnosis of lupus anticoagulant, you mentioned the DRVVT and the PTT-based method. What if you add the hexagonal phase? Can you just do one of these and the hexagonal phase?
The hexagonal phospholipids are actually implicated and they are the ones used in the reagents. The thing is, some centers would omit either the mixing or confirm, then you will lose a significant proportion of false positive or negative when you only depend on 2 components instead of the 3.
Okay, thank you.
Thank you, Dr. Muhammad. We have a question.
Assalamu alaikum. Thank you so much. This was excellent, amazing talk. Regarding the same line of Dr. Alim or Prof. Mansour, who's going to pick up these cases? Is the counselor and refer to the molecular? Or, yeah, as you mentioned, sometimes it's difficult, sometimes they can pass it as normal, and maybe they go to the court.
Yeah, actually, we have 2 layers to detect those cases. First of all, it needs to be detected by a physician in the laboratory. And you know, now we have accreditation for all laboratory, and we need to have a hematopathologist or at least clinical pathologist who is trained and who has experience to interpret the hemoglobin electrophoresis for both, by the way, premarital and newborn screening, because you know now newborn screening is mandatory by wiqaya. Still, it's under the care of wiqaya, but soon it will be distributed to all hospitals. So this is the first layer. It has to be done by well-trained hematopathologist or clinical pathologist with experience in hemoglobin electrophoresis. This is the first layer. Second layer is the physician who do counselor, who issue the compatibility certificate. And he need to double check. And you know, sometimes say if she's having like delta or he's having delta beta thalassemia trait and he is normal, you could issue the certificate, but we put like in the space in need for consultation. Because again, it is the right for other partner to know about the other partner. So we have actually 2 layers. The third layer is the steering committee directed by Dr. Suha Suleimani and her team to detect those cases. But you know, actually, I do not need to give you like a feeling that you need to get rid of those cases. No. the main issue here actually is just to follow the protocol and to integrate everything together and to do layered, standardized approach to diagnose those cases.
It's covered by the insurance premarital now the next.
I think I need to go to my colleagues, the administrative and politicians who have always.
Next 26 القابضة, it will cover this one.
I don't have an idea actually.
Thank you.
Dr. Ayman?
Thank you, Dr. Mansour, Dr. Ammar, and Dr. Rehab. It's very nice discussions. I think this is the time to have Center of Excellence of Hematopathology, hemoglobinopathies and coagulation centers, which are facing a problem or lots of problem in Jizan, especially for hemoglobinopathies and also for coagulation. We not have a tertiary centers with full equipped and full instrument. This is, I think, the time to get good sensors, one sensors, and also make a good channels with the movement is happening now to change in the health system to take it by from Ministry of Health to the الشركة القابضة. I think you need to raise this issue to the people leading the service. Thank you.
Okay, thank you, Dr. Ayman. Actually, just to confirm, to emphasize what we have said, when we analyze the data of 2 million participants in premarital screening program for 8 years, Saudi Arabia, and we do like a population adjusted prevalence to link the prevalence to the population in each region, in the 13 administrative region of Saudi Arabia, we discovered that Jizan by far is the highest with alpha, beta, and structural hemoglobinopathy. Traditionally, we know that Eastern region has the highest, but we discovered that in Jizan, we have all the genetic haplotype, we have beta thalassemia, alpha thalassemia, and we have many cases of hemoglobin H and S disease. So actually, for sure, we need to do now. And I think now also MOH, with Dr. Hatoun Izzat now, she's doing, she's the director of and the leader of hematology in MOH, and she's doing like this. Now they are doing registry. So I think the first step is to collect the data and to present it for the one who's the decision makers. And I think also in Jizan, I think it is the best place for the center because you have many hematopathologists, many hematologists, and many cases.
Yeah, thank you very much. We'll conclude our session today. We'll have 10 minutes for a coffee break. I hope we'll be back at 9:40. Yeah, thank you, speakers.
I would like to thank the SSBMT Society for giving us a day for pathology. And I would like to thank the President, Dr. Ahmed Al-Askar, for providing us with the opportunity to present our cases today. Today, we have a different format for our conference. It's a case-based approach with a special emphasis on cytogenetic I would like to thank the SSBMT Society for giving us a day for pathology. And I would like to thank the President, Dr. Ahmed Al-Askar, for providing us with the opportunity to present our cases today. Today, we have a different format for our conference. It's a case-based approach with a special emphasis on
لا مثلا 7 المساء. ايش المشكلة؟ المفروض تطلعي بنتين تطلعي. انا اول كلود
ايه ما في مشكلة.
بعدين لو خلصتي 3 ورحتي وصلتي 4.
لا إذا خلصنا 3 إيه بس إحنا أوريدي متأخرين. لا أدري.
لا بسيط نسوي كده.
We will start please the second session. Thank you. So this second session.
This one. Yeah. Walking mic, how I can do it? How is the walking mic? I can't use it.
Okay, and yeah. In this second session, we'll be focusing on the myeloid neoplasms, part 1. Our first speaker is Dr. Arij Al-Magheri. Dr. Arij is a fellow of the Royal College of Physician and Surgeon of Canada. She is currently a head of Hematopathology Division and the Department of Pathology and Laboratory Medicine at King Abdulaziz Medical City, Riyadh. She completed a residency training in Hematopathology and Transfusion Medicine at the University of Alberta, Canada, followed by 2 years fellowship in flow cytometry at University of British Columbia. She is the author of many publications in peer-reviewed journals. She has an interest in advancing the knowledge of flow and molecular pathology.
Okay.
Welcome, Dr. Arij.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everybody. Thank you, the organizing committee, for the invite. Today, I'm going to present a few cases in myelodysplastic neoplasm. And I'm sure that all of us here, following the recent 2 schemes for MDS and myeloid neoplasm classification for low and high-risk MDS. So the first case is 33-year-old male, previously healthy, presented with extensive right lower limb DVT after a month and a half of COVID vaccine. He reported an intentional weight loss of 10 kg. He has no family history of hematologic disease or malignancy and no organomegaly. The CBC and differential was significant for anemia, thrombocytopenia, and 6% blast. And as you can see here, the blood smear showed a leukoerythroplastic blood picture. and the bone marrow aspirate was markedly hemodiluted, but it shows megaloblastic erythroid changes, also significant granulocytic dysplasia in the form of hypolobation as well as hypergoroid neutrophils, and 6% blast with no hour roads in the peripheral blood, and 2% blast in the bone marrow. The bone marrow biopsy was markedly hypercellular for the patient age at around 100%. And as you can see here, there are increase in megakaryocytes. And the megakaryocytes, interestingly, they show atypical bizarre morphology with bulbous-like as here or cloud-like nuclei. Tend to have loose and dense cluster and with abnormal topography. And these morphologic findings typically seen in primary myelofibrosis. Sorry. Back home. So there was no increase in blast as per immunohistochemistry CD34 and 117. And there was bone marrow fibrosis of grade 1 out of 3 by special stains. We did molecular tests for myelobronchial neoplasm, and all of them came back to be negative, as well as other etiologies for non-clonal cytopenia and dysplasia. So the final diagnosis was marked hypercellular bone marrow with megakaryocytic and granulocytic significant dysplasia, along with increased blast of 2% in the bone marrow and 6% in peripheral blood, with grade 1 out of 3 fibrosis was consistent with MDS with increased blast 1 as per WHO and excess blast as per ICC, with the comment that because of the young age of the patient, at presentation, inherited bone marrow failure and germline studies is recommended. So the FISH studies came back to show monosomy 5, trisomy 8, and deletion 13q14. Cytogenetic was very complex, showing more than 3 abnormalities. Myeloid gene panel was positive for TB53 heterozygous pathogenic mutation. Telomere length studies and chromosomal breakage were negative. He was started on AZA and supportive therapy, and he was listed as well for a bone marrow transplant, but unfortunately he didn't make it. So the learning points here, MDS morphology and clinical presentation sometimes can overlap with other myeloid neoplasm, such as MPN or MDS-MPN. And because of that, integration of cytogenetic advanced molecular studies in the diagnosis is very critical for accurate classification. And we used to have MDS at elderly, and we know that MDS is a disease of elderly age, but sometimes we see it in a young age group, and in these cases, inherited bone marrow failure and germline study should be tested. Second case, a 36-month-old male presented with a 2-month history of bruises, as well as anemia, thrombocytopenia, neutropenia, and 8% blast. So the bone marrow aspirate shows marked erythroid hyperplasia with erythroid lineage counting at 78%, of which proerythroblast reaching up to 20% of total bone marrow cellularity. And as you can see here, there is significant megaloblastic changes, megakaryocytic dysplasia, small bilobe, as well as blast counted at 5% in the bone marrow with our rods. So the differential diagnosis was childhood MDS with increased blast 1 or acute erythroid leukemia or AML myelodysplasia related. So the bone marrow biopsy was
markedly hypercellular, and showing marked profound erythroid hyperplasia with megaloblastic changes, significant megakaryocytic dysplasia, and distorted bone marrow architecture similar to what we see usually in MDS. So the blast was not increased by CD34. 117 show few clusters of early erythroid precursors. ECAD was weak to negative, and factor VIII highlight increase in megakaryocyte with some nuclear separate loop and dysplasia. B53 stain, which is typically seen or increased more than 7% in cases of MDS biallelic TB53 or acute erythroid leukemia, is not seen here. So the diagnosis was childhood MDS with increased blast evolving to acute leukemia. And FISH for AML MDS came back to be negative. The cytogenetic shows translocation 3-5, which can be seen in MDS or AML myelodysplasia related. FLT-ITD, interestingly, came back to be positive. Myeloid gene panel shows KRAS pathogenic mutation, and he was treated as AML arising from MDS, but he didn't achieve CR, so he was reinduced and then going through the intensification. And currently he's post second Hablo transplant. So MDS with profound erythroid hyperplasia is not uncommon, but we see it sometimes, and it is confusing with acute erythroid leukemia and AML myelodysplasia related, because all these three entities share the erythroid hyperplasia, significant dysplasia, as well as complex cytogenetic. And sometimes to differentiate between these entities is really difficult, but for acute erythroid leukemia, you need more than 80% erythroid lineage proliferation, of which more than 30% pro-erythroblast, and there's maturation arrest at pro-erythroblast stage. Also, it's highly associated with TB53 biallelic mutation. While AML myelodysplasia related, you require myeloid blast more than 20% to make up this diagnosis, which is not usually met for acute erythroid leukemia or MDS. So the third case, I'm not sure if I'm doing well with the timing, but the third case, which is really interesting, she's 39-year-old female with cytopenia. She has anemia, thrombocytopenia, and monocytopenia. And interestingly, she has strong positive family history of hematologic malignancy. She has two sisters with acute myeloid leukemia. So the peripheral blood shows really mild dysplastic changes in the form of pseudo-Bilger-Hewitt. Also, there are some round macro-ovalocytes. The bone marrow was hypocellular for her age at 30%, with reduced erythropoiesis and granulopoiesis. The factor VIII highlight some dysplastic megakaryocytes with monolobate and separate loops. Blast was not increased in the bone marrow, and there is no bone marrow fibrosis, so the diagnosis was descriptive. And with the comment that the patient young age and positive family history of malignancy is highly suggestive of myeloid neoplasm with germline predisposition, and clinical correlation with myeloid gene panel inherited bone marrow failure is recommended. So the FISH and cytogenetic came back to be unremarkable. Myeloid gene panel after 4 weeks came back to show GATA2 pathogenic or likely pathogenic mutation. And after 2 years, she had another bone marrow because of severe cytopenia. And this time, as you can see here, she has significant granulocytic dysplasia in the form of hypogranularity, pseudo-Bilger-Hewitt. She has marked macro-ovalocytosis and macrocytosis. She has a significant megakaryocytic dysplasia in the form of macro-megakaryocyte and separate loops, bilgeroid neutrophil, and significant erythroid dysplasia. This time, the bone marrow is still hypocellular at around 30 or 40%, but it's more than the last bone marrow. So because of these findings, we tended to give it a classification of hypocellular MDS as per WHO 5th edition, and MDS with multilinear dysplasia as per ICC classification with the diagnostic qualifier as recommended by the two classification, MDS with germline GETA2 mutation. The FISH and cytogenetic came back to show monosomy 7 and trisomy 1. And she had allogeneic hematopoietic stem cell transplant from matched and related donor. She's currently well and almost 2 years from her transplant. So just few words on GETA2 germline heterozygous mutation. We know that GETA2 is a transcription factor that has a pivotal role in hematopoiesis, lineage determination, and hematopoietic stem cell self-renewal. GETA2 haploinsufficiency is an autosomal dominant inherited bone marrow failure with immunodeficiency and predisposing to AML or MDS. It is a multisystemic disease, and the patient can present with multiple organ affection, such as lymphedema, lung involvement, immune deficiency, as we said, and sometimes as a syndrome-like features. Myeloneoplasm occur in almost 2/3 or more, even in these patients with the average age of 12 to 35 years in one of these studies. And usually it's associated with monosomy 7, trisomy 8, trisomy 1q, and derivative 1,7. The most important here that bone marrow at the baseline for these patients usually show hypocellularity and megakaryocytic dysbiosis and should not be further overdiagnosed as MDS unless the patient has two of the following criteria, like acquiring pathogenic genetic alteration, or having new cytopenia or progressive cytopenia with increased bone marrow cellularity, or multilinear dysplasia, or increase in the blast. Are we good? Okay, so maybe this one and stop. So the fourth case, 68-year-old male with pancytopenia with no definite family history of hematologic neoplasm or organomegaly. The CBC was significant for pancytopenia, macrocytosis, and 3% blast. So the CBC showed, the bone marrow aspirate showed significant erythroid dysplasia in the form of multinuclearity, asynchrony, or megaloblastic changes, micromegakaryocytes, also blast with no hour rods, bilgeroid neutrophils. So the bone marrow biopsy was showing variable cellularity from 30 to 50%, and there is a significant or overt bone marrow fibrosis of grade 2 out of 3 as per the reticulin and trichrome. There was increase in bone marrow blast reaching 10% and 3% in the peripheral blood. So the final diagnosis with myelodysplastic neoplasm with myelofibrosis. The cytogenetic and FISH came back to be positive for deletion 5q, deletion 7q, deletion 17p13. JAK2 mutation was negative. Myeloid gene panel was positive for DNMT3A and RANKS1 mutation. He had allogeneic hematopoietic stem cell transplant with non-myeloablative regimen, but unfortunately he had early AML transplant and he was reinduced with azavin, but he didn't make it. Maybe the last case, 70-year-old male with comorbidity cytopenia, no significant medication history, no organomegaly. The CBC was significant for macrocytosis, which is really marked here, and anemia, thrombocytopenia. The bone marrow aspirate showed significant erythroid dysplasia in the form of bilobed small megs, separate loops. There was also right-shifted erythroid proliferation with marked megaloblastoid changes here. Also, there is some nuclear budding and multinuclearity. There are some segmented neutrophils and some hypolobated ones. Blast was not increased. The bone marrow cellularity was markedly increased for the patient age. And there is, as you can see here, right-shifted erythroid proliferation with some megaloblastic changes, also some megakaryocytes showing separate loops and dysplasia. So based on the morphologic findings, we said these are suggestive of MDS with multilineage dysplasia. This case was seen before the current classification scheme, with a comment that other etiologies for non-clonal cytopenia and dysplasia has to be excluded. Clinical correlation with the cytogenetic and molecular. FISH and cytogenetic came back to be negative. Vitamin B12 was borderline normal, folate was okay, copper and zinc was within or were within normal limits. And look at that, the MMA was markedly high, more than 2,000. And looking back at extracted data for serial MCV and hemoglobin from the patient chart, patients has recovered or increased or normalized, hemoglobin and MCV after 3 weeks of vitamin B12 injection. And this is really interesting. Upon further investigation, we find out that the patient has a history of chronic gastritis. Final diagnosis was megaloblastic anemia. And this is very important because exclusion of non-clonal cytopenia and dysplasia is general precaution statement in the WHO before rendering MDS classification. And this is because of that overlap, as bone marrow morphology in megaloblastic anemia may mimic myeloneoplasm, ranging from MDS to acute erythroid leukemia in some cases. And megaloblastic anemia can cause even ring sideroblast, and this has been reported in some anecdotal case reports. Giant bands and giant metamyelocyte is very characteristic for megaloblastic anemia and should be looked for in case having severe megaloblastic changes and more segmented or hypersegmented neutrophils. And always you have to double check MMA and homocysteine. We're fine. 2 minutes, maybe this and stop. So 82 years old female with comorbidities presented with anemia and no organomegaly. The CBC showed anemia, normocytic anemia. And as you can see here, the blood smear showing really normal erythroid or nucleated red normal red cells morphology, mild anisobicytosis. There is subtle granulocytic dysplasia, less than 10%, of course. And interestingly, you can see the small micro megakaryocyte with the size of or even less than myelocytes. And the bone marrow biopsy shows hypercellularity for the patient age with predominance of these micro megakaryocyte or small hypolobated megs. And the FISH came to show deletion 5q as well as cytogenetic. The myeloid gene panel shows RANKS1 and TET2. So the final diagnosis was MDS with isolated blast and with isolated 5q deletion, or MDS with deletion 5q as per ICCS classification. So in conclusion, the morphology and molecular cytogenetics are still the cornerstone of MDS diagnosis. Exclusion of non-clonal cytopenia or dysplasia is essential before rendering the MDS diagnosis. Genomic profiling significantly improved the diagnostic approach to MDS, risk stratification and management. It is crucial to consider germline inherited bone marrow failure in the differential diagnosis, especially in the young age of the patients, and positive family history, as this will guide the transplant decision. Baseline dysbiosis is common in patients with germline predisposition and should not be over-diagnosed as MDS. Thank you.
Thank you, Doctora Arish, for sticking to the time. And I'd like to introduce the second speaker, and we will have questions and discussion at the end of the session. It gives me great pleasure to introduce Doctora Nahla Al-Ghasham. She is a consultant hematopathologist in King Abdulaziz Medical City, National Guard, Riyadh. She is the program director of Hematopathology residency training program, and she is heavily involved in many hematological activities and education. Dr. Al-Ghasham, she has a diagnostic experience covering a wide range of benign and malignant hematological disorders with particular interest in myeloid neoplasm and bone marrow pathology, plus flow cytometry. She is heavily interested in challenging and unusual cases that require extensive integrated multidisciplinary morphologic, immunophenotypic, and molecular studies. We are privileged to have you, Doctora. Please start. Thank you.
Thank you. Thank you, Dr. Ammar, and thank you for the organizing committee and scientific committee for the kind invitations. It's a pleasure to me always to join the SSBMT, and I would like to thank you for their effort and also thank you for the supporting team. I will try to stick to the time, so I'll present only 3 cases of MBN that is recently been faced in our center in the National Guard, Riyadh. And we will see how sometimes the bone marrow finding is not aligned with the molecular or clinical presentation. The first case is for an 80 years old male patient. He is a non-MPN. He is a non-polycythemia vera, and then he is transformed to have a post-polycythemia vera myelofibrosis. The patient is recently presented with a progressive leukocytosis and high LDH concerning for possible transformations. So as I told you that he's a JAK positive, he'd been diagnosed as a polycythemia vera and then post-polycythemia vera myelofibrosis, and evaluation with a previous karyotype in 2011, 15, and 18, karyotype was normal. So this patient, in these situations, we need to rule out that there is no leukocytic transformation or there is no reactive changes that lead to increase the white blood cells. And also we need to rule out that there is no clonal evolution in this case. The complete blood count, as you can see here, we have a very high white blood cell of 89 with mainly a left shift, band forms, myelocytes, and also we have a basophils of 4%. The platelet is within normal, the hemoglobin is low with normocytic normochromic anemia. I would like to apologize that due to a technical issue, I don't have the picture for peripheral blood and aspirate, but I have the golden money. I brought the trypan biopsy picture, which is more than enough for diagnosis of cases of MBN. So for this patient, peripherally, as I told you that we have the left shift, we have a nucleated RBC, so we have a leukoerythroblastic blood picture in the peripheral blood. Also, we have the teardrop, which is a characteristic for bone marrow fibrosis in cases of myelofibrosis. Platelet is adequate. The aspirate is diluted, non-particulated, so it's not adding any information. The trypan biopsy, so let's remember that he is an 80 years old patient. So for an 80 years old, this is a very hypercellular, almost a 95 or 90% cellularity. And you can see here that there is like loss of heterogeneity of the bone marrow. The area of hematopoiesis is mostly contained granulocytic precursors and with differentiations up to segmented neutrophils. We have some megakaryocytes, so still preserved, but the erythropoiesis is also reduced. This is factor 8 staining, the immunohistochemical stain. You can see and appreciate that the megakaryocyte is reduced. These are only blood vessels and the sinuses staining, but the true staining for megakaryocytes, we have this one, we have this one, and we have this one, which is low for the percentage or for the quantity of the hematopoiesis in the bone marrow. As we know that the patient is already diagnosed as post-polycythemia vera myelofibrosis, so we expected that the patient have a high increase in the fibrosis. So this is the reticulin stain. You can see here that we have increased reticulin fiber with intersection, with tertius and thickening of the bundle. And also collagen fibrosis, you can appreciate the blue staining. So this is a sinus, which is, we consider it as an internal control for the collagen, but also away from the sinuses and the blood vessels, we have a very good staining for the collagen fibers. So we consider the fibrosis is variable between 2 and 3 myelofibrosis. For further investigation with cytogenetic and molecular, and as I told you that previously the karyotype was normal, he found to have a complex karyotype at this time. So we have a 15 cells with Philadelphia chromosome, and we have 3 cells have other variant of translocations, and only 1 normal cells. This result is confirmed by FISH analysis and also by molecular study for BCR ABL mutations. Further investigation with NGS, and this is the result of NGS, you can see that we have a JAK mutations, and we have also a TET2 mutations also for the patient. But before that, we never did an NGS for him. So this is the first time we have the result for NGS. So the primary consideration for this patient, the diagnosis is a chronic myeloid leukemia on a background of JAK2 positive polycythemia vera or post-polycythemia vera myelofibrosis. This is because of a positive PCR-ABL and the leukocytosis and the hypercellularity and the basophilia and the cytogenetic and molecular abnormality. Of course, the patient is not a case of blast transformation or reactive leukocytosis, since that there is no increase in blast and the presence of molecular BCR-ABL superimposed any abnormality on this patient. So it's been reported that some patients will have a combined BCR-ABL and JAK mutations, either at the beginning of diagnosis, at the first presentation, or later on of the disease. And there is like more than 40-50 cases reported in the literatures, and could be therapeutic, could be related genetic or without any prediction. Second case, a 59 years old male with JAK positive mutation and splenomegaly. The thing is that you will find that all my patients will present to us with a previous investigation for mutation-related MBN. This is based on the agreement between us and the clinical side that if you are suspecting a case of MBN before doing a bone marrow, before doing an invasive procedures, let's do the simple peripheral blood testing for JAK, calreticulin, and MBL. So most of our patients, which is very excellent collaboration between us and the clinical side, to have the mutation analysis before even doing the invasive bone marrow procedure. So this patient is almost 60 years old, positive JAK, splenomegaly, but also he have an end-stage renal disease and on hemodialysis. So the bone marrow is done for diagnosis of MBN. The CBC parameter, we have a very mild leukocytosis, mainly of neutrophilia, and we have anemia, normocytic anemia, and the platelet is within normal. So it's not that impressive, the CBC for the patient. It's not adding or can help in the diagnosis or classification of the patient MBN. Peripherally, white blood cells shows a reactive changes with toxic neutrophils, no significant left shift, no blast, no dysplastic changes, adequate number of platelet, white blood cells, there is no teardrops. The aspirate shows no increase in blasts, and the MA ratio is slightly or increased 6.4. There is a mild increase in megakaryocytes, mild increase in granulocytes, and reduced erythroid with a 12% only. Yes, 12%. The iron stain is also normal. This is the trypan biopsy. The trypan biopsy was very nice. You can see here that the distribution of hematopoiesis and architectures is a bit affected with uneven distribution of fat cells and hematopoietic area. This is iron stain. Sorry, this is a reticular stain, but I presented first to show you the distribution. The cellularity is high for a 60 years old, which we expect to have 40% cellularity bone marrow trypan biopsy plus minus 10%. This is increased. We give it like an average of 70% cellularity. We have some reactive changes in the bone marrow. We have, as you can see here, lymphoid aggregates, which confirmed to be a reactive lymphoid aggregates by immunohistochemistry, CD20 and CD3. We have a mild increase in the megakaryocytes with mild atypia. Granulopoiesis is active. Erythropoiesis is active. Again, this is not an impressive bone marrow finding for diagnosis of any subtypes of MBN. This is another area which is hypocellular for, as I told you, that we have like a variation in the cellularity. So this is the hypocellular area, but you can see here the megakaryocyte is here and there. Some loose aggregate megakaryocytes. I'll show you by immunohistochemistry. Reticular stain, it was very difficult. Knowing that the patient is end-stage renal disease on hemodialysis, we repeated the reticular stain multiple times to get a good result. And we think that due to metabolic abnormality in those patients, this will affect the quality of the staining of immunohistochemistry and for the special stain. So we consider it like myelofibrosis or increased grade 1, not more than that, of reticulin fiber. This is the factor 8 for staining the megakaryocytes. You can see here the megakaryocyte is mildly increased with some area shows like a loose cluster. This is the two lymphoid aggregate that I told you, which is reactive. And again, I told you that there is in the peripheral blood, we have the toxic neutrophils. We have some also prominent plasma cells and eosinophils in the, so for sure we have a reactive changes in the bone marrow. This is the megakaryocytes again, and a mild atypia is appreciated. So hypercellular bone marrow, mild increased megakaryocytes, active erythropoiesis, granulopoiesis, prominent eosinophil, reactive lymphoid aggregates, no increase in blasts, no significant increase of myelofibrosis or reticulum fibrosis. So again, we are still not convinced about any of the subclassifications of MBN, although that the patient clinically have a splenomegaly and he is JAK positive. So as I told you that the JAK positive, the NGS study for the patient revealed a two type of JAK mutations with a high FAV percentage. One of them, which is the classic V617F, is a 55.2. The other one is 77.9%. Again, we have a mutation, TET2 mutations with a low FAV. So what type of MBN this patient? For sure, he have an MBN. He have JAK, he have splenomegaly, but the bone marrow morphology is not aligned with any of the three major type of MBN. Could be a masked polycythemia vera because of JAK, splenomegaly, a hypercellular bone marrow, increased megakaryocyte. But the patient is anemic with a normal platelet. So he's not, and even we go through his trend, previous trend of hemoglobin, he never been documented to have high hemoglobin. For sure, it's not an essential thrombocythemia. We have a normal platelet. And also, it's not a myelofibrosis. We have only grade 1 myelofibrosis. So, patient have an end-stage renal disease with hemodialysis. Of course, he will have a good reason to have anemia and also to have abnormal laboratory marker. And this may affect the diagnosis for MBN. So the best fit for this patient is the MBN NOS. This is the recent WHO 2022 criteria for diagnosis of MBN. The patient should have a presence feature of anyone and of the following three. And for our patient, we have the splenomegaly and mild leukocytosis of 15. We don't have also hypercellular bone marrow, but we don't have megakaryocytic hyperplasia that significant. He's not meeting any criteria for MBN or MDS or MBN MDS, and we have the JAK2 mutation, and we don't have a previous documentation of any therapeutic cytotoxicity or of course, we got a very nice biopsy. We can't blame the biopsy that this is not good. So the biopsy was good. The sample was excellent. We did extensive cytogenetic and molecular study. So we are satisfied with the material that we received. So the best diagnosis for this patient is MPN-NOS. The third case and last case for me today is a 16-year-old male. It's almost a pediatric, suspected to have an MBN because of routine screening of the CBC detected a high hemoglobin, red cells, and borderline high hematocrit, and also a borderline low MCV, adequate platelets, normal, and normal white blood cells. And further investigation for MPN-related mutation, the patient came positive for JAK2. So, erythrocytosis, more than 160 for male patient as per criteria. JAK2 is positive. Is this enough for a diagnosis of MBN as per WHO and ICC 2022? Yes, this is enough, even if we didn't go through the bone marrow. But as we have the bone marrow finding I'll present to you what we have. Peripherally are remarkable. The peripheral blood morphology is nice, no abnormality, no erythrocytosis, no left shift, no reactive changes. The bone marrow aspirate is particulated and hypocellular. The erythropoiesis, granulopoiesis, megakaryocytes active, no increase in blast, no abnormal cells, and also we have some reactive plasma cell, eosinophil and basophil. This is the trifine biopsy. 16 years old. This is a hypocellular for the patient's age. We give it like a 40-50% cellularity. It's not showing any hypercellular or increased megakaryocytes, no clustering, no atebia. Erythropoiesis, granulopoiesis nicely distributed. Also, we did reticulin stain, no increase in myelofibrosis. So hypocellular for the patient's age. Are remarkable. No fibrosis, normal architectures. JAK positive, as I told you before. The erythropoietin is normal, which supports a primary bone marrow cause for erythrocytosis. And NGS is ordered but still pending. And this is a recent case that we have last month. So for any suggestions and discussion, it will be welcomed. So could this be an early masked polycythemia vera or hypocellular polycythemia vera? Since the patient have a hypocellular bone marrow, normal megakaryocytes, he's young, this is against the MBN. It's JAK positive erythrocytosis and normal erythropoietin, which is you have a two major criteria and supportive criteria. If we didn't do the bone marrow biopsy, this patient can easily diagnosed as a case of MBN and treated as a case of MBN. Could this be a secondary? Against that is the normal erythropoietin. Usually the secondary erythrocytosis will have a high erythropoietin. Of course, JAK2 will rule out presence of any secondary. Could this be due to an overlap with other condition? This patient is an MPN since he have a high hemoglobin, JAK positive, and low to normal erythropoietin. And maybe he have something else that causing the bone marrow hypocellularity. And this need more investigations and clinical correlation. So for this stage, and since the NGS is not yet released in the system, this bone marrow is a hypocellular for now with active trinary hematopoiesis, but we acknowledge the positive JAK2, we acknowledge the erythropoietin and increase megakaryocytes, normal erythropoietin, and we repeated the JAK2 mutation testing. This could be false positive JAK2 mutations. And also we ordered the NGS and we suggest a follow-up with a serial CBC and maybe repeat of the bone marrow if the JAK2 it came positive again. So just to mention the false positive JAK mutation result, it's uncommon, but it's possible. Okay, it could be due to a technical artifact, due to a cross-contaminations or low-level sequence noise, or allele drop-in or polymerase error in high sensitivity assay. So since that we are always increasing the sensitivity of our tests, we will catch some false positive cases. It could be to sample mix-up or mislabel or poor quality of DNA or degraded sample. So any weak positive or low FAV JAK result should always be repeated to confirm the true positivity. The thing is that with our tests, it's qualitative, it's not quantitative. So it's either positive, negative. We don't know about the
I'm sorry to interrupt, but the time.
Yeah,
Time
I'm
is up.
finishing.
Okay.
So we need to repeat if there is a low FAV percentage. There is some documented cases of JAK positive in a small in a young age, less than 50, and with a variable course of disease. Long term shows that about 10 to 15% will progress to polycythemia vera or myelofibrosis, and for these patients, we need, of course, again to collaborate the clinical, molecular, cytogenetic, and the pathology finding. This is the end. Thank you very much.
One important housekeeping issue. Kindly at the back, we hear a lot of noise coming to the front. It really affected hearing and listening to the presentation. Kindly keep conversations to the outside if you're interested to talk with your colleagues. Otherwise, we would like to continue and listening very well to the presentation for the sake of those who really wants to listen. Thank you.
Thank you, Dr. Nahla, for this really nice presentation. Dr. Nahla, we expect feedback on the group as soon as the NGS is out. So it is my pleasure to announce our next speaker, Professor Hiba Baslan, who is my colleague and one of my dearest friends, is a consultant hematopathologist at King Fahd Specialist Hospital, where she served as the head of hematology and head of flow cytometry until recently in 2022. She is also a professor at the National Cancer Institute in Cairo University. She has an authority in oncology diagnostics and advanced flow cytometry. She has over 30 peer-reviewed publications, a frequent speaker at conferences. She serves at advisory boards for MPN and BPTCN and has extensive experience in the quality systems such as CAP and CIBAHI.
Okay.
Go ahead, Dr.
So my dear. Okay, I will start with sending my deep appreciation to our chairman, Dr. Ahmed Al-Askar, for giving us this yearly opportunity to having a hematopathology overview. And thanking the organizing committee, my friend and my colleague, Dr. Rima Rabih, and my longtime colleague, Dr. Ammar Al-Saghir. And thanks all the audience for taking from their weekend to attend our day, our hematopathology review day. Actually, the two ladies has covered the MDS and MPN perfectly. And my session will be the overlap between the MDS and MPN. When we talk about MDS and MPN neoplasm, we are talking about hematological malignancies, a group of hematological malignancies that bridge the cytopenic, dysplastic, and the proliferative biology. It also represents the aging of hematopoiesis and the genetic injury intersect. As we all age, the hematopoietic stem cell experience the DNA damage, telomere shortening, and epigenetic drift. All the environmental factors that we're passing through, especially chronic inflammation, autoimmune disease, oxidative stress, and even immune pressure can tend to pressure the somatic mutation of the key regulators of the splicing, the epigenetic, and the signaling pathway. All this starts at the beginning as age-related benign clonal hematopoiesis, but with the accumulation of this insult and this genetic injury, the MDS-MPN syndrome exists. So our bone marrow is a cumulative record for all the genetic insult through through our life. So we will say that proper morphology and molecular testing is the key for diagnosis of this group of diseases. According to the WHO 2022, the CMML, the group is confined to chronic myelomonocytic leukemia, the MDS, MPN with neutrophilia, MDS with SF3B1 and thrombocytosis, and not otherwise specified. When we talk about myelodysplastic, we will talking about the cytopenia, the anemia with the cutoff value presented by the WHO, the morphological dysplasia, and we are talking also about the myeloproliferation expressed by the increased blast, the leukocytosis, the monocytosis and thrombocytosis, and definitely splenomegaly, together with the molecular abnormality in both. Actually, what we are looking for, if we search what we are looking for, we can diagnose easily. We are searching for this megakaryopoiesis, the dysplastic feature, which can be MDS-like megakaryocyte, micro megakaryocyte, hypolobated megakaryocyte, multinucleated together with a large and giant platelet. We are talking about ET-like megakaryocyte, which is large, hyperlobated, bulbous, and also loose clustering, or MF-like megakaryocyte, atypic, and is hyperlobated or hyperlobated with megakaryocytic nuclei, hyperchromatic, and bulbous cloud-like. We are talking about this granulopoiesis represented by hypergranularity, hyposegmentation, and hypersegmentation, the presence of blast or abnormal localization of immature precursor. We are talking of this erythropoiesis represented by nuclear budding, ring sideroblast, megaloblastic changes, cytoplasmic and internuclear bridging, and also vacuolization in the cytoplasm and poor hemoglobinization. The most challenging in this group is the enumeration of between or the maturation pattern of the monoblast through promonocyte and the monocyte. In cases of chronic myelomonocytic leukemia, monocyte by itself is clonal as well. There is a lot of immature monocyte which is labeled as promonocyte. So we have to be sure how to differentiate between monoblast, promonocyte, and monocyte. Here is a short algorithm how to reach the diagnosis. At first, we have to find this evidence of MDS and MPN-like feature, excluding the CML by quantitative PCR, exclude the MPN with xenophilia, proper counting of the blast, then we will check. If we have monocytosis and definitely dysplasia, then we will go with chronic myelomonocytic leukemia until the molecular give us a clue about what we are looking for. If we have a thrombocytosis and anemia with megakaryocytic atypia, then ring sideroblast by Ernstein, we are talking about MDS, MPN with ring sideroblast. Again, we will wait until the molecular testing. Then neutrophilia with marked dysplasia and left shift will give us to MDS, MPN with neutrophilia. If we don't go into, we find the MDS, MPN feature, but is not matching any of this, then we will classify it as MPN, MDS, not otherwise specified. Our first case was a case 6 years old. Definitely this group of diseases, we call the group of the older people or the age, but actually nowadays we will see a lot in their 40s and 50s having chronic myelomonocytic leukemia. This patient represented 60 years, presented to our hospital as essential thrombocytosis and symptomatic anemia as fatigue, palpitation, infection, weight loss, bone pain, and he has mild splenomegaly. His preferred blood represented marked thrombocytosis, but the count showed blast and promonocyte almost to 4%. His absolute monocyte count, because of the presence of a lot of immature monocyte, is 34%. Absolute monocytosis of 1.2. So he has neutropenia, marked monocytosis, and thrombocytosis. Okay. Then we checked the We checked the bone marrow aspirate, unfortunately a bit up-articulated, but as we can see here, a lot of micromegakaryocyte, multinucleated megakaryocyte, multinucleated, hypolobated, and hypolobated micromegakaryocyte. This megakaryopoiesis, erythroid or megaloblastic erythroid, cytoplasmic bridging. Again, the count was lymphocyte, monocyte, immature monocyte, monoblast, and promonocyte. So again, it shifts us to a case of chronic myelomonocytic leukemia. Check the bone marrow biopsy, giving the same picture. This is a hypercellular bone marrow for the patient age. There is a lot of megakaryocyte with loose and not tight collection, but I would say loose collection with the same picture. I like to do CD61. The CD61 confirmed all of them are a huge number of megakaryocyte, and all of them are micromegakaryocyte hypolobated. The reticular stain was almost 0 to 1, and the CD34 was not increased. So, first of all, we do as we have told by Dr. But first, that the nutritional profile in these cases is really important. We have to confirm that the nutrient profile is good. The vitamin B12, folic acid, and iron panel was normalized. We did in-house cytogenetics testing show normal karyotyping. Fish for 5q deletion, which is the first thing to think about because of the dysplasia and the thrombocytosis, and it was negative, and also for platelet-derived growth factor alpha and beta. In-house molecular testing for PCR was PCR-able was negative, and three molecular consecutive for MPN was also negative. We sent for panel of myeloid neoplasm. The NGS panel for the myeloid neoplasm, actually practice that this is a so informative technique. For this case, we actually fulfill the diagnosis. We have monocytosis, we have dysplasia. Until now, we don't have clonal, but we have blast less than 20 and even less than, put it in CMML1. There is myeloproliferative condition represented by the thrombocytosis. So our patient actually fulfilled the criteria, but we were conservative to add a case of chronic myelomonocytic leukemia type 1 versus MPN with monocytosis. Actually, we don't have a document that the patient have a myeloproliferative, and the 3 molecular testing was negative, yet we were conservative to put MPN with monocytosis and to wait for the NGS. The NGS came with this result: TAT2 mutation, SRSF2, ASXL1, and GATA2. The 3 of them is consistent to be the profile of CMML, and we added this an addendum that the patient is a case of chronic myelomonocytic leukemia, and actually the presence of ASXL1 mutation could help us to understand why the platelets was marked thrombocytosis associated with the primary presentation. Second case was a female, 66 years, presented again to our hospital with thrombocytosis. She developed progressive fatigue and no palpable lymph node, no hepatosplenomegaly. What we can see is thrombocytosis with a large giant, a large platelet with even hypogranular form. Her panel, nutritional panel, was normal. Her vitamin B12, folic acid, and iron. Then here's the bone marrow aspirate. The bone marrow aspirate again showed dysplastic megakaryocyte. Here's the dysplastic megakaryocyte. Dysplasia in the granulopoiesis evident by chromatin, clumped chromatin, defective granulation, hyposegmentation, and also dysplastic erythroid precursor. Here, defective hemoglobinization, and what we can see here, cytoplasmic bridging and basophilic stippling. So Again, the patients show hypercellular bone marrow with multi-lineage dysplasia evident in 3 lineage. Again, this is the bone marrow biopsy, which show hypercellular and atypical megakaryocytic hyperplasia with ET-like or MF-like megakaryocyte. At that time, we found thrombocytosis for this case, so iron stain was done. By the iron stain, we found that there's more than 15% ring sideroblasts, which is accumulation of iron granules occupying more than 1/3 of the nucleus. And here is the factor 8 highlighting the dysplastic megakaryocyte. So the retic stain was negative. The in-house testing for the cytogenetic was negative. The PCR negative. We found JAK2 positive, and we sent for NGS. Differential diagnosis has to be excluded as well in these cases. MDS with low blast with SFB3, because this is we expected from the NGS to find. So this is excluded by the thrombocytosis, and MDS with low blast and isolated 5q deletion and excluded by negative cytogenetic and the megakaryocyte. Doctor earlier showed us how the 5q megakaryocyte is hypolobated and small form, which is totally different than this one, which have large megakaryocyte representing the MPN-like megakaryocyte between ET and myelofibrotic megakaryocyte. So this is difference either by morphology or the negative cytogenetic morphology by its own can say that this megakaryocyte, even with the dysplasia, it is a different form. Our patient, we added that this patient is MPN MDS with more than 15% ring sideroblasts and thrombocytosis waiting for the NGS. The NGS came with SF3B1 mutation, ASXL1, and CPL. Unfortunately, this category is the best prognosis, but finding the ASXL1 overriding the benefit of the SF3, so the combined profile suggests overall unfavorable prognosis. In these cases, actually, we can exclude the molecular. If we have sustained thrombocytosis for 3 months, then we substitute the molecular finding. And if we have more than 15% ring sideroblasts, we can exclude the SF3B1 mutation. So this category, we can exclude molecular, and when there is molecular, the JAK2 has to be positive rather than the chronic myelomonocytic leukemia or the neutrophilia. It is better not to have JAK2 mutation of the MPN. Our next case is 70 years old patient presented with pancytopenia as query NGS. We received the patient with leukocytosis, mild leukocytosis, anemia, and thrombocytopenia moderate form. She has neutrophil of 60 band. There is left shift to the level of blast. So we find marked neutrophilia and left shift to the blast stage. It's the dysplasia. The dysplasia noted by defective granulation, in the peripheral blood, erythroid in the peripheral blood. So here is the bone marrow. Typically, it is marked hypercellular bone marrow for a patient of 70 years with marked left shift with the overriding of the neutrophil and the mild left shift. Can we say about this case to be chronic neutrophilic leukemia? Can we say so? It is one of the differential diagnoses, but actually we were talking about this with Dr. Rim earlier, that cases of chronic neutrophilic leukemia, we must have, we must have actually granulocytic hyperplasia and mature granulocyte more than 80%, and at the same time there is no dysplasia. So we are here still in the level of MPS, MPN dysplasia. Returning to our case, so the biopsy confirmed the hypercellularity, the dysplastic features in the megakaryocyte, Here, the CD61 was also highlighting the dysplastic feature and the increase dysplastic megakaryocyte and no increase in fibrous tissue. Actually, there is a lot of overlap in MDS and PN as a molecular, but as we can see here that for cases of CNL and MDS, the dysplasia is the main feature, even though the CSF3 it can present in cases of chronic neutrophilic leukemia even 80%, while it can be present in MDS and PN with 20%. So our nutritional profile was karyotyping, negative MDS. Again, we have in this case to make sure that there is no JAK2, no NPL. So for us, the patient fulfilled the criteria of myelodysplastic, myeloproliferative neoplasm with neutrophilia. We are looking for the NGS, which confirmed the diagnosis to be myelodysplastic, myeloproliferative neoplasm with SRSF2 and TET2 frame shift. So as we can see here that the cases of myelodysplastic, myeloproliferative neoplasm, we have to be sure of proper assessment of the pathology to reach a proper diagnosis. We have to be careful because it is presented in the group with the 40s and the 50s as well. Unfortunately, they have bad prognosis and transfer to stem cell transplantation. Yet looking forward to therapy that it can represent better future for these cases. Thank you very much, and I finished earlier than my time.
Thank you, Doctora, for finishing earlier. Give me great pleasure to introduce our next speaker, Dr. Reem Ala Al-Rabih. Dr. Reem is a board-certified pathology consultant. She specializes in hematopathology, lymphomapathology, and also transfusion medicine, as well as coagulation, stem cell and apheresis. She's board certified in anatomic and clinical pathology and specializes in blood transfusion. The Dr. Reem is currently the head of hematology, coagulation and flow cytometry laboratories at King Fahd Specialist Hospital, Dammam, Saudi Arabia. The floor is yours, Dr. Reem.
Thank you for the kind introduction, Dr. Ammar, and thank you for the SSBMT for hosting my talk. All the cases we saw previously happened in the perfect world, where you have an insured patient with access to all the ancillary testing. I'm going to show the real world case where you have a patient from a displaced tribe. So he's uninsured. He doesn't have the luxury of having all the ancillary tests. And we had this case during a period where we had shortages of reagents. So we have an incomplete picture. And even though we had all these issues, we'll try to reach the diagnosis together. So this is a 27-year-old male who presented with epistaxis, gum bleeding, and anemia for 2 weeks. His CBC showed pancytopenia with few circulating blasts. That was back in 2021. His CBC, as you can see, has pancytopenia with around 5% blasts. He had a bone marrow aspirate done, and it showed the diagnosis of BALL. His flow cytometry showed positivity for TDT, 34, 19, 10 bright, 79A, 22 dim, 20 partial, 66 dim, and 81, and negative for all the other markers. So he was started on the RBFM protocol. And this protocol, in summary, has an induction phase of 5 weeks. It contains vincristine, prednisolone, asparaginase, danomycin, RSC, and methotrexate. And they go through phases of treatment from induction, consolidation, to maintenance. Remember, this patient is just eligible for chemotherapy, not eligible for any transplants. Back then, he had, according to the cytogenetics, that the karyotype failed. And we only had limited probes available at that time because of shortages. So they did by PCR, we did the BCR-ABL1, P190 and P210 were negative. And the fish showed some duplications, MLL rearrangement negative. However, we have an incomplete picture at this point. During the course of therapy, his follow-up bone marrows in 2021, day 33, we had a biopsy only, very limited analysis, showed rare clusters of immature cells. We repeated it on day 42, again, hemodilute aspirate, trilineage hematopoiesis, and hematological remission. However, we could not assess MRD properly due to hemodilution. In 2022, when he was in maintenance, he had myeloid hypoplasia, which we thought was secondary to his treatment, and he was in remission and MRD is negative. We had, with all these issues, we have staffing issues also in technicians or technologists assisting in bone marrow procedures. We lost that service, so we rely heavily on fellows to do the bone marrows by themselves. So in maintenance, again, in 2022, he had a good marrow, a good specimen, hematological remission, MRD negative. In 2023, he always dips into this myeloid hypoplasia or sometimes thrombocytopenia as well. Again, he's in remission with incomplete recovery, MRD negative. By 2023, end of maintenance, he was in good shape, hematological remission, MRD negative. Then in 2024, he presented with prolonged neutropenia and thrombocytopenia. He was also lost to follow up several times during the course of therapy because of his social issues. He had a hypocellular marrow showing trilineage hematopoiesis with no increase in blast cells. However, he did have megakaryocytic hypoplasia and dysplasia. MRD is negative. We put in a comment that he's off therapy, recently receiving GCSF. Please check nutritional profile, medication effect, viral infections as causes of dysplasia, and please do MDS fish and karyotype. According to cytogenetics, MDS fish and karyotype failed. We don't have the option to send out in this patient. So his bone marrow evaluation in 2025, when he finally came back to follow up, showed pancytopenia with 10% circulating blasts. You can see here in the peripheral blood, there are literally no neutrophils and no platelets. His bone marrow aspirate is adequate, showed few hypercellular marrow particles. The differential that was performed was around, again, 10% blasts. He did show severe dysplasia. You have the erythroid precursors here, showing megaloblastic changes, some nuclear cytoplasmic dysynchrony, as well as nuclear irregularities. You see binucleation as well as multinucleation, and as well as karyorrhexis. In the bone, also the myeloids looked dysplastic with left shift. You have several hypo-segmented, hypogranulated neutrophils with increased blasts around 10%. The megakaryocytes were very dysplastic with many small and hypolobated megakaryocytes as well as micro megakaryocytes. So I put in an initial diagnosis of MDS increased blasts 2, since he had 10% blasts, for correlation with cytogenetics and molecular studies, and I was suspecting it to be post-cytotoxic therapy since he was recently off chemotherapy for BALL. The karyotype came back finally, complex karyotype, including deletion 4, deletion 5q, and monosomy 7. The probe for chromosome 17 was out of stock. So I don't have that information. This is the real world. Wallah, I'm talking. This is what happens in the real world. So thankfully, we sent it without the insurance noticing that it's not funded. We have the myeloid tumor panel showing potential actionable variant in TP53 with a VAF of almost 77%, and the detected variant has previously been reported in somatic cases as well as in germline cases causing Leaf-Romani syndrome. So I amended the diagnosis with this comment. Per WHO 5th edition, a TP53 of VAF of more than 40 may be regarded as a presumptive or not definitive of copy loss on the transallele or copy neutral loss of heterozygosity when a constitutional TP53 variant can be ruled out. Therefore, this could be classified as MDS with biallelic TP53 inactivation. Due to the patient's young age, it's mandatory to rule out germline TP53 mutation by submitting a buccal mucosal sample, which is non-tumor tissue, for targeted testing. This may also represent a myeloid neoplasm post-cytotoxic therapy. So he came back 3 months later with a hypocellular fibrotic marrow with many immature cells, and you can see many dysplastic megakaryocytes. Hypocellular for age, the bone marrow is hypocellular for age with around 10 to 20% with marked serous degeneration and fibrosis. All elements were decreased with dysplastic megakaryocytes. CD34 again highlighted the 10 to 15% blasts with MF2 reticulin fibrosis. The clinicians asked the patient, and he reported positive family history for multiple members with breast and colon cancer. He rapidly progressed to AML. He was not fit for intensive chemotherapy and unfortunately succumbed to his disease. We could not confirm with germline testing because he wasn't insured. Going back to TP53, it encodes the P53 tumor suppressor protein, a transcription factor that responds to cellular stress, including DNA damage. Oncogenic mutations of TP53 often result in dysregulation of the P53 function due to structural changes in DNA binding protein. Under normal condition, you have the MDMX, MDM2, causing kind of a negative regulatory effect on the P53, and the end result is the degradation of P53. When you have stress or DNA damage, there will be phosphorylation of P53 and upregulation causing gene transcription, and either results in DNA damage repair or gene transcription and causing tumorigenesis. It's the most commonly mutated gene in human cancers, and in germline mutations, it occurs in the cancer predisposition syndrome, the so-called Leaf-Romani syndrome. Clinical and preclinical research into drugs that target TP53 is ongoing, but we are mostly interested in MDM2 inhibitors that aim to restore the P53 function. MDS with biallelic TP53 activation is a myeloid neoplasm associated with cytopenia, dysplasia, less than 20% blast, and most importantly, like Dr. Erij highlighted in her lecture, less than 30% pro-erythroblast to rule out acute erythroid leukemia. It's characterized by 2 or more TP53 mutations or TP53 mutation and evidence of concurrent copy loss, as you can see here in the karyotype. Here you can see chromosome 17, there's loss. So just in summary, there is no remaining wild type TP53. Both alleles are affected. So you need to do NGS and karyotype as well as FISH for chromosome 17. It can occur spontaneously after exposure to DNA damaging effects such as chemotherapy, and as well as inherited predisposition, Leaf-Romani syndrome or inherited bone marrow failure syndrome. So I think I was right in calling it an MDS with biallelic TP53 inactivation, because at the end, all these differentials fall under this category. And they will also drive myeloid neoplasms through divergent mechanisms. So you might argue, what is the difference between MDS with single monoallelic TP53 alteration and this entity? If you look at an NGS report from a patient with monoallelic TP53 alterations, you'll definitely find other driver mutations, but the cytogenetics will have less complexity. It's the opposite when it comes to this entity. In MDS with biallelic TP53 inactivation, they have fewer driver mutations and higher number of copy number abnormalities and cytogenetic lesions, like we had with our patients with multiple deletions and monosomy. So the complex cytogenetic abnormalities commonly included are 5q, 17p, loss of heterozygosity with or without copy number alterations, monosomy 7, and so on. The majority of TP53 alterations are missense mutations, like the one reported in our NGS panel. Here you can see an example of fish where you have 5 interphase cells, 2 signals of green and 2 signals of red is abnormal. When you have 1 signal of red, that means there's loss of the TP53 in these cells. So what we have in summary is a multi-hit mutation status resulting in this neoplastic clone that lacks any wild type of P53 mutation. And in addition to the regular myeloid NGS panel, you have something that you have to do something that targets the TP53 following the initial results. So you need to sequence analysis that covers at least 4 to 11 exons. And in addition to a technique to detect the copy number status, usually FISH or karyotype. The loss of genetic material may also be used may also be detected by other copy number assessment, such as array comparative genomic hybridization or inferred by next-gen sequencing. So this is just repeating what my comment said in my bone marrow report, that a TP53 VAF of more than 49 may be regarded as presumptive to this diagnosis. When you have 2 or more TP53 mutations detected, they usually affect both alleles and also can be considered multi-hit events. And as I said, more than 90% of these patients have very complex karyotype. You can also use P53 immunohistochemistry as demonstrated here in this picture. In summary, the diagnostic criteria, the essential ones are cytopenia involving 1 or more lineages, dysplasia involving 1 or more lineages, blast less than 20%, and with the detection of 1 or more TP53 mutation in the presence of TP53 mutation or direct and indirect evidence of TP53 loss or copy-neutral loss of heterozygosity. Desirable is complex karyotype with at least 3 abnormalities. These patients usually have a very severe course or accelerated course. They have increased blasts, a higher risk for leukemic transformation, and higher risk of death, independent of the IPSS score and independent of the treatment, as well as independent of any stem cell transplants. So if you don't have a comprehensive multi-hit TP53 analysis, it should be noted that patients with MDS with mutant TP53 and a VAF of more than 40 with complex cytogenetics may have similar poor prognosis. Leaf Romani is an autosomal dominant caused by pathogenic sequence variants of the TP53 tumor suppressor gene on chromosome 17p, and it's characterized by multiple cancers. The third in line was hematological cancers. And according to the phase of age, certain tumors might be more prevalent. I just wanted to point out that in the childhood phase, it's highly associated with hypodiploid pediatric ALL. So in these patients, they might require NGS to detect TP53 mutation and possibly go into the Leaf Romani workup. There is a wide range of onset in other soft tissue sarcomas. Here, there are NCCN guidelines that combine the classic and CRUMFIT criteria to guide testing for Leaf Romani. It doesn't apply, the ones in black does not apply to our patient because he doesn't have a solid tumor, but there are some exclusions at the end that says if there is a clinical scenario not meeting these criteria, but warranting germline evaluation for clinical discretion. So I guess we can initiate testing if we have a pathogenic or glycopathogenic variant of TP53 with a high VAF. So if we look at the essential diagnostic criteria for Leaf Romani spectrum, if we say that our patient has a possible or a pathogenic germline TP53 variant, no history of cancer, and some history in the family, this could be called an attenuated Leaf Romani syndrome, which is a less severe form with a moderately increased risk for certain cancers. So if you find a TP53 mutation in blood, saliva, or buccal samples, try to do skin fibroblasts to confirm the germline and the germline etiology of TP53 mutation. So as we said, they confer an elevated risk for radiation-induced secondary malignancies as well as related to chemotherapy. As I said, in addition to other testing, you should confirm that you sequence a TP53, and this will identify 89% of the pathologic variants, and they should cover exons 2 to 11. This is from Gene Reviews. Going back to my initial assumption that this is a myeloid neoplasm post-cytotoxic therapy, going back to his chemo protocol, he did not receive any alkylating agents. So MDS happening post-cytotoxic therapy requires alkylating agents or ionizing radiation exposure. Latency is unknown, and it is high-risk MDS with with aberrant karyotype and several unbalanced chromosome aberrations, including multiple losses. They're also frequently associated with TP53 deletions and mutations. And they're likely to be multi-hit and with high VAF frequency. So if we go back to his RBFM protocol, he received a topoisomerase inhibitor, which is a daunorubicin. And this usually results in a kind of an early progression to AML or ALL, but not associated with an MDS phase. So I think this diagnosis is out of the question. So take-home points: detection of biallelic TP53 alteration requires sequence analysis coupled with a technique such as FISH to detect copy number status. TP53 VAF of more than 40 may be regarded as presumptive, not definitive, of copy loss on the transallele or copy neutral loss of heterozygosity when a constitutional TP53 can be ruled out. MDS with biallelic TP53 inactivation cases have significantly fewer additional driver mutations and higher number of copy number abnormalities and cytogenetic lesions. This is what I have for the day. Thank you. This diagnosis is a unicorn. I got this picture from a tapestry in Stirling Castle in Scotland this last summer. Thank you.
Thank you, Doctora. We appreciate your finish on time. It gives me great pleasure to introduce our guest speaker who came all the way from Toulouse, France. This Dr. Pierre Brosset. He's a professor of pathology from Toulouse University Hospital. He's the head of pathology department and director of a large research laboratory under the name of LabX Toucan. Dr. Pierre, he is nationwide coordinator of the French Network for Second Opinions in Lymphoma Pathology, which has supported the French National Cancer Institute. He is member of Clinical Advisory Committee and contributor to International Consensus Classification of Myeloid and Lymphoid Neoplasm 2022. He is a member of the French Academy of Medicine. He is a known editorial board and reviewer of many reputed international journals, I cannot read them all. And he has many publications, more than 320 papers in different journals, such as Blood or American Journal of Pathology, Oncogene, etc. We would like to welcome Dr. Pierre, and we are looking forward to listen to you. Thank you.
Salam alaikum. Good morning, everyone, and thank you, Mr. Chairman, for this presentation. So I'm expert in lymphoma. This is a myeloid session, so I'm going to talk about lymphoma diagnosis, but with the head of artificial intelligence. And I would like to share with you our experience in the field of pathologic diagnosis. The microscopic diagnosis of rare tumors is a challenging task. And as illustrated by this nationwide study we carried out with Philippe Gollard, we created a network for a second opinion for lymphoma diagnosis in France, and we reviewed 32,000 cases. It turned out that the initial diagnosis was inaccurate in 20% of the cases, with a direct clinical impact on patients' management. So there is a problem in histopathology diagnosis of lymphoma and rare tumors in general. So how to improve this? Possibly with the help of artificial intelligence, but the way is still long to go. And so the first breakthrough in the field of pathology was the invention of digital pathology, which consists in using slide scanners and transforming histopathology images on glass slides into an informatic files containing huge amount of data. This water slide image contain, on average, millions of cells, billions of pixels, billions of octets. They are ideal material for sampling and segmentation and to run AI algos. Two approaches for machine learning, conventional machine learning. When you want to analyze and recognize pictures, you can train classifiers, but with conventional machine learning, you extract the characteristic, the features of the image, and then you train the system to recognize these features. On the other hand, and what is used by many teams in the world, is the deep learning, in which you have both an automatic feature extraction and a classification. And this approach, these algos are ideal to handle such amount of data, the data we have on water slide images. So this is the design of a deep learning approach. You have a sampling, automatic sampling, and the information is coming from patches, randomly selected from the image, and then they are run into the algo, and at the end we expect to have a prediction. So you can anticipate that at this point we have a black box. We don't know on what kind of feature the decision has been taken. So there have been a lot of studies over the last 10 years published promising that thanks to AI and based on the histopathology image analysis, it was possible to classify the tumors, even to propose to make a mutational analysis of these tumors. This is this seminal publication published 7 years ago. Proposed to an algo which was able to make the diagnosis of non-small cell lung carcinoma and to deduce the molecular, the different mutations present in the tumors. I would say that after these 7 years, nothing has replaced molecular biology to do so. So there is a problem with AI related to histopathology images. There have been a lot of publication promising many things, classification, mutational status analysis, etc., etc. I would say that most of the studies are not reproducible. So is there a problem with AI and histopathology image? So what we did very modestly in the lab, I was working with computer scientists. I'm not expert in computational science, so I'm working with engineers, and we asked a very simple question on histopathology image. Was it possible to differentiate two very similar images, follicular hyperplasia, and follicular lymphoma, which are very similar in terms of morphologic features? We select 500 cases of each, and then we design a deep learning approach, very classical one. We train the system, the algo, we validate, and then we test. And we look at the accuracy of prediction at the end. Fantastic, the accuracy is quite high. The algo is able to distinguish follicular hyperplasia from follicular lymphoma in 97% of the cases. It's a fantastic result. So we said, okay, we wanted to challenge our algo and to see how algo was able to recognize images coming from other departments. We asked colleagues in universities in France to provide us with images of follicular hyperplasia and follicular lymphoma. And it turned out that the accuracy of prediction dropped dramatically to 70%. So something went wrong. It's what the computer scientists call the lack of generalization, or so-called overfitting. Our algo is unable to recognize the images from other departments. There is a bias. So where is the bias? You all know in pathology, you all know that there is a problem with the tissue processing, and there are many steps in the tissue processing that lead to the image. And in particular, the staining step is particularly sensitive to produce this kind of image heterogeneity. So how to circumvent this problem? We can increase the size of the training set, or we can informatically work on the images through data augmentation, color normalization, and we can also use other AI strategy, to which I will come back later. What we did in the lab, we wanted to work informatically on the images, and what we did, we did an experiment, a simple experiment. We took a tumor and we sent the samples of this tumor in 3 different labs. And we look at the images after the tissue processing in these 3 different labs. And what we observed was 3 different images. So there is a huge heterogeneity from one lab to another, and sometimes between the lab itself. So how to manage this if you want to work with AI and deep learning? So we have tried to explain that, and we have extracted informatically the pixels from these 3 images. We obtained 3 clouds showing that these pictures are completely distinct informatically. And we try to reduce this dispersion of the pixels by working through data augmentation, color normalization, and if we combine the 2 approaches, we reduce this heterogeneity, and we can obtain this kind of result, certain degree of normalization of the image. And then we come back to the training, and then we insert in the workflow this filter of color normalization and data augmentation, and we increase the generalization of the algo. There are the bias when you're dealing with deep learning. What is a bias? It's it's a systematic link between something that is not biological meaningful in a training data set and the expected label. Here we have performed heat maps on the 2 images, follicular hyperplasia and follicular lymphoma, extracted the most relevant patches from these images. And we show that here we obtained patches which are highly indicative of malignancy in the follicular hyperplasia, and the other way around for follicular lymphoma. So there is a problem. And the choice of the patches in deep learning for the prediction is difficult to understand. This is the black box effect. So what we have in mind is to create a solution, what we have called assistant pathologist. The problem is not to replace the pathologist, it's to assist them in their everyday practice. This is the goal of AI in the future. And what we want to, we are dealing with rare tumors and lymphoma, and so what we would like to create is an assistant, an algo, which is able to assist the pathologist in lymphoma diagnosis. So there are many challenges to face. The first is that we are dealing with more than 100 different lymphoma subtypes, according to the classifications. And the tissue processing heterogeneity, you now know that is a problem. We receive more and more needle biopsy, and the diagnosis is easier on surgical incision material. And the ideal number of cases to reach a robust accuracy should be around 25,000 cases. So many challenges. So, but we start from the French network database, in which we have collected 200,000 cases. We have now some experience in deep learning models, and we can also work on the images informatically. And we can reinforce the training by injecting as much as possible metadata, such as clinical information and biological parameters from the cases. So it's what we did. These are preliminary results. We collected 2,000 cases of follicular hyperplasia, follicular lymphoma, DLBCL, SLL, and Hodgkin lymphoma. These 3 subtypes account for 75% of all cases of lymphoma. There is a bias also here. But we started with this relatively short series of cases. We trained algos, CNNs, convolutional neural networks, which had already been trained to recognize pictures. So this is what we call transfer learning. This is a fully supervised approach. And then we look at the end what happened. It works. It works. The accuracy of prediction is quite good for follicular lymphoma, for SLL, and for the LBCL. However, for Hodgkin lymphoma, there is still a lot of work to do to increase this accuracy. So we are in the good way. There are other possibilities and other alternatives to deep learning, such as foundation models, which are derived from generative AI. And I would like, at the end of the presentation, to describe the strategy we have developed in Toulouse, which is called Cartesian genetic programming. So what about foundation models? There have been a lot of publications over the last 2 years in the best journals describing this approach. And this is a strategy different. The algo is relatively similar to a CNN, but it's a transformer, something different. With I will not go into detail, but the principle is that this is a self-supervised learning on completely unlabeled data. Let me explain. The strategy consists in using this algo, a transformer, which is a kind of CNN, let's say, and we collect thousands of whole slide images, and we train the algo on billions of patches extracted from images coming from different tumors and organs. So the idea is to saturate this transformer with the highest number of patches possible. And then in the second step, there is a supervised fine-tuning training. We can train more specifically the algo, pre-train with patches with specific tumors. It's not working in the case of lymphoma because there's we have 100 different subtypes, and the amount of patches used in the different papers we have access to is not sufficient to allow us to reach a good accuracy. So what we have in mind is to develop another approach, which is based on Cartesian genetic programming. What is Cartesian genetic programming is the use of algorithms which are selected by a Darwinian approach. Let me explain. These algos are composed of blocks. Each block is coding for a function able to extract features from images. So you have to ask the algo, I would like the algo to extract, to delineate the cells, to count the cells, etc., whatever. And the boxes are tandemly and randomly arranged, and we create several algos, and then these algos are selected for a task, delineating a cell, segment a tissue section, and then we select the best algos in the first round, and then at the end of the first selection, this algo undergo a crossing over, and after this crossing over, there is a random mutation inserted in the code randomly, and then there is a second round of selection, and like this, many generations of algo are selected. Let me show you an example. This is a simple approach. We have a cell culture, and we have obtained a mask manually with informatics commercial software, and we have segmented the different cells present on the two images. And we have asked the different algos selected to do the same job with the same accuracy. So we have to start the selection and we start with the first generation, and we can monitor the accuracy prediction of the algo over time. And this is what happens, over time. You can see here the accuracy prediction is increasing, and the mask is becoming very close to the controls, and the accuracy prediction reach a plateau with very good rate. And here you have the final result, which is perfect. So we have something very simple over 25,000 generations, which is able to do an automatic job on your images and extract features. This is very useful. So we can use this on FFP tissue sections, for instance, here. And the quality of this approach is that we can work with a small amount of patches. Only 30 patches here on these images allow these algos to recognize the nuclei on this image automatically. So this is very powerful. So the strategy we want to follow is what we did, and we want to do is this, an automatic extraction of features by CGP, and then we have explainable features we can use to train CNN and obtain a prediction. So in conclusion, tissue processing heterogeneity is a cause of H&E variability and the main cause of overfitting in deep learning. We can work informatically to reduce this heterogeneity. There are other solutions of machine learning, foundation models, and the approach we have developed in Toulouse, we are working on. What is our goal is to create an assistant pathologist. What is an assistant pathologist? By analogy on what we're doing in routine, I'm training interns in my department, like the majority of you. And this is the intern, and this is the senior pathologist. The intern is naive at the beginning, and over time it is becoming more and more expert. And what I expect from the algo is because the algo has no limit for training, is to be able to assist me after looking at the image to make a diagnostic hypothesis, to write a standardized report automatically, and to suggest ancillary technique to perform to finish and sign out the case. So where are we in terms of industrial valorization for AI solution in pathology? There are quite a few companies compared to radiology. There is striking difference between the pathologists and only some companies propose solution IVDR research use only. So, but there is a long way to go, and so but we are on the good track. And I would like to thank the people who are working with me in Toulouse. Without the engineers, in 2025, medicine without engineers is not possible. So we are, my engineers, the doctors who are working with me, and this is the description of our laboratory. We have many platforms, and we will be happy to collaborate with people in Saudi Arabia. Thank you for your attention.
Thank you, Prof. Pierre. Can we invite all the speakers to the podium for Q&A discussions? Microphone to Dr. Mansour, please. Here.
Thank you very much for this very informative session, actually. And I have two questions, one for Dr. Nahla and the other for Dr. Arij. Starting from my colleague, Dr. Nahla. Actually, thank you for presenting this case in which you have JAK2 positive, despite the clinical pathological feature does not support the diagnosis of MPN, especially in young age adolescent patient, I could say. I think without clear morphological and clinical pathological features of MPN, we cannot diagnose him as MPN unless we have the complete picture. And I would suggest that you need to think of CHEP, clonal hematopoietic of undetermined potential. And you need also to rule out the possibility of congenital and familial polycythemia for many reasons, actually. It is very endemic in our region, and he is still young. And I think you need to think of von Hippel-Lindau gene. You need to think of PHD1, hypoxia-inducible factor, HIF alpha and beta. And also, do not forget high affinity hemoglobins, because it might lead to a polycythemia. And in National Guard, I remember a case, I think in 2014, we diagnosed him with primary familial congenital polycythemia vera, congenital polycythemia with APOR mutation. And, you know, at that time, it was very difficult to reach the diagnosis. So I think it's good to think of that, unless NGS came up with astonishing or another diagnosis. So this is my question and my comment for you. If you want to answer, and then
Thank you very much for your comment, but totally agree. Cases of MPN needs collaboration, genetic, clinical, laboratory. So this patient, as I told you, never been on high white blood cell before. So we go through all his investigation. He's still young, 14. It's possible that he have MPN BV, for masked BV, for example. But again, as a pathologist, I need to see the tissue biopsy showing the MPN. Again, ICC 2022 and WHO say that if you have JAK positive, if you have erythrocytosis or high hemoglobin hematocrit, this is MPN. But for us, again, I would recommend repeat of workup, confirm the finding. Maybe we can go deep further away from the NGS. It's not an easy case and it's still under investigation, but we need to be careful with those patients.
Totally agree. And actually now it's a comment for Dr. Arij. Actually, I think, practically speaking, acute erythroid leukemia is one of the pain area in the WHO classification.
I agree.
And due to actually arbitrary and many irreproducible findings, and if you take the journey of classification of acute erythroid leukemia since 2008, at least since I was born as a hematopathologist, and passing to 2016 and now 22, if you see the classification, they keep changing the classification, the criteria, and they remove some classification. And now in 2022, they still insisting that we don't have acute erythroid myeloid leukemia. We have only pure erythroid leukemia, and you have to add also biallelic B53. I think, we had many cases which fit anything except acute erythroid myeloid leukemia, in which the patient has acute presentation and he has having only 8 or 9% myeloblasts with our roads, and he has erythroid hyperplasia. And, even pro-erythroblast, sometimes it is very difficult to be calculated whether you integrate e-cadrine and with morphology. So actually, it is one of our pain in the diagnosis of WHO classification. So do you believe that still we have to use acute erythroid myeloid leukemia back to classification 2008?
Well, this is a good question. And I think pure erythroid leukemia or acute erythroid leukemia, as you said, it's a very rare entity. By the way, we had a case before that case, and it was typical for pure erythroid dysplasia or pure erythroid leukemia, sorry. So
I remember we were pulling the case that was confirmed because that one was typical, full of proerythroblast compared to this one. I'm happy about the current classification because I believe like pure-erythroid leukemia, it's a distinct entity. The one with the old classification, which is M1, was called with myeloid or the increase of myeloblast. It's overlapping with the MDS, and that's why it was or AML with myelodysplasia-related changes. That's why it was excluded. And usually the pure erythroid leukemia, they have very dismal outcome. I remember one of the studies mentioned overall survival of less than 6 months or 4 even. So yes, it's very difficult. And in that case, we were really, you know, the count, sometimes you need to extend the count reaching to 500. That case, we reached to 1,000 just to increase the reproducibility of proerythroblast percentage count. But still, we sign out the case as childhood MDS evolving to acute leukemia because, you know, the hematologic neoplasm, usually they are dynamic, and I have diagnosed many cases as MDS and with excess blast, and in 2 weeks or next week they have increased blast meeting the criteria for AML. So I think I'm happy with pure erythroid leukemia. The biallelic TP53 is very important and it helps a lot. In our case, it was negative.
It was very clear. Thank you, Dr. Rich. I have this question. Dr. Bakshi? Yeah. No, after you. No. Go ahead.
Assalamu alaikum. My question, rather comment is for Dr. Reem. First of all, a very nice case presentation and also explaining the P53 aberrations to the audience. So I want to argue about the usage of germline mutation related predisposition in P53 cases like this, which is really important because of the family, in future of the consequences of having solid tumors and other tumors, generally speaking. And also because in this patient, I think you said patient has a family history, young age, high VAF. So it's all kind of adds together to give sort of a lead towards a germline predisposition related myeloid neoplasm. Still is an MDS, right? It wasn't an AML yet. Still an MDS.
At the time, MDS, no, but it switched to AML pretty quick, within 3 months.
Yeah, so so the issue's already progressed very fast. So the other thing is obviously the Li-Fraumeni syndrome, which is kind of, is not the prototype. I mean, we talk about Li-Fraumeni having solid tumors and for AMLs, but actually it can, the spectrum is very wide. It can have so many tumors at the same time. And in the families of different, there's no connection. We sometimes think the patient has a lymphoma, and then patient has sometimes AML later on in life, or AML first. We think it's not connected. Actually, a lot of them are germline. So we kind of underdiagnose. It's recognized in our community, especially in Saudi Arabia, where we have a lot of family, marriages and, siblings. And this is very, my point is just to say that this is the hematolymphoid neoplasms with germline mutations are very under-recognized. So raising the awareness about this in our clinical colleagues as well as the pathology world is very important. I want to hear your comment about the germline predisposition in this case also.
In this case, as I said, the patient was not eligible for further testing as well as his family because of lack of insurance. If in perfect world, we would have tested the family as well. I would like to guide this comment towards Dr. Arid because she had a perfect case of GATA2. And it went into transplant. Did you test the family before transplant?
Because honestly, sometimes it's really hard to do germline testing because the recommendation is to do buccal swab or skin fibroblast culture, which took long time. to my knowledge. But I think this is very important and it should be part of the workup for any patient who's young, presented with hypocellular, borderline dysplasia. I think it should be done, صراحة. But in our case, the scenario it was a little bit different because already we know that the patient has two sisters who were diagnosed with acute leukemia. And one of them, she has a very impressive NGS, and GATA2 was one of these mutation. Also, the 2 weeks ago, one of my colleagues, Dr. Abdullah, he had the other sister who's presented with MDS. So already we have the link that this is inherited regardless the germline. But I think it's very important to have germline testing to confirm that.
No, send out.
Usually send out.
Maybe send out. Most of the time, send out. Most of the centers are send out.
To my knowledge, it's send out just unless there is any other hospital.
We came to an end to this session and to the Q&A session as well, but there are many questions. If you do have questions and queries, the speakers will be available at the break and lunch. So please, you can have better communication with the speakers.
Just wanted to comment about the JAK2. Actually, JAK2, in such cases, all of our labs doesn't have JAK2 except, as Dr. said, only positive, negative JAK2. In such cases, which there is no informative bone marrow, allele burden has to be requested in such cases. The truth that the allele burden of JAK2 must be 0. Cases of 0.0, 0.1 to 1, these cases have raising this case of even to 0.1 to 1. To these cases, we have to comment on it is clonal hematopoiesis, which has to be followed up, continuous follow-up has to be done. But for the cases of PV, it is the most allele burden, the most category of the MPN that having allele burden. It has like almost from 50 to 80%, followed by the MPF, which have 30 to 60%, followed by the ET, which have almost 15 to 30%. So the allele burden to differentiate, even in, I think you can be reminded by Hans, that the allele burden is part of their workup, even to differentiate cases of polycythemia vera versus ET, that these cases which have very high allele burden to the side of polycythemia vera rather than ET. So we don't say that we will do it, but in cases that it is really masked or it is not sure, we have to request or send out for JAK2 allele burden because it will give us a hint. Is it present or not? If it is 0, this is what expected. All of us shouldn't show JAK2 positive. The minor thing, even 0.1 to 1%, we say that this is clonal, we respect it as clonal, and we has to be followed up regularly to see this patient will develop, what he will develop later on. Okay.
Very good comment.
So it's really important issue.
We'll continue later on. I think we are behind in time, so we will, according to schedule, we should be back by 12:30. ها؟ ما أدري إذا بيزودوه بس according to
12:45.
so we'll be back 12:44.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon. Thank you for sticking around after lunch, which is a very, very challenging task to do. So I salute you all. We will continue our program today with lecture by Dr. Haytham Khogair. Dr. Haytham Khogair is one of the figures, the main figures in hematopathology in the kingdom. He is the head section of hematopathology and consultant of hematopathology and molecular genetics in King Faisal Specialist Hospital and Research Center. And he will be talking today about AML. Dr. Haytham, الله يحفظك ويسلمك. تجد عندك هذا وهذا لازم تلبسه. Excuse me. This.
Which one you want to use? Anything. You want the walking? Yeah, anything. Anything, no problem. What is the laser? This is the power. See the laser? Yeah. You want the point? No, where is the pointer? Yeah, this is the pointer. Sorry. This is the pointer. This is the forward. Ah, okay, this is forward? Forward, yeah. And backward, this one is backward. Okay, good. Yes. بسم الله الرحمن الرحيم. الصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا ونبينا محمد عليه أفضل الصلاة وأتم التسليم. Thank you very much for that kind of introduction. It's pleasure to be here today speaking to you about one of the important concepts related to AML. One of our aim as a hematopathologist to add a value of our clinical practice to our colleague in the clinical part. So I hope in the end of this talk, we'll agree that sometimes simple thing you add, it will be of the great value for our clinical colleague. So let's start with a case. 68 years old male presented to the ER with dyspnea and fatigue. There is no personal or family history of the cancer or cytotoxic exposure. CBC showed cytopenia alongside with the 50% circulating blast, and the bone marrow examination revealed hypercellular marrow with 70% blast.
So flow cytometry was done on the bone marrow aspirate and shows these leukemic cells are positive for CD34, 117, 13, 15, 33, and apparent expression of 756, and confirmed the myeloid origin by MPO, and negative for the rest. So this is the peripheral blood morphology. As you can see, there is multiple blast. Bone marrow aspirate shows more blast, and the bone marrow biopsy reveals diffuse infiltration by leukemic blast. So our diagnosis was acute myeloid leukemia, simple diagnosis. And usually all the cases should be sent for the ancillary test, including cytogenetic FISH and molecular NGS analysis, and the result to be followed. So cytogenetics came back with the complex karyotype, and the FISH confirmed the TP53 abnormalities. However, these results received or delivered after usually it takes 5 to 7 days. And the molecular NGS testing reveals a mutation in the TP53 gene with variant allelic frequency of 60%. And again, also with sometimes NGS typically takes around 10 to 14 days. So while TP53 mutations are found in the 5% to 10% of de novo AML and MDS cases, they can occur in 25%, 40% therapy-related AML and MDS cases, and also in 50% of cases or patient who shows complex karyotype. 2022, the ICC recognized the TP53 mutated AML and MDS as separate and unique entity, while this is not recognized in the 5th edition of the WHO. So my question here, how important or essential is it for the clinician to know the TP53 mutation status as quickly as possible? Several studies indicate that individual with the TP53 mutation has a worse outcome than prognosis. ELN and NCCN list AML with mutated TP53 as an adverse risk group. And based on the fact that patients with the TP53 mutation, they are resistant to the chemotherapy, so TP53 and has poor prognosis, so TP53 status is emerged as an important determinant of therapy selection. Several studies indicate hypermethylating agents are more effective in inducing remission than chemotherapy. So consequently, urgent action is important, and prompt assessment for TP53 mutation is crucial. Given that, or recognizing that NGS result typically takes sometimes, usually 10 to 14 days. And this is because of some constraints, difficulties. So the alternative or the best quick alternative method is immunohistochemistry to assess the TP53 protein expression. This test retains the result just in 24 hours and can give you let's say, insight about the possibility of the TP53 mutation as detected by NGS. Several studies have evaluated the TP53 IHC in AML and MDS, and these two studies were among the earliest studies to evaluate the significant role of the TP53 IHC in the AML and MDS. So collectively, the finding demonstrate the TP53 IHC positivity correlate with the worse overall survival rate, supporting the potential role of TB53 IHC in the AML and MDS. However, the important thing that to mention in these two studies, and few other studies came after this, these studies, they used the manual IHC scoring system, and they used the cutoff 10% to call these cases as a positive. Dr. Tashakuri from the MD Anderson, he evaluated the TB53 expression retrospectively and by using a digital image analysis and the cutoff of 7.2% on 211 patients with TB50 with non-TB53 mutational status. So now we have a 3 IHC TB53 pattern that correlate with the underlying TB53 genomic status. The first one is wild type, as you can see here, faint, heterogeneous, nuclear staining that reflect the normal physiological condition where TB53 is tightly regulated and rapidly degraded by MDM2. So this is why we can see faint expression. In contrast, as you can see here, this is the mutant pattern. You shows strong TB53 accumulation, and this is specifically reflects when we said +3, high level of intensity. And the reason here mutated TB53 is resistance to the MDM2 mediated degradation. So it results in high accumulation of the TB53 protein in the nucleus. The third pattern is truncated pattern, completely negative. Again, this pattern is abnormal. And as you can see, these cells internal control endothelial and histiocytes, while the leukemic cells are completely and entirely negative, and this consider also negative abnormal pattern. So this is what I meant by high intensity. So always we count +3. We don't count +2, +1, and the 0. So always we count +3. So this table shows the concordance between TB53 molecular finding and the TB53 immunohistochemistry result. So out of 128 patients with TB53 mutation based on the molecular testing, 120 shows positive IHC mutant expression, including both the mutant type and the truncated type. So this difference, or this the result, is excellent surrogate marker. And among 83 patients with the wild type, 76 patients shows a wild type expression. So TB53 shows high sensitivity and specificity. So from this table and from this figure, we can say TB53 IHC can predict the TB53 mutation as the NGS can you give the result or the finding. So going back to our case, bone marrow biopsy, diffuse infiltration by leukemic cells, and this is the P53 expression. So from the first look, you can say more than 50% are positive for P53. And as I said, we count only these cells that showing +3 nuclear staining. So my home message, because simple thing like adding TP53 in all AML cases and MDS, it will add value for our colleague in the clinical part. So B53 immunostain is a powerful surrogated marker for TP53 alteration in AML. As a prognostic value, abnormal B53 by IHC, either high or no, is linked to poor survival, independent of the other risk factors. As a clinical utility, B53 is fast, low cost, and widely available, making it highly useful for quick triage while waiting for NGS result, risk stratification in resource limited or urgent setting, and standardization is essentially you have to look for the antibody clone and you have to establish a cutoff interpretation criteria to ensure the reproducibility across the lab. Several elegant studies reported and established very strict cutoff and saying less than 5% will consider wild type B53, more than 10% consider mutant B53, and any result between 5% to 10% are deemed indeterminate. So by adding this simple test in all cases, it may change and it will be useful information for our colleague in the clinical side to act on it. And even if the resource is limited, I do advise my colleague just to select the cases, those showing background of MDS and those who have a history of the chemotherapy. Thank you. I'm done.
Hi. Thank you, Dr. Haytham, for this interesting talk. Now we'll move to our next lecture with Dr. Khalid Al-Ayed. Dr. Khalid Al-Ayed is a consultant hematopathology and flow cytometry at King Saud University and also works as a researcher at University Hospital Case Medical Center in Cleveland, Ohio. Dr. Al-Ayed academic background includes a Master of Science and System Biology and Bioinformatics from Case Western Reserve University, as well as several fellowships and certifications in the field of hematopathology. He's a fellow of College of American Pathologists, a fellow of Royal College of Pathologists of Australia. Welcome, Dr. Al-Ayed, and the floor is yours.
Thank you very much. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullah. Thank you very much, Dr. Noor, and for the organizing committee for inviting me. I'm really happy to be here. So I'm going to talk today about PBDCN. Diagnosis begin with awareness. Starting with case one, this is a 59 years old male known to have diabetes, hypertension, and smoking. He presented in November 2024 with enlarged lymph node on the left side of neck, which was followed by skin lesions involving the neck and chest, then eventually his limbs, associated with fever, fatigue, and weight loss of 8 kilograms. No family history of cancer or bleeding disorders. Initial hospitalization showed severe anemia, his hemoglobin reaching 3, associated with shortness of breath, admitted for 2 months, treated with antibiotics and steroids. improved in terms of the neck mass and the skin lesions, kept on transfusion support, and received almost about 7 packed RBCs. But his symptoms recome again, the skin lesions and the lymph node start to enlarge again, and he was transferred for a tertiary care. When we saw him, his imaging, the CT scan and PET scan showed lymphadenopathy, splenomegaly, bone marrow involvement by PET, and thyroid nodules. MRI for his brain was negative. So the pathology review have showed his peripheral blood containing around 30% circulating immature cells. And you can see here, they are somewhat heterogeneous and not uniform. Some of them are like medium in size with high NC ratio, round nucleus, open chromatin, no prominent nucleoli. And on the left side, on the right side, you can see some of the tumor cells are more large in size with slightly abundant cytoplasm, slightly basophilic, deeply basophilic, and similarly, no like prominent nucleoli. If you focus with me here, some of the blasts show like a stack of vacuoles in the end of the cytoplasm just underneath the surface in some of the blasts. His bone marrow aspirate similarly shows a high percentage of leukemic cells reaching 50%. Here slightly different. We can see, as you can see here in the 3 plots, some of the blasts show cytoplasmic protrusions, tail-like, and the cells show some eccentric nuclei in them, and the cytoplasm is more basophilic. His fine biopsy, you can see here. The involvement is not complete. So it's a patchy, vaguely nodular, some like sheets of cells. So it's like partially diffuse and vaguely nodular pattern of involvement. And you can see the normal hematopoiesis is somewhat pushed or like displaced away from the tumor cells. High power of the tumor cells, you can see them medium in size with open chromatin, scant cytoplasm. Some of them show like a twisting nuclear pattern. No like increase in mitosis or apoptotic figures. Moving to the flow cytometry analysis. So similarly, there is 50% of the bone marrow cells are falling in the blast gate. And the lineage-specific markers, we started with them. So there is no clear evidence of the presence of any of the B-cell markers. You can see here, CD19 is negative, CD10 is negative, CD22 is negative. MPO as compared to the positive control in the sample that is in the blue square is clearly negative MPO, and the monocytic markers are negative. You can see here CD64, and CD16, CD14 are negative. CD34 is negative. There is partial expression of CD117. And the last 2 plots show the common myeloid or monocytic markers, CD11B, 11C, CD15, and CD33, all are negative. Completing the panel, we find that blast cells are strongly positive for CD56, partially positive for CD4, and CD123 is positive with very bright expression for HLA-DR. We complete the panel by IHC staining. So you remember the bone marrow fine biopsy by H&E. The tumor cells are patchy, and here is the same. So leukemic cells are clearly positive and strongly positive for TCL1 and TCF4. Karyotypic analysis show normal diploid, male karyotype, and negative FISH analysis for AML panel. So the case was diagnosed as blastic plasmacytoid dendritic cell neoplasm, PBDCN. Our patient received the anti-CD123 targeted therapy for 2 cycles. along with intrathecal chemo for 4 sessions, followed by allo stem cell transplantation in March 2025 with matched sibling donor, his brother. And currently he's stable and the patient was discharged home. He is complaining of some anemia and thrombocytopenia, and his recent bone marrow in June 2025 showed hypocellular bone marrow with regenerating trilineage hematopoiesis -4 disease. Moving now to case 2. This is a 17-year-old girl, known case of left tibial osteosarcoma, diagnosed in September 2022, treated with chemotherapy, and presented in July 2025 with fever, fatigue, and epistaxis. Her labs show severe anemia, thrombocytopenia, and circulating immature cells with skin lesions. This is the peripheral blood of the young girl, and we can see there is around 90% tumor cells in the peripheral blood. We can see here a wide range of cells. It's medium to large in size with slightly or moderately cytoplasm. Similar to first case, there is some cytoplasmic granules near the end of the cytoplasm, just underneath the surface. However, some cells are more basophilic, show more basophilic blue cytoplasm with some myeloblastic features. The trifine biopsy, the bone marrow aspirate was done, but was badly diluted, was like similar to a peripheral blood. The trifine biopsy show complete replacement of the normal hematopoiesis. So mostly all bone marrow spaces are completely involved by what you can see here, sheets of blast cells. And you can see the high power here. The blast cells are more towards the large in size with abundant cytoplasm, appreciated by the widely spaced cells. And majority of blasts show a prominent nucleoli. The flow cytometry analysis of these cells. We can see here 94% of the peripheral blood cells are falling in the monocytic gate. And by assessing the lineage-specific markers, we can see here the B cell markers CD19, CD10, CD22 are negative. CD5 and CD3, CD3 not shown here, both are negative, and MPO compared to the positive control in the box is -2. In this case, the leukemic cells express strong expression for CD64 with a subset of CD14 expression, negative for CD34 and CD117. There is strong expression for CD11C along with CD33. CD15 is strong with big and partial expression for CD11B. So monocytic markers are clearly identified here. Continuing the panel, the leukemic cells are very strong for CD4 and CD56 with partial expression for CD123 and partial expression for HLA-DR. IHC staining, the leukemic cells are completely negative for TCL1 and TCF4. Genetic studies have shown normal diploid female karyotype for the girl. FISH analysis for AML panel was negative. NGS have detected TP53 mutation and NRAS mutation. So the case was diagnosed as acute monocytic leukemia. And if you check the findings for this case, it is meeting the criteria for acute monocytic leukemia post-cytotoxic therapy. Now I'm going to talk about our topic for this talk. So PBDCN is a hematologic neoplasm characterized by proliferation of immature plasmacytoid dendritic cells with high frequency of skin and bone marrow involvement and poor outcome. Majority of PBDCN cases believed to arise from a precursor, plasmacytoid dendritic cell precursors that directly differentiate from the hematopoietic stem cells. However, recent literature have shown that Other cases of PBDCN are found to be originate or coming from other type of dendritic cells, such as the common dendritic cell, as shown here. Or some of cases are coming from monocytic derived dendritic cells. And these cases have found or appreciated by a new transcriptomic and single cell sequencing data. PBDCN is a rare disease, annual incidence of 0.04 cases per 100,000 individual in the United States. It has a bimodal age distribution with a median age commonly in the 67 years old and another one in the pediatric group with a median of 10 years old. There is a male predominance 4 to 6 to 1 in the adult age group, not seen in the pediatric group. Clinical features, usually patients present with skin lesions, leukemic presentation without extramedullary disease, seen by the fatigue, easy bruising and recurrent infection, lymphadenopathy, and some cases presented with CNS symptoms. Pathology, as we saw in the first case, usually bone marrow is involved variably, ranging from 10 to 80%, and it is a diffuse interstitial pattern of involvement with displacement of hematopoietic elements. Usually the cells are medium in size. The bone marrow cytology features similarly medium-sized cells, eccentric round irregular nucleus with fine chromatin, light gray or slightly basophilic cytoplasm, and frequently contain vacuoles, and the pattern of string of pearls is noticed, tail-like protrusion, pseudopodia. In tissue, usually it's a diffuse monotonous infiltrates with a medium-sized immature cells that mimic lymphoblasts, sometimes myeloblasts. Immunoblastic lymphoma-like features can be seen. In the lymph node, usually the involvement is in the medullary and interfollicular areas. In the skin, it is a disease that affects the dermis and can extend to the subcutaneous tissue, sparing the epidermis and the adenic cell structure. Immunophenotyping is the key for this entity. And I mean by awareness in the topic of this talk is the immunophenotypic awareness. So remember with me, 1, 2, 3, 4, 5, 6. It means the CD123, CD4, and CD56. Keep it in mind. So the new WHO 5th edition and the ICC classification put a heavy weight on the immunophenotype analysis for detecting this entity. So the WHO have shown that there is a PDC specific marker. It's the CD123, TCF4, TCL1, CD303, and CD304, and commonly comes with CD4 and CD56. And the list that below is the expected negative markers. It's the lineage specific for other entities. CD3, CD14, CD19, CD34, lysozyme, and myeloperoxidase. So for diagnosing this entity, you need CD123 along with other PDC marker, plus minus one of the CD4 or CD56, and the absence of the lineage specific markers. Similarly, the ICC classification has put some weight on the site of involvement, the morphology of the tumor cells, and with the same immunophenotypic criteria for diagnosing PBDCN. I was fortunate enough to be part of the MD Anderson work, and publishing the first cohort cases of PBDCN. So we have presented 16 cases of PBDCN, and you can see here, if you see the first 4 columns, these are the lineage specific markers for PBDCN, and you can see majority of them are positive in the leukemic cells. You can see a few cases that do not show CD56, and then if you compare to the lineage specific markers, they are entirely negative for any expression of them. And please focus with me on CD34. No case is showing any positivity for CD34. The MD Anderson group have expanded this cohort, and subsequently in 2021, they have added additional cases, making the cohort 39 cases. And you can see here in yellow boxes, you can see here the lineage-specific markers are entirely, completely negative to be expressed by BDCN cases, CD3, CD13, CD19, CD34, CD64, and MPO. And again, I want to highlight on CD34, it is almost always negative in PBDCN cases. TDT, you can see some cases that are positive for TDT. What is the differential diagnosis for PBDCN? This is the list for the top differential diagnosis for PBDCN cases. I'll go one by one and to show how to differentiate and how to identify each one. So if you look at acute leukemias, specifically AML and or LPLs, whether TLPL or BLPL. So you will find a positive lineage-specific marker. It has to be detected and not meeting the immunophenotypic criteria for PBDCN. Moving to the plasmacytoid dendritic cell hyperplasia and the mature plasmacytoid dendritic cell proliferation associated with myeloid neoplasm. The first one is a benign reactive process. The second one, although it is clonal and can be seen commonly with CMML cases, here how do you differentiate with PBDCN cases? First of all, these two entities are mature, showing mature morphology. So the plasmacytoid dendritic cells should not show any immature features. No open chromatin, no high NC ratio, no sometimes prominent nucleoli. And it has to be a minor percentage of cells, and in tissue it is like an interstitial cellular aggregates or even some interstitial collection of cells. You commonly don't see there is absence of strong expression of CD56, BCL2, and SOX4 seen in PBDCN. So these cases should not show any strong expression for CD56, BCL2, and SOX4. And for specifically the mature plasmacytoid dendritic cell proliferation associated with myeloid neoplasm, they tend to show some loss of expression or downregulation of CD303 and TCL1. Last differential diagnosis for PBDCN is the AML with plasmacytoid dendritic cell differentiation, labeled as PDC AML. This is recently described. So there is, I believe, firstly described by Case Western Reserve Group. I was fortunate again to be working with them. So they have reported in 2020 and followed by MD Anderson and other group, they have shown this entity. So what is the unique about AML with BDC? So acute myeloid leukemia with more than 2% plasmacytoid dendritic cells is defined, or the definition for PDC AML. So in the Case Western group, they have shown in 7 cases that a range from 5 to 26% of the bone marrow cells or the peripheral blood are PDC cells along with the blast. The MD Anderson group similarly showed 2 to 26% with a median of 6.6% in 53 cases. So these cases are clearly AML. So you have a blast population that is more than 20%, and the diagnosis of AML is identified. Plus, you find these small population or small percentage of PDC cells along with the blast cells. To differentiate, usually RANX1 mutations are common in these entities and it's not seen in PDCN cases. And these cases have an inferior prognosis compared with AML patients without PDC expansion. So the MD Anderson group have shown like very helpful markers to differentiate between the two. So you can see here the 39 cohort of cases of PBDCN and compared to 53 cases AML with PDC. You can see here, by definition, AML PDC is negative for CD56, and you can see additional marker. You can see the CD34 is uniquely negative in PDCN. and positive in PDC AMLs, and CD4, CD13, CD22, CD25, TCL1 are additional marker, very helpful to differentiate between the two entities. This is the case Western cases. So you can see here 3 cases, each one in a row, and you can see all the cases are acute myelomonocytic leukemia. You can see a clear myeloblast population by red, clear monoblastic promonocytic population by blue, and a separate entity by purple that expressing the PDC markers. You can see here the CD123 and CD304 in the top case. The second case, you can see there is a partial expression of CD34 in the PDC cells. And it can present like in multiple pattern. You can see it as a separate like population, or in some cases is a continuum, like a maturation pattern. You feel the cells are maturing and they are forming like a one population with a maturation pattern. This is the MD Anderson case. You can see here 2 population, one with the clear PDC markers, and the other one is clear AML cells. Moving to the genetics, 50 to 70% of PBDCN cases show complex karyotype. And the most frequent mutated genes are TET2, seen in 40 to 80% of cases, followed by ACXL1, 30 to 40% of cases. Other list of mutated genes are reported. Prognosis and treatment. The median overall survival ranges from 9 to 24 months. The general approach is intensive chemo, followed rapidly by hematopoietic stem cells allo. More recent data have shown that the CD123 targeted recombinant protein drug showing very effective results, and it's approved in the United States and Europe. And it is used here also, alhamdulillah, in Saudi Arabia. And all treatment should include CNS prophylaxis. So I will conclude with the take-home message. A major barrier to timely diagnosis is the limited awareness of PBDCN as a distinct entity. So please, when you see skin lesions and CD123, extra work has to be done. And I really like the Oncology Daily when they have selected PBDCN Awareness Day, and they selected January 23. And if you think about it, January, if you'd like use the American style, they start with the month. So 1-23, so it's 123, CD123. And I conclude by this. Thank you very much for listening, and I'll be happy to answer questions.
Thank you, Dr. Al-Aid. This was really a very interesting subject and a very tricky one. Our next speaker is Dr. Abdullah Swaidan. Dr. Abdullah Swaidan is a consultant molecular genetics and hematopathology at King Faisal Specialist Hospital and Research Center in Riyadh. And he will be talking today about molecular studies in myeloid neoplasms. Floor is yours, Dr. Abdullah.
Assalamu alaikum wa rahmatullahi wa barakatuh. I would like to start by thanking the organizing committee. Thank you, Dr. Reem, for the invitation, and thank you, Dr. Muhammad, for this introduction. Today, I will be taking you through some cases, and I really like the idea of doing a case presentation because it's forces us to do more practical aspect that we can help us in real practice. So far, I enjoy many of your presentation, different thing about AML, MDS, MBN, and others. And my talk, myeloid neoplasm, is the same. So I will present cases of MDS, MBN, AML, and show you how molecular genetics help in these cases. So the concept of personalized medicine, precision medicine, has been around for a long time. And I'm happy to say that hematology and hematopathology is way advanced in applying precision medicine compared to other cancers. So if you look at other pathology field, we are in hematology way advanced in terms of using targeted therapy and helping patients with precision medicine. Still, many patients, many myeloid patients, they don't receive precision medicine. Still, a lot of patients receive chemotherapy. They don't get targeted therapy based on the genomic profiling of their leukemia. There are many reasons for that, but our job as a hematopathologist, as oncologist, is to help these patients to receive targeted therapy because there is a data-proven survival benefit for these patients. I would like to focus your attention to a comprehensive approach. So molecular alone is not the answer. You need the history, you need the morphology, you need the karyotyping, the FISH, the flow cytometry, and molecular analysis. So our job as a hematopathologist to combine all of this together to reach the most appropriate diagnosis and help to guide the most accurate therapy. Why we do molecular testing? We do it sometime for diagnosis, classification. Many of these genes has significant in terms of diagnosis or risk stratification for prognosis or for targeted and therapy. So if there is a therapy like in FLT3 or IDH1/2 or JAK2 or others, then doing the molecular is a good here. We can use molecular analysis also for minimum residual testing. So patient post-chemo or detecting early relapse can be done by molecular analysis since we can detect something before it's come to the morphology level. Dr. Heba presented this very nicely about the MDS-MBN group, and this is a recent paper, relatively recent, showing how heterogeneous this group. So you can see here the diagnosis, and you can see the cytogenetics finding. You can see all of the molecular findings, so including DNA methylation, chromatin remodeling, RNA splicing, multiple methods or multiple mechanisms for targeting this. And you can see these mutations are not specific, but they are seen throughout the MDS, MBN. You can see them sometime in AML or MDS. So they are not specific, but still collectively they target you in terms of diagnosis or prognosis. The LN guidelines is also risk classification is also critical in terms of classifying patient to favorable risk. And this is the 2022 ones where the FLT3 allelic ratio is no longer here. And you can see it's not by allelic CEBBA mutation. It's more like the BZIP domain mutation, in-frame mutation that has a favorable prognosis. And I will discuss this also in details. You will see the including of multiple of the mutation that's related to myelodysplasia related changes. And you can see that also they include multiple factors like 18, like 816 and others in terms of risk stratification. And if you find any of this adverse effect with MBM1 mutation, usually they trump the favorable prognosis of MBM1 mutation. Let's go through the cases. So case one, this is a 78-year-old female presented with anemia, thrombocytopenia, and eosinophilia. So 33% of white blood cells is eosinophilia. You can see here some erythroid hyperplasia. You see some eosinophils, neutrophils in the bone marrow biopsy. So karyotype shows 46XX with translocation 8-9. And this is the FISH. So in the first, we have a break-apart probe for JAK2. So you can see the JAK2 here is rearranged because we have separate copy. This is the break-apart. Then we have the dual color probe. And you can see this is JAK2 rearranged with BCM1. So this is different than regular JAK2 mutation. This is JAK2 fusions. And JAK2 fusion is well known to happen with 8-9 translocation in cases with eosinophilia. So this is the diagnosis in the new WHO, myeloid lymphoid neoplasm with JAK2 rearrangement. Basically, as you can see, part of JAK2, including the tyrosine kinase domain, is fused with BCM to have this chimeric fusions and will lead to continuous activation of JAK2 and more proliferation in these cases. So this is BCM1 is the most common partner, but we can have another partner like BCR or ETV6. Usually these cases will have eosinophilia and erythroid hyperplasia like one we see here. Why this is important? It's important because we have therapy. So JAK2 here testing as a fusion help in terms of diagnosis, and also because the patient can receive JAK2 inhibitors. So doing molecular test help this patient both for diagnosis and for therapeutic. And this is the diagnostic criteria for this entity in the new WHO. Next. This is a 68-year-old female presented with no energy, night sweats, lower jaw pain, and she found to have anemia, thrombocytopenia, elevated white blood cells. So she has leukocytosis. And as you can see here, we have some abnormal granulation in the neutrophils, and also we have different monocytes with different stages of maturation. So karyotype shows 46XX with translocation 312. So this was detected by karyotype, as you can see, translocation 312. And here we have two break-apart probes, one for ETV6 and one for MECOM. So the ETV6 is rearranged and MECOM is rearranged. So basically this patient has a fusion between ETV6 and MECOM, which is a translocation 312. Is this diagnostic for any entity, 312? Okay, excellent. So this patient has this fusion, and it's not specific, this fusion. So you can see 312 with many entity, including the CMML1. So basically, this patient does not have increased blast, has many monocytes with different stages and dysplasia. So this is consistent with CMML1 with translocation 312. In addition, with the myeloid NGS, we found A6L1 mutation and SRSF2 mutation, both of them, especially the SRSF2 hotspot mutation at very high allelic frequency. So CMML is well known. Almost 90% of CMML will have mutation, and in pediatric, almost 100% of them will have mutation with the NGS, especially the TIT2, A6L1, and SRSF2. But in this case, it's a CMML with translocation 312, this associated with poor prognosis. So usually finding this translocation 312 will add more prognostic significance, and we know these patients at higher risk to transform to AML. Next case, 84-year-old female presented with normocytic normochromic anemia, blast 3% in the bone marrow. You can see this, there is a lot of erythroid here. And with this erythroid, we have the famous ring sideroblast. So we have erythroid hyperplasia, a lot of dysplasia even within the erythroid megaloblastic changes. And also we have ring sideroblast. So based on this, what's your diagnosis? You don't have now any molecular, just you have ring sideroblast, you have anemia, refractory anemia, and dysplasia. So this will be eligible for the new in the new WHO to be called MDS with low blast and ring sideroblast. Once you do the molecular testing, then this diagnosis can be upgraded later. So we did the karyotype. There is two clones in the karyotype. There is translocation 18X. There is derivative 116. So it's a complex karyotype in some way, two clones. Then we have the NGS. So with NGS, we found SF3B1. This is not the most common mutation. So the most common mutation is the one presented with Dr. Hiba, the K700 codon. This is the R625L, which is very close to it in the same domain, and it's also pathogenic, well-known mutation. There is truncating mutation in AX6L1 and in B-core gene with good allelic frequency. So the diagnostic criteria now, now the diagnosis had changed. So previously we say MDS with low blast and ring sideroblast. Now, according to the WHO, the 5th edition, you need to upgrade the diagnosis to this one, MDS with low blast and SF3B1 mutation. And the diagnostic criteria for this, you have low blast, you have presence of this mutation, SF3B1, and absence of 5q monosomy 7 or complex karyotype. And there is a significant also for this mutation. So within this mutation, now we can classify this patient because they have one mutation favorable, like SF3B1, and have two mutation with adverse. So the patient has both in terms of clinical significance. Next case, 75-year-old male, recently diagnosed with MDS, with increased blast. So we no longer use excess blast, now increased blast, one. And so the patient known to have MDS, but now presented with pancytopenia, now circulating blast increased to 10%. Flow cytometry shows 35% blast. Bone marrow, as you can see, full with immature cells, and many of them are blast. So this patient basically moving from what's known to be MDS to full-blown AML. So the karyotype also shows multiple clones. So there is one clone with monosomy 18, the other clone with deletion 1q. They did MBM1 staining by IHC, and it's positive. So there is MBM1 mutation, at least by IHC. And we received the NGS, it's positive for FLT3 ITD at 3.5%, MBM1 type B at 35%, and STAG2 mutation at 75%. And this is not uncommon for cases who move from MDS to AML to have multiple mutation with different allele frequency, because they are gradually evolving. So the leukemic clone evolving from MDS all the way to AML. FLT3 is very common. Almost 1/3 of AML cases will have FLT3, and in this case, the patient, based on this finding, will be eligible for FLT3 inhibitors. So, and the best diagnosis in terms of for this case, and according to WHO, is MDS transforming to AML with MBM1 mutation. Next. A 35-year-old male presented with muscle aches, progressive fatigue, self-limiting gum bleeding with brushing, intermediate hematosis, nausea, vomiting, and night sweating, headache, watery eyes. There is no chest pain, no shortness of breath. So the history here is like typical presentation of leukemia, and evolution of the bone marrows. Evaluation of the bone marrow shows 68% blast. And you can see the picture. There is many blast and many immature cells. Flow cytometry positive for CD34, CD13, CD117, CD38, CD45, and aberrant expression of CD7. Negative for CD3, 33, and CD10. Karyotype normal, and FISH is normal. So this patient, AML, with normal karyotype and normal FISH, we need molecular for better classification. So we did the NGS, and the NGS found two mutations in CEBPA genes. The first mutation in codon 312. So codon 312 exactly in the BZIP domain here, codon 312, and the other codon is codon 77 here in the beginning of the gene. So CEBPA gene is one exon, have multiple domains. One of them is the BZIP domain from 278 all the way to 358 codon. Mutations in here has better clinical significant, favorable outcomes compared to mutations in other places. And in fact, the somatic mutation can happen anywhere in this gene, but the germline mutation usually happens at the beginning in the N-terminal part here in the beginning of the genes. And by the way, there are many mutations in the middle that are common, not clinically significant, benign mutations. So this patient will have what we used to be called biallelic CEBPA mutation. And still, this is the preferred name in the WHO. So this is from the WHO, where they classify it to double mutation and single mutation. Cases with CEBPA double mutation, almost 2.8% of AML will have double mutation. 91%, similar to this case, will have double mutation with one of them in the BZIP domain, and very few, 9% out of all these mutation have double mutation but without the BZIP domain, and there is no evidence that these have a good prognosis. It's only good prognosis if you have double mutation in the BZIP domain, or if you have single mutation in the BZIP domain. So this domain is the most critical one when it's come to prognostic significant for AML, and we can see this even here. So cases with double CBBA, double mutation, or even single mutation in the BZIP domain will have better clinical significance compared to the wild type, or if there is a mutation in the TAD domain in the beginning, where it will do worse. So not all CBBA mutation is the same. If it's double mutation, including the BZIP domain, or if it's a single mutation in the BZIP domain, then it will be a better prognosis. Last case, 19-year-old male with 1 week of fever, chills, night sweat, vomiting, anemia, thrombocytopenia, and leukocytosis. There is 42% circulating blast, so very clear this is an AML case. Skip the flow cytometry shows clear acute leukemia. Karyotype showed translocation 6-9. And when we did the NGS, we found the DEK with NUB2 and 4 fusions and FLT3 ITD mutation. And as you can see here, we have the double fusion for both DIC and NUB2 and 4, and you can see there is a fusion here, which is the abnormal clone, and this is the normal cells for comparison. So this patient doing the FISH karyotype and NGS, all of them confirm this fusion, the DIC NUB2 and 4 fusions, which is not a common fusion. So it presents in almost less than 2% of all AML, associated with poor clinical prognosis, and usually seen in young adults like this patient, 19 years old. The critical thing when it comes to diagnostic criteria, if you find this fusion, then even you don't need to have the 20% blast, because this fusion is seen usually with cases with AML. So if you find this fusion by NGS or by FISH, then it's diagnostic for this entity. And thank you so much.
Thank you, Dr. Abdullah, and I would like to ask you, as well as the other speakers, to be in the stage for a short Q&A session. And we will start, for the sake of time, because we're a little behind, to take quick questions. Any of the audience? So, Dr. Prof. Nasser, over there. Raise your hand, please. Raise your hand, please, for the question. Yeah. Okay.
Assalamu alaikum. Yeah, excellent presentations, all three of them. Just question, not really a comment, actually. Khalid did a really nice job with the PPDC, and I just wanted to, I don't think there's anything to add, but just wanted to emphasize that all the patients, may not have access to, obviously, you see anti-CD123 antibodies in some centers. So the alternative therapeutic option in such patients could be venetoclax, because they have really good response if they're positive for BCL2. So I would say that doing BCL2 marker as a prognostic marker or predictive marker would be a good idea in BPDCN cases, just for general information. And also, they have a very high incidence of CNS involvement. As you mentioned it in the passing, but just to emphasize that doing a CNS evaluation is a must, and that also alters the prognosis in these patients. That's it. Thank you.
Any comment, Dr. Khalid?
Yeah, totally agree.
Okay. So there is a full agreement with the comment. Any more questions? Dr. Reem, here.
I don't have a question, but I have a comment for Dr. Abdullah. We've always learned that AML with mutated NPM1 comes with normal cytogenetics. So this is a surprise to me. When you have kind of a complex karyotype and there is an entity where even when it's the first presentation and there's no history with dysplasia, complex karyotype, and mutated NPM1 to diagnosis at MDS transforming to NPM1 AML. So this is new to me. So this is what's the purpose of this conference, is to learn from your colleagues. Thank you.
Excellent. Yeah, thank you so much. You are absolutely right. And usually NPM1 is a de novo event, like de novo AML compared to AML that transforming from MDS. But again, this is I agree with you, interesting case where it's MDS transforming to AML and it's also acquired NPM1.
Any more questions?
Because these kind of would be like two differential diagnoses. And then AML with AML NPM1 would be a good prognosis, AML, right? But if it's AML with transformation from MDS, it would be a poor prognosis, correct? So that would make a big difference, right?
I agree, and I don't have an answer, but you're absolutely right.
I mean,
I don't know if the WHO has any recommendation for this, which and we say in the presentation, if you have a case with NPM1 mutation, with any adverse things within the LN guidelines, then this will trump the advantage of NPM1.
Yes.
Okay.
Sorry. So even in de novo AML with mutated NPM1, we see some level of dysplasia, but we don't call it MDS.
Yes.
So it is a common finding. So we should really look at cytogenetics when it comes to NPM1.
Okay. More questions? Then I have a question to Dr. Abdullah. It's a great combination for you and Dr. Reem Al-Rabih, I think the hematopathologist and the molecular, subspecialty, because, as you said, most of our diagnosis hinges on, molecular findings. So for eosinophilia, these are problematic cases when people start with eosinophilia. When people like me who are not trained in molecular genetics, the triaging of cases, especially taking into account that our centers are different in their capabilities, what is done in-house and what is sent out. Finding a way to triage all of these cases and make sure that you order the right test in the right time is a challenge. Now, for example, people now are prone to order FIP1, L1, fish with cytogenetics and all of that. Are we going to miss these cases, like the case you presented, PCM1?
Sure, yeah.
So the strategy, like probe strategy, let's say, for fish.
Yeah, thank you, Dr. Muhammad. Eosinophilia is a big subject and it can be reactive and it depends on the presentation and the level of eosinophilia. So if you have very high eosinophilia, let's say more than 3,000, 4,000 cells, then this is very dangerous. And once it's reached that high level, it can be dangerous for end organ damage and can affect the heart and other organ. So you don't want to reach to that. If the patient has persistence, then we should offer them fusion panel testing, and this is what we do. We offer them comprehensive fusion panel, so we test for all fusion, including BDGFR alpha, beta, FGFR, including the JAK2 and FIP1, L1, as you mentioned. So we would like to offer them all of this fusion to rule out the hypereosinophilic syndrome or neoplastic process of eosinophilia compared to reactive. You don't want to wait and assume it's reactive, then at the end, patient come with complications.
And with that, we conclude this session for today. Thank you, doctors, for your interesting lectures. we'll start the next session without break.
Assalamu alaikum. Thank you so much everyone for being here, especially on a late weekend afternoon. Dr. Nof Hijazi and myself, Dr. Batarfi, will be presenting the next four distinguished speakers, starting with Dr. Shamail. There will be one presentation which is going to be an online. So starting with Dr. Shamail Mohammed. So she's an anatomical pathologist at King Faisal Specialist Hospital, and she's interested in lymphoma and lung pathology. Doctora?
Thank you, Dr. Khalid. Good afternoon, and welcome everybody to the lymphoma pathology portion of today. I would like to begin by thanking the SSBMT for arranging such an outstanding meeting, and especially to Dr. Reem for inviting me to be part of the program. Now, since the organizing committee skipped the tea, I will present a case which is a piece of cake for you, so that'll be a treat. Today, in my talk, I'll take you through a situation that reminds us of an important concept in medicine, which is when the hoofbeats are zebras. Sorry, there's... Just 1 second, there's just a technical error. So I was saying that I will be illustrating a concept in medicine, which is when the hoofbeats are zebras. This concept captures those rare conditions that implement diagnostic challenges, and I'll share an example with you today. So our plot starts with Mr. K. Mr. K is a 34-year-old male who presents with skin lesions for more than 1 decade. According to Mr. K, he does not remember the last time he saw the normal skin color. So he describes that some of his lesions are watery, so probably those are the blistering lesions. And on examination, the dermatologist describes diffuse maculopapular lesions across his extremities and trunk. Finally, a dermatologist decides to do a skin biopsy. The biopsy, as you can see here, shows this atypical dermal infiltrate, and the other half shows a very minimal perivascular infiltrate. The dermal infiltrate, as you can see, goes up in the upper dermis, mid dermis, and abruptly stops at the dermal epidermal junction. It consists of monocytoid, medium-sized lymphoid cells. On high power view, you can see some of them are oval, some of them are ovoid or round, and some of them are spindly with oval to spindle-shaped nuclei, abundant granular cytoplasm. So when in the dermatopathology realm, when you see these kind of cases, there are 2 differential diagnoses that we train our residents. So the first differential that you think of when you see this dermal infiltrate in the dermis is Langerhans cell histiocytosis. The uniqueness of Langerhans cell histiocytosis is that you see the infiltrate would cross the basement membrane and go into the epidermis. The second differential that you should think of when you see this kind of infiltrate is mastocytosis. Histologically, the difference here is that the infiltrate will stop at the basement membrane, will respect the barrier, and will not involve the epidermis. So to confirm the diagnosis, the dermatopathologist performed CD117 and tryptase, which was positive. She also performed CD25, which showed a focal aberrant expression. So at this stage, we thought this is a mastocytosis. We stop at the differentiation. Clinical pathological correlation is recommended to differentiate whether it is a cutaneous mastocytosis or systemic. Now, keep in mind, when you see a mastocytosis in adults, even if it's presenting as a skin lesion, you have to rule out systemic mastocytosis. So many blood investigations, everything was normal, tryptase was normal, peripheral blood morphology was normal, flow was negative. Unfortunately, bone marrow examination was performed in an outside hospital, which was not sent for review, but according to the hematopathologist, there was an infiltrate within the bone marrow. The KIT mutation was negative, FISH negative, and NGS panel was negative. So followed by PET scan, which was all negative, and ultrasound showed mild hepatomegaly. So putting all this information together, we came up with the diagnosis of systemic mastocytosis. So since I am an anatomic pathologist, I'll concentrate on the tissue pathology part, but of course, I will touch the high points of the diagnostic criteria for mastocytosis in the bone marrow. So interestingly, the cells that cause this disease were first described 150 years ago by Paul Ehrlich, who was a Nobel Prize laureate. He described aniline positive cells within the connective tissue, and he called them Mastzellen, thinking that they play an important role in the nutrition of the connective tissue because of their granularity. Mast meaning in German as fattening. 10 years before that, the very first skin lesions that are associated with mastocytosis, which would be later on called urticaria pigmentosa, were described. The one was in pediatric and one was in adult. So after the initial description of Paul Ehrlich of mast Zellen cells, 60 years after that, the association between heparin in the tissue of increased mast cells was noted, and finally the discovery of that the mast cells themselves are the culprit in releasing the heparin and histamine, which leads to the allergic reactions. So what are mast cells? They are myeloid cells derived from marrow progenitors. They are involved in the IgE-mediated immunity due to the release of histamine and cytokines and chemokines, leading to the various hypersensitivity reactions. The mast cells, as we saw, are medium in size, can be round or oval with round to oval nuclei. This is an example of another one of our cases. It has abundant cytoplasm with granules. They might be spindle in shape. So this is a let's go back. This is another case with spindle cell, predominant spindle cell morphology. Characteristically, they're positive for CD117 and tryptase. They can aberrantly express CD2, 25, and 30, and they are characteristically negative for CD123 in the normal mast cells. However, they can be positive in the abnormal mast cell neoplasms. The mastocytosis now, it's the clonal proliferation of these mast cells that we talk about, and they can accumulate in the skin or more than one organ. The mast cells release, as we said, chemokines and cytokines, histamine, tryptase, which leads to the tissue damage and various symptoms. Various symptoms being according to the organ that is involved. So either constitutional symptoms, fever, malaise, joint pain, skin manifestations, so either the blistering lesions or the maculopapular rash, the mediator-related systemic illnesses, so either an anaphylactic reaction or a hypersensitivity reaction. It can affect the musculoskeletal system, so presents with osteopenias and even fractures. And our patient, Mr. K, that I showed you, also developed a fracture later on. The underlying driving mutation involves the KIT gene, characteristically D816V. Other mutations of non-exon 17 are also involved. Keep in mind when you have the D816 gene, they are imatinib resistant, and other non-816V genes are imatinib sensitive. The driver mutation or the KIT mutation leads to a ligand-independent activation of the receptor, which leads to uncontrolled mass growth and survival. So what is the mast cell morphology in mast cell neoplasm? You can see a various spectrum of morphological findings ranging from mature all the way to immature mast cells. The mature being either I don't have that now. So round to oval, which will be well differentiated, or spindle cells, or you can have promastocytes, which are atypical bilobated, could be granular or hypogranulated, or even completely immature blastoid with immature nuclei and prominent nucleoli. A word of caution for the well differentiated morphology. So some people think that this is an actual subtype, which is not. The mast cell well differentiated is just a variant that can be seen in any of the systemic mastocytosis subtypes. The thing to remember is that they might be negative for 2 and 25, and they express CD30. So the mastocytosis now can be divided into 4 main categories: the cutaneous, systemic, the sarcoma, and extracutaneous mastocytoma. Each one of these categories will have subtypes, and we can go through all of them. briefly. So the cutaneous mastocytosis is a mast cell disease that is confined to the skin. You can have various subtypes, as you can see, maculopapular, diffuse mastocytosis, or mastocytoma. This is the most common type that you see in children, and this is self-limited. It is commonly associated with KIT mutation. And again, remember, if you see cutaneous mastocytosis in adults, you always have to rule out systemic mastocytosis. Let's concentrate on the systemic mastocytosis. It's a myeloid neoplasm, as we mentioned, characterized by clonal proliferation of these mast cells, typically also harbor the KIT mutation, involves at least one extracutaneous organ. Almost always the bone marrows are involved. So how do you classify this case as a systemic mastocytosis? What is the criteria? Apparently you have major criteria and minor criteria. The major criteria is multifocal dense infiltrate of mast cells of more than 15 mast cell aggregate in either bone marrow or other extracutaneous sites. And then you'll have other minor criteria, for example, the morphology or the KIT mutation or the tryptase level. The WHO wants one major and one minor criteria. ICC are quite sufficient with one major criteria. So the bone marrow morphology is characterized by a nodular or diffuse infiltrate of atypical mast cells. You can see sometimes they have spindle cell morphology, and you can highlight them with a tryptase or a c-KIT. Let's see an example. So this example was a 32-year-old male who has been in the healthcare system, again, for more than 10 years. He's been going around presenting with hypersensitivity reactions and allergies to different kind of allergens, and has been admitted to the ICU for more than 4 times due to bee stings. He goes to the hospital, gets his EpiPen, refills, and goes home. Finally, one of the allergy immunologists noticed that the patient has skin hyperpigmentation and decided to recommend a skin biopsy. And you can see the skin biopsy here. There is a very minimal, as you can see, perivascular dermal infiltrate of monocytoid cells. The CD117 was positive, so it was a mastocytosis diagnosis. Because it presented in an adult, this triggered a systemic investigation, and a bone marrow biopsy was performed. This was shared with me by my senior hematopathology colleague, Dr. Randa. So thank you, Dr. So this biopsy, again, you can see the trephine biopsy, and there is an atypical lymphoid monocytoid infiltrate over there at the top, paratrabecular, and they are mostly spindle cells, as you can see, almost like a granuloma, if I have to say, and then abundant cytoplasm, a bit granular. The smears showed these atypical spindle cells with granularity within them. Tryptase and CD117 was positive, CD25 was positive, so we call this systemic mastocytosis. Now, as we said, the mastocytosis can involve other organs. For example, it can involve the GI, spleen, lymph node, liver, spleen, and spleen is more common than the liver and lymph node. Now that we know how you call a major criteria or the criteria for systemic mastocytosis, how do you come up with the subtypes that you see here? So you have bone marrow, indolent, smoldering, aggressive, associated with hematological or myeloid neoplasm and leukemia. So these variants depend on 2 factors, the B findings and the C findings. B findings being the burden of disease, and C is cytoreductive needed. So B findings is the burden or the density of the disease, and you can read here in more details that you want to see more than 30% of infiltrate within the bone marrow, or tryptase, which is more than 200, or signs of myeloproliferative disease, or hepatosplenomegaly, but you don't have, and organ damage. In contrast, C findings here, you will see end organ damage. So now you will be seeing effects of bone marrow abnormalities, neutropenia, hemoglobin and platelet dysfunction, hepatomegaly, or liver dysfunction, hypersplenism, malabsorption, or fractures. So you're starting to see end organ damage in C findings. You will combine the morphology, the clinical, the B findings and C findings, and you come up with your variants, either smoldering, indolent, bone marrow, or aggressive, or leukemia. Let's take 2 slides for the leukemic part. So mast cell leukemia means it has to meet the diagnosis of systemic mastocytosis. Here you will have more than 20% atypical cells within the smear. Those could be immature promastocyte, metachromatic blasts, pleomorphic cells, or immature cells. Again, they'll be positive for 117 tryptase. Molecular, they can be KIT positive or other non-exon 17 positive. Remember, if you have non-KIT mutations, so for example, TET or ASXL1, always remember that this might be associated with other myeloid or hematological malignancies. So in conclusion, or as I conclude, I'll circle back to my quote that I mentioned earlier, is when you hear hoofbeats, think of horses, not zebras. In other words, when you are working up a patient, we should think of common illnesses rather than rare diseases. But we all know hoofbeats are not always horses. And this is the case with systemic mastocytosis, a rare disease, mimics many common illnesses because of their heterogeneous and non-specific signs and symptoms. As we saw, they can affect the skin, the GI, liver, spleen, bone marrow, skeletal muscle, characterized by proliferation of mast cells that can be positive for tryptase, CD117, aberrant expression of 2, 25, and 30. The driver mutation is KIT and can be non-exon 17 positive. And if you have other mutations, think of associated myeloid neoplasms. And it takes an average of 6 years from the onset of symptoms till there is a confirmed diagnosis of mastocytosis. Our job is to effectively reduce the time of diagnosis. Now, but you see there is so much data around the patient's presentation, the history, and the patient's journey. And this is where artificial intelligence might play a role. So researchers using natural language processing and machine learning were able to come up with algorithms that put all this data together and put everything together and raise a flag when these symptoms, these hoofbeats, are zebras and not horses. Thank you very much.
Our next speaker is going to be Dr. Dua Al-Gaidi. Dr. Dua is a distinguished pathologist, board certified in anatomic and clinical pathology. She completed her fellowships in oncology, surgical pathology, and hemopath, and is also currently pursuing a fellowship in thoracic pathology.
Assalamu alaikum wa rahmatullah. Just make sure that the voice is clear and you all can hear me. Can you all hear me? Sorry.
Yes.
Okay. Good afternoon, everybody. First, I would like to sincerely thank the organizer for the kind invitation to speak today. Special thanks to Dr. Al-Rabih. It's a privilege to share this session with colleagues who are equally dedicated to advancing our understanding of hematopathology and lymphoma diagnostics. I would like also to express my gratitude to Dr. Vega, the lymphoma head from the hematopathology department at MD Anderson Cancer Center, who shared these cases that I'm going to present today. As you can see, we are switching gears. My talk will focus on large B-cell lymphoma with IRF4 rearrangement, rare but increasingly recognized entity with important diagnostic and clinical implications. Although it was a provisional entity in the last WHO, now it's a well-recognized entity in both the WHO and the ICC classification. This lymphoma has drawn attention because of its distinct morphologic and immunophenotypic profile, its unique molecular signature, and its remarkably favorable prognosis. These features together raises the critical questions of whether it's the time now to de-escalate the treatment intensity in these patients safely, especially in selected younger patients. To frame our discussion, I will discuss with you two clinical scenarios that highlight the diagnostic challenges we often encountered in practice as a hematopathologist. I will then expand it into a broader review of the clinical, pathological, and molecular spectrum of this lymphoma, followed by the outcome from multi-institutional study and their implication for management. So let us start with the first case, a patient who presented with a cervical lymphadenopathy. This case nicely illustrates how this lymphoma can mimic more than one entity and why a comprehensive diagnostic workup is critical in these cases. So this patient is a 35-year-old male with an enlarged neck lymph node. Head CT scan, as you can see, showed this 1.5 to 2.5 centimeter partially necrotic right level 2 lymph node. This lymph node is hot by the PET CT scan with SUV of 11.1. So out of this 2.5 centimeter lymph node, we get only this tiny core, which is the classic scenario we face as a hematopathologist. But clearly on low power, you can appreciate the vaguely nodular effacement of this lymph node by atypical lymphoid infiltrate. These lymphoid infiltrate are medium to large in size with centroblastic morphology with multiple membrane-bound inconspicuous nucleoli. Some of them also showed immunoplastic morphology. It's a very high-grade lesion with multiple mitosis and apoptotic body. So we are dealing with a high-grade lymphoma. By immunohistochemical stains, these cells are positive for CD20. It's expressing a germinal center immunophenotype. They are positive for CD10 and BCL6. And here is the surprise. MUM1 is strongly positive and uniformly expressed in every cell. Ki67, as expected, are increased with a proliferation index of 70%. This is a summary of the immunophenotype. These cells are also expressing CD5s in a subset. They are weakly positive for CD30 and EBER-ish is negative, and this excludes EBV positive diffuse large B-cell lymphoma. By flow cytometry, we were able to detect a clonal population that showed an increased site scattered. These populations strongly express CD20 and CD10. They are also positive for CD79A, weakly express CD5, and they are lambda restricted. Because of the MUM1 expression, we did additional study, including cytogenetic and FISH. So cytogenetic showed normal male karyotype. FISH for MYC, BCL6, and BCL2 gene rearrangement are negative. And this lymphoma is positive for IRA4 rearrangement. As you can see in this image, this is the patient's fish. It's a break-apart probe. So normally you have two signals together, but if they are separated, then it's positive. And IRA4 is marked with this green probe. So as we can see here, we have a rearrangement in the IRA4 gene. So we have all the diagnostic tests to make the diagnosis on these patients. Additionally, just for academic interest, we did a molecular analysis, but it's not necessary in this patient. So we did RNA-seq, which is negative for fusion. Just keep in mind that the fusion usually with the immunoglobulin heavy chain or light chain, either kappa or lambda loci, they are typically not detected on the RNA-seq. We also did an NGS lymphoma panel, which detect the RAS homology family member A, row A, with a VAF of 33%. It's not the typical mutation that we see or that we link with this lymphoma. However, this mutation has been seen in a lot of cases of diffuse large B-cell lymphoma or even pediatric Burkitt's lymphoma. So collectively, with the morphology and the immunophenotype and the FISH result, this is diagnostic for large B-cell lymphoma with IRA4 rearrangements. Just few about the patient follow-up. So the patient received the best available therapy regimen, which including the R-CHOP. And following this treatment, the patient has remained in complete remission with no evidence of disease recurrence. It's been like 7 months now, and he is free of disease. So let's discuss this lymphoma a little bit more. So large B-cell lymphoma with IRA4 rearrangement, it's a well-recognized entity now in both the ICC and the WHO 5th edition. And thankfully, it's the same name in both classifications. IRA4 rearrangement detected by FISH in most cases. Just keep in mind, sometimes this rearrangement is cryptic, so you will get a negative FISH result. If the clinical and pathological suspicion is high, you can try a different modality for diagnosis. This lymphoma accounts for less than 0.1% of all large B-cell lymphoma, so it's not common. It's typically involved the Wilder ring or cervical nodes. Sometimes, as I'm showing here in this image, it can show asymmetrical tonsillar enlargement. Keep in mind that rare reported cases involving the gastrointestinal tract, actually, it's the second most common location after the Wilder ring. Few reported cases have been seen in lung, but it's like 3 cases so far. The age range, it's vary from, we have a spectrum from 4 to 79 years with a median age of 12 years. So it's a lymphoma of children and young adult. Slight male predominance, and this specific lymphoma has an excellent prognosis with 100% 5-year survival. Immunophenotype, as I showed, they are usually positive for both BCL6 and MUM1, and combination of the BCL6 and MUM1 expression in pediatric low-stage B-cell lymphoma should prompt the screening of IRF4 rearrangement. This is very important. CD10 and BCL2, on the other hand, can be expressed in half of the cases. And this lymphoma can also express CD5 in 30 to 40% of the cases and more common in children. The Ki67 usually high. This is a high-grade lymphoma, often having a proliferation index of more than 80%. c-Myc expression can be seen by immunophenotype. However, FISH should be negative. BLEMP1, which is plasma cell differentiation marker, is negative in these cases. What's interesting to me in this lymphoma is the gene germinal center B cell type gene expression, despite the strong MUM1 expression. Even on the gene expression profile level, these lymphoma clustered with the DLBCL with germinal center immunophenotype, because most of the time we link the MUM expression with the activated B cell subtype, except in this lymphoma. By molecular and cytogenetic, as I explained, these cases showed the translocation of IRAF4, which can be detected by FISH, most commonly with the immunoglobulin heavy chain locus or the light chain. Sometimes, as I said, this can be cryptic. They should be negative for MYC and BCL2 rearrangement. If you have a BCL2 rearrangement or MYC rearrangement, this excludes the diagnosis, and likely you are dealing with high-grade lymphoma NOS. On the other hand, BCL6 rearrangement have been reported in some cases. The most common mutated gene for this lymphoma is the IRAF4, CCND3, NF kappa P pathway-related gene, including the CARD11, CD79B, and MYD88. MAP kinase and CARD11, interestingly, they are associated, when they are present, they are associated with follicular growth pattern. So, why the accurate diagnosis in these cases matter, since you probably know that the treatment strategy now for large B-cell lymphoma with IRAF4 rearrangement is similar to other high-grade lymphoma, including the DLBCL NOS and also Burkitt lymphoma. So they are treat them with the same protocol. So why does even an accurate diagnosis matter? This is happened last year. A group from Germany published this paper on blood. They claim that now this is the time to de-escalate the chemotherapy treatment for these patients. And it's a retrospective multi-institutional survey. They included in their study 75 patients, which is considered the largest series today. The median age of these patients is 10 years with equal male and female distribution. And out of the 75 patients, the majority of them presented with head and neck and pharynx, most common location. The second most common location is the gastrointestinal tract. The histology, the majority of the cases showed diffuse pattern. However, follicular pattern being seen in 20% of the cases and mixed pattern in around 15%. All of the cases, almost all, 97%, showed IRAF4 rearrangement. And MECA BCL2 is negative. BCL6 rearrangement have shown rare, detected in only 4% of the cases. Most of these patients receive a B-cell non-Hodgkin lymphoma chemotherapy. However, small subset, especially the patient with a gastrointestinal presentation, they have only complete resection and watchful waiting approach. The prognosis is excellent with a 96 overall survival. So the conclusion of this paper is that these lymphomas showed excellent outcome across all stages. And they really suggest the potential for treatment de-escalation in future trial. And it's really considered now by the oncology group is to de-escalate the treatment for these patients. That's why an accurate diagnosis and using a comprehensive panel is important to guide the therapy for these cases. And the histopathology, not the stage, may guide the therapy stratification, and watchful waiting may be visible in selected cases. Regarding the differential diagnosis of these cases, I think the most important differential to consider is high-grade follicular lymphoma, because both of them will show the same morphology. And this is an excellent review from the group of MD Anderson. They discuss the differential diagnosis of these lymphoma, and I'm going to show you this table, which summarizes the difference between these two entities. And as you can see, they are very similar on morphological assessment. The only differences is the strong expression of MUM1, which is negative in high-grade follicular lymphoma. The IRAF rearrangement is positive in the large B-cell lymphoma with IRAF4 rearrangement. It's part of the name. And BCL2 rearrangement should be negative in these cases. If you have it positive, most likely you are dealing with high-grade follicular lymphoma and not the other entity. So I will conclude with a second case that showed you the dilemma that sometimes we have, not sometimes, most of the time we have it in lymphoma diagnosis. So this patient is a 49-year-old gentleman who presented to the emergency department with abdominal pain. CT scan showed no lymphadenopathy. However, he had an elevated white blood cell count of 21 with a 68% lymphocytes. So older gentleman with a lymphocytosis, the most common differential to consider is CLL, SLL, and patient had blood flow, which we don't have, that showed a CD5 positive B cell population. However, it doesn't show the the classic CLL immunophenotype. And the patient had also mild lymphadenopathy that detected by PET scan. That's why, because of this uncertain diagnosis, a cervical lymph node biopsy was performed. And this is the lymph node. This time we have an excisional biopsy. And from low power, the architecture is preserved mostly. However, we do see some diffuse area here, and also a follicular pattern from low power. This is the high power, and as you can see, we have two distinct patterns, one diffuse on one side and the follicular pattern on the other side. The diffuse area showed the classic morphology of possible CLL, small lymphocytes with the nuclei showed clumped chromatin, what we call a sucker ball pattern. And in some area, there is like increase in pro-lymphocytes, which give this lighter area, what we called a proliferation center in CLL. However, the other area showed this follicle. Could this be a residual follicle? Yes. However, it has some monotony, and there is atipia in some cell with centrocytic morphology. Okay, so at this point, we felt that we are dealing with two populations.
1 minute left.
Okay. And by CD5's BAX5, it showed a strong expression of CD5 on the diffuse area, and the follicular area were negative. So BCL2 is positive in both populations, which should ring the alarm. So this is the first process, which is positive for MUM1, which is interestingly, and they are showing a follicular pattern by expression or germinal center immunophenotype by expressing BCL6. The second process is CLL-like. Flow cytometry also detect two populations. By FISH, the FISH result is interesting in this case, which showed the IRAF4 rearrangement. So is this large B-cell lymphoma with IRAF4 rearrangement? The answer is no, because the morphology is not good for that. We are dealing with a low-grade low-grade lymphoma, not a high-grade lymphoma. So we do favor this to be a composite lymphoma with two distinct cell population or lymphoid process: classic follicular lymphoma with IRF4 rearrangement, and chronic lymphocytic leukemia, small lymphocytic lymphoma. Just keep in mind that IRF rearrangement has been detected in some cases of classic follicular lymphoma. It's been reported. Just keep that in mind. You need to have the classic morphology of large B-cell lymphoma with IRF4 rearrangement to call it. So IRF4 rearrangement in hematological malignancy, it can be detected in follicular large cell lymphoma, especially in patients older than 40 years. And these cases might express MUM1 by immunophenotype. However, these cases lack the translocation. Other neoplasm with IRF4 translocations, such as plasma cell myeloma and CLL, also can show the IRF4 translocation, and the classic ALK-negative ALCL with DUSP22 translocation, and these have significant better prognosis. So to conclude, large B-cell lymphoma with IRF4 rearrangement is a distinct entity, common in pediatric and young adult, typically involve the Wilder ring and usually localized. Histopathology and immunophenotypically, these cases showed a high-grade morphology with combination of BCL6 and MUM1 expression. This should raise the suspicion. IRF4 translocation is the hallmark of this entity. They are negative for MYC and BCL2. And prognosis is excellent, we will see treatment de-escalation in the future for these cases. And accurate recognition is essential to distinguish large B-cell lymphoma IRF4 from morphologically mimics, ensuring appropriate prognostic counseling and therapy planning, and future prospective clinical trial are needed to define the optimal management and exploring this de-escalation strategies. And actually, there are a lot of clinical trials started now in US regarding this de-escalation strategy. These are my references, and thank you again for inviting me for this conference, and I will stay if you have more questions. Thank you.
Thank you so much, Dr. Dua. Our next speaker is Dr. Fatma Al Ahmed. She is a consultant hematopathology and lymphoma pathologist. She's working at King Fahd Medical City, KFMC in Riyadh. Dr. Nasser? Okay, sure. Okay, sorry for that, Dr. Nasser. Our next speaker is Dr. Nasser Bakhshi. So he's a consultant, hematopathologist, and the director of hematopathology residency training program at King Faisal Specialist Hospital. He has been always one of our known figures in Saudi, and currently he is the deputy director of pathology and laboratory medicine, and the current also the chair, the diagnosis and diagnostic laboratory medicine at King Faisal Specialist Hospital. Dr. Bakhshi.
Bismillahirrahmanirrahim. Assalamu alaikum. Is it loud enough? I'm seeing a lot of people still present, sticking around, the brave and determined. Alhamdulillah. Just a word of thanks for SSBMT, especially Dr. Askar's group, for organizing and facilitating this event. Thank you very much. And Dr. Reem, for inviting me, allowing me to present my cases and the topic of T-cell lymphomas. And this is a very broad topic, as you know, but I just handpicked two interesting cases. One of them is kind of a diagnostic conundrum, and the other one is just this unusual presentation, but they're just to try to cover a certain theme in a wide spectrum of T-cell lymphomas, which you're gonna know at the outset that there's how many? 35 plus types of T-cell lymphomas. So it's not possible to cover even half of those in 20 minutes. So just as I said, I will try to focus on certain theme. So let's get on with the cases. So this first case is a 33-year-old female who has no problems medically previously reported, and she was presenting with some cough and sputum and was evaluated at a medical center outside. And the hematologically interesting finding is she has bicytopenia, and she also has hepatosplenomegaly and ascites. So she was evaluated, as I said, and a bone marrow was done at that center, and they reported that it was a dry tap, and then no report was available for us to see. So she eventually got transferred to King Faisal Specialist Hospital for workup and management. So her examination revealed nothing specific except that obviously she had this large spleen and liver, and there was moderate ascites, but significantly no lymphadenopathy. So as per the initial investigation, she was concluded to have community-acquired pneumonia, sepsis. Only thing that she had is bicytopenia, so it wasn't really clear what is the cause of her having low WBC count and also platelets. So because of an absence of lymphadenopathy, a possibility that she was having a lymphoma was less likely. However, was still recommended a bone marrow biopsy. So from the WBC point of view, she has actually low counts at the beginning of her presentation, and platelets, as you can see, are single digits, and hemoglobin is relatively maintained. LDH was not too much deranged. ALK phos was higher, and the CRP was also on the higher side. Other markers I'm listed here, especially ferritin, IL-2 receptor or CD25, and triglycerides and fibrinogen. In the context of this case, as you know, some of these lymphomas, as I'm going to show you, have a consequential involvement of the hematophagocytic system, so they can present with HLH. So just to brief you about that, there was an elevation of ferritin as well as IR2 receptor. Interestingly, I mean, usually our clinical colleagues do not order EBV titers. For some reason, they did in this case. And so it was very interesting that there was positivity for IgG and very high viral load, which is very high, as you can know, 300, was it 3 million or 312,000. This is the PET CT at presentation. And as you can figure out from this image, there is a lot of bone marrow involvement, high uptake with the liver and spleen also showing uptake, liver less compared to spleen, but bone marrow is very significantly active. So it was concluded that there is a disease in the bone marrow and liver, but it wasn't specified. Is it a lymphoma or infection? This is the peripheral blood smear. Hopefully it's clear. And it does show abnormal cells. So what is striking about these cells? At first look, obviously, they don't look like blasts. So they are large. They have got more or less compact chromatin, maybe a little bit lacy in some of these cells. But the more interesting and the eye-catching finding is the presence of these very block-like granules in most of these cells, as you can see in the second picture. So this no pointer is not shown here for some reason. Anyway, it's not shown in this. It's shown pressing, but it's not coming on the light. Can you see the pointer? Anyway, so we'll just move forward. So this in high power, just to confirming the same finding. Okay, so a bone marrow aspirate, as you can see here, it is very dilute, but has these abnormal cells. A majority of the abnormal cells was the, as I shown you here in the micro picture. So these are very similar to what we have seen on the peripheral blood, slightly more immature looking in the bone marrow aspirate. What's also striking is that there were some blasty looking forms, but the granules were very prominent. And the other finding, obviously, is also very obvious, is the presence of these punched out vacuoles. It was presented today at the BBDCN as one of the cases where vacuoles circumferentially around the new cytoplasm is one of the key findings morphologically. This is not like that, but then this does have vacuoles. So we go to the flow now, and in flow, it has an abnormal population clearly. I'm not showing you all the graphs for time, sake. So because one of the things is that we did obviously analyze it very thoroughly, and the forward scatter was high, side scatter is high, CD45 is brighter. In the background, red population, which is the T cells or the background T cells. And CD8 and CD8 is present, CD3 is negative, CD4 is negative, and CD56 in the last graph is also negative. Okay, so the other markers that are of interest here is the presence of CD7, which shows partial positivity, then CD16, which is very strong, CD94. I don't know if you guys use CD94 in your labs, or we use it a lot, and then HLA-DR and CD6, as mentioned, CD16 is also strongly positive. Okay. As I mentioned in the beginning, that CD3 surface was negative, so we're interested to know whether the cytoplasmic CD3 is present. Also, because one of the key things you would like to rule out in a case which has got CD3 as being negative surface is obviously leukemia or immature population of T cells. So we did that, and we did a bunch of markers. I listed here CD34 negative, CD99 negative, TDT negative. I think 99 is listed twice, I don't know why. And so the cytoplasmic CD3 showed clear expression, though it was positive, as you can see the background, negative population. Okay. At this point, so bone marrow, let's go to the bone marrow trophine biopsy now. So bone marrow trophine biopsy, she's 33 years old, very cellular, rather hypercellular for her age, with infiltration by tumor along the whole part of the marrow with few hematopoietic elements present. CD3 epsilon, which is our cytoplasmic marker, is confirmed. So we saw on the flow perforin was showing some staining, but not really impressive. Granzyme was positive, as you can see in this picture. Okay, so we did an EBER, and it was very strongly positive in the vast majority of these cells. And so on the basis of this, next slide. Okay, CSF, by the way, was also performed, and it was construed to be positive with small percentage of the cells with a similar phenotype as I showed you on the bone marrow and peripheral blood. So just to wrap up what we saw here, and including this into the gamut of the differential diagnosis, maybe I will invite audience to just tell me what do you think so far, or do you want me to provide more information just to be interactive? Let's pick you up a bit. What do you think? MashaAllah. Why? What do you think something odd about NK cells in this? Yeah, positive. Anybody else? So we have 4 possibilities here, right? So we have NK cell proliferation, which happens in autoimmune disease, viral infections, post-transplant. It's not that, right? This is too aggressive. Yes, we have extranodal, but it's only bone marrow. It's not involving, we have liver spleen, yeah, but it's just not the picture of an external, correct? Are you talking about something like nasal, skin, GI? Sorry? No, nasal, yeah, but still bone marrow, right? Predominantly bone marrow. Bone marrow, liver spleen. Yeah, that's a differential diagnosis. And then the third one would be aggressive NK cell leukemia. We'll consider that strongly. And then fourth would be, LGL, NK cell LGL, right? No, not the T cell, the NK. Correct? These are 4 different. Anything else? Yes. So that'd be also out, right? I wouldn't think of that one. But there are these bunch of these diseases that are present in children. This patient is 33. She's not like child, but a little bit older. But these type of diseases are quite aggressive, and they can be in children, both NK and T, especially the systemic, the T cell. Now it's called a lymphoma. It used to be called LPD before. The one here, this one, systemic. This is a very aggressive disease, right? Very short survival. So, but it's not a child, and presentation is a little odd the way it's evolving. Anything else? Hepatosplenic, EBV is not gamma delta, so it's definitely auto. So we conclude, actually did say that there is, that's the reason I'm going to show you this picture, is because there's an odd thing in this flow. I'm going to come back to that. I'm sure you didn't pay enough attention to what I was saying in the flow because I was going fast. Sorry? Yeah, but the cytoplasm CD3, but your surface is negative, so that kind of takes the T cell out, so brings the NK, right? Yes, there is actually, let me go back. So because these are interesting, you'll probably see these things quite often in your practice. So it's just CD8 being present and CD56 being negative. CD8, I can explain, has been described in NK cells, and that's why I showed you that figure in the end. I'll come back to that. But CD56 negative as NK, but there are other markers, right? There's CD94, there's 16, right? The 56 is a little odd. So that's why I was a little bit surprised. Sorry? I don't know. I mean, there are 2 types of NK cells. As you know, there's the early immature ones, which is bright CD56 positive and dim or negative for CD16. And there's a more mature one, right? This looks on the mature side, which is CD56 bright, CD16 bright, but 56 negative or dim, correct? I don't know. I mean, this fits that. But these cells don't look that blasty, right? They don't look that immature to my eye. So that was the odd thing. So we didn't have really much choice, actually, to do much. Patient was doing very bad, aggressive with CNS involvement. So I did, I'll show you this thing just to quickly tell you that, yeah, there is not really much to choose between NK sometimes and T cells, especially the cytotoxic, right? There are a lot of overlap. The main thing is the surface CD3, right? We go by the surface CD3 and T cell receptor complex, which is not evolved or fully developed in NK, but it is fully developed in the T cell. This is the main difference. The others, you can go, back and forth. You can come back to, haunt you if you call it T cell. Sometimes you will say NK and it turns out to be T cell, because that's why they use the word NK/T in many instances, right? But I think T cell receptor is the key. Right? If you kind of show that there is a T cell receptor developed or T cell receptor positivity, either by flow, cytogen, or molecular, or whatever way, you even have immunohistochemistry now to do the T cell receptor marker assessment, so you could be sure that this is a T cell. Okay, that's my point. Okay, so my conclusion, this was, I presented at oncology rounds, and I sold them the set NK cell leukemia, aggressive NK cell, as Muhammad mentioned, and this behaved exactly like it was very aggressive. I'll show you the management of this patient. Just quickly to show you that the differences and markers that have been reported. This is after review of literature. There were very nice papers. I can refer to you later on. It is very uncommon, by the way. How many cases have been described in literature? Not more than 500. Okay, and I think we have only 3 or 4 cases in the entire period I have had in King Fahd, maybe even before. Also, we are not like the ethnic population. It's more common in Asians, like Japan, Hong Kong, and Taiwan and other countries, but we do have it here, but not so common. Maybe you're missing some of these. So this patient was admitted, managed with different regimens. Always, the disease never went away. Even daratumumab, anti-CD38 was tried experimentally because a lot of them have CD38 expression, and there is some studies. PD-L1 was not given at an inhibitors. That would have been a good idea. I didn't think about that time. This was way back in 2017, and the patient did not survive. Any question? We can come back to this. Anybody has anything? Anyway, we'll go to the next one. So just for the completion's sake, so these studies about molecular, maybe this is very uncommon, but we do know that something more about the molecular findings in these type of cases. This is the study, these 3 studies that kind of emphasize the molecular derangements in these. In short, there's JAK-STAT pathway involvement in majority of the cases, about 30 to 40%, which means all the 4 JAKs, JAK1, JAK2, JAK3, and some other one, as well as all the 7 STATs, STAT1, STAT2, STAT3, more commonly STAT3 and STAT5 NB, STAT3 in particular, have been implicated in the molecular lesions of this. And the second one is epigenetic modifiers, especially the ones listed here, the KMT2DA and the CREBP have been implicated quite a lot, and the limited number of cases have been studied. And then lastly, the DNA repair related genes like the P53. So we go to the next case, a little bit similar, but totally different findings. So this is a 55-year-old male and presenting with...
Sorry, doctor, 2 minutes.
2 minutes. Okay, maybe I took too long for that. Okay, so this patient has a different presentation in terms of like being more like solid tumor rather than being the leukemia presentation that I showed in the previous one. So this was treated in, operated for a mass in Jizan. After that, patient was transferred to our care, and this is a post-op PET CT, and grossly there was mass in the intestine, also 2 polypoidal lesions and ulcerated mass. And this is the histology. I'll quickly go over the histology and many pictures. Okay. Okay, so the preservation is not the greatest. As you can see, there's some autolysis. And so there's the kind of conclusion of the findings. So our differential diagnosis at that time with this presentation was anaplastic large cell lymphoma, primary intestinal lymphomas, and then others listed here. So pan-cytokeratin negative, CD20 negative, 3 positive, CD2 positive, 30 weak staining, but positive in a vast majority of tumor cells, 56 negative, granzyme positive, perforin positive, Ki67, 70%, I would say maybe more. So this is a list of the markers. So this is a case of a primary, so there was no other involvement in any other organ system, nor there was any lymph node except for the regional lymph nodes. So this was called a primary intestinal T-cell lymphoma GI tract. But what was the subtype? So this is a list of differential diagnoses I have here for you, but you can rule out some of the indolent ones clearly because it's very aggressive. And EBV, again, very strongly positive. So what do you call it now? RIM. Extranodal, right? This is your extranodal tip, but it's not common to present with the intestinal obstruction and all the stuff like that. That's didn't have any nasal involvement at all. Non-nasal, yeah. Okay, so we got this finalized. So interesting thing about this case is that it's usually not considered as a differential diagnosis. We think of primary intestinal as a EATL or METL as our differential diagnosis, but this was not that. So the point I want to emphasize here is that it's actually the incidence of T-cell lymphomas. If you look at worldwide incidence, in different regions, so it varies. So in terms of like European countries and Western countries, the extranodal lymphomas are not as common. NKT cell lymphomas are not uncommon. Whereas in Asian countries, they are the highest list of the lymphomas that, like, isn't seen in this study, almost like 30% of lymphomas. And what about king face cell? And anybody has done studies here in our setup to see what is the incidence? We did some time ago a collection of some data, but it was ages ago. I haven't updated it. And here, I think we're very similar to the West. We have EBV. It's a little bit more common than the West, but not as much as the Asian countries that we know of. So again, this patient did very well. This is the opposite of the first case. Got PEG asparaginase and GMOX and went into remission, autotransplant, and patient survived and is doing well despite COVID exposure. And this is our CT, his CT after final. And this is probably the most important slide. So you can see how many entities we have. We covered only 2 entities, very uncommon. But you have to keep this chart in your context when you're trying to solve the T-cell lymphoma conundrums, because they are not common. They will haunt you if you just try to use NK versus T and then go from one category to another. So you have to do a clinical pathological evaluation. This is important. You cannot just do microscopic histopathology as immunohistory. You have to do clinical. So these are entities that are based on what? So regional involvement, the type of involvement, cutaneous, extranodal, nodal, leukemic. And if you follow this, I think you will be safe in dealing with T-cell lymphomas, because they are uncommon. Just 12 to 15% of all lymphomas are T-cell. I'm over my time. Sorry, Khaled. Thank you very much for allowing me. Thank you. I'm happy to take questions.
Okay, our next speaker is Dr. Fatima Al-Goua Ahmed. She's a distinguished pathologist at King Fahd Medical City. She has done her residency and fellowship in both hematopathology with a specific focus on advanced flow cytometry and minimal residual disease detection. Her talk is going to be about plasma cell neoplasms.
Is it working? Oh, perfect. Okay. Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, everyone. Thank you for staying with me for the last lecture, and thanks for the organizing committee for giving me this opportunity. I'll be presenting only one case, but with extensive, conflicting, and controversial literature. So, I have no financial conflicts to disclose, but I have to acknowledge that the case material I'll be presenting is courtesy of University Health Network in Toronto, and it was kindly shared by Dr. Ali Sakhtari, and it's been anonymized and used with permission. So our case concerns a 49-year-old male who was diagnosed with multiple myeloma in 2017. The diagnosis was made outside Canada, and then he received autologous stem cell transplantation in 2019. 3 years later, he presented to UHN with pancytopenia. So the clinical concern was recurrence of his multiple myeloma versus post-transplant lymphoproliferative disorder. His bone marrow biopsy showed diffuse and interstitial proliferation of small mature looking cells. They had plasma cell-like morphology. They had the eccentrically located nuclei, perinuclear half, and rare inconspicuous nucleoli. However, to our surprise, CD138 was largely negative, except for rare weak positive cells. And on the contrast, CD20 was diffusely and strongly positive. Similarly, CD79A was strong positive, while PAX5 was largely negative, except for, again, rare weak positive cells. And then IR4 was heterogeneously expressed.
The infiltrate was also CD10 and BCL2 double positive strongly and diffusely, while BCL6 was totally negative. And the infiltrate was Ig kappa restricted with cytoplasmic expression and IgG positive. Additional exhaustive list of immunohistochemistry stains, including CD19 and Eber-ish, were all negative. So the differential diagnosis at this point was either relapse or recurrence of his multiple myeloma, although CD138 is negative and CD20 is diffusely positive, which is very unusual. And then the other differential is B-cell lymphoma, particularly follicular lymphoma might be considered given the co-expression of CD10 and BCL2, but the morphology doesn't fit, and more importantly, the B-cell markers CD19, PAX5, and BCL6 were all negative. The other consideration was LPL, and of course there are rare cases of CD10 positive LPL that have been reported, but again, the important thing is the lack of CD19 and PAX5 making it much less likely. Additional workup of the patient showed Additional workup of the patient showed multiple lytic lesions with no lymphadenopathy or soft tissue masses or thickening on CT scan. And his SPEP detected M protein of 19 gram per liter that was Ig kappa. Going back to the flow cytometry and reanalyzing it showed, in addition to the population of concern with similar immunophenotype, a small subset of plasma cells that were 138 dim with cytoplasmic Ig kappa restriction, and then analyzing the residual CD19 positive, 20 positive lymphocytes, they were polytypic for surface light chain immunoglobulins and no immunophenotypic evidence of B-cell lymphoproliferative disorder. And then the molecular analysis for mid-88 came back negative. So the preferred final diagnosis was plasma cell myeloma recurrence despite the absence of CD138. Then the original diagnostic material from 2017 finally arrived to EHN, and upon review, it showed basically the same finding with same immunophenotype and morphology. So going to the literature, the history of CD138 negative plasma cells goes back to 1993 when it was described by Ridley et al. They described that CD138 was not present on all plasma cell myeloma cells, both in cell lines and in bone marrow samples. And then the observations and reports continued for almost a decade until a significant turning point came in 2004 by Matsoy and colleagues when they described the presence of highly clonogenic cells that were CD138 negative and suggested that they might represent multiple myeloma stem cells. However, the expression of CD138 can be influenced by several factors that can lead to potential pitfalls in its assessment. And one of the factors, one significant factor is sample age, or the time from sample collection to analysis. And that was described since 1998 by Mitchell Jordan and colleagues, where they showed that CD138 was actually present in all viable myeloma cells, but it disappeared rapidly upon apoptosis, while other markers of plasma cells, including CD38, remained positive. They also showed that dexamethasone and room temperature storage can result in rapid and strong apoptosis and subsequent loss of CD138. So the conclusion of that paper was that the previous observations of CD138 negative plasma cells was rather technical issue and resultant plasma cell apoptosis. Again, in 2012, that study was reproduced by Jacob Christensen and colleagues, where they show that only CD138 positive cells are present in fresh myeloma samples. And if 138 negative plasma cells were detected, these also were annexin 5 positive, which is an early marker of apoptosis. And they report that the largest drop in CD138 expression happened 3 to 4 hours post-sample collection, which is quite early considering the in-lab processing time. They also assessed the morphology using laser scanning cytometry and showed that these 138 negative cells have apoptotic morphology as opposed to intact morphology in the 138 positive population. And then their quantitative PCR analysis of CD138 messenger RNA was equally high and positive in both 138 negative and positive subsets. So they suggested that that CD138 gene was present and turned on, and the negative phenotype was rather due to loss of protein or proteolytic cleavage rather than the absence of gene expression. On the other hand, this work, which is microarray-based analysis of plasma cells, both in normal and malignant, done by DeVos and colleagues in 2006, demonstrating the hierarchical plasma cell maturation from plasma cells that starts by downregulation of B cell markers CD20, 22, and 24, and then upregulation of CD38 starting from the plasmablast stage, while CD138 does not appear to be appreciable until later stages of maturation of plasma cells, particularly in the bone marrow. Further, in this study done by Carrick's and colleagues from 2010, they analyzed the peripheral blood from adult healthy donors and identified circulating plasma cells that had heterogeneous expression of CD138, with approximately half of them lacking 138 expression. And then they fact sorted these cells and assessed the morphology and found that both subsets, 138 positive and negative, had typical and normal morphology of plasma cells. They also assessed the viability using annexin 5 and found that both subsets were equally viable and the annexin was negative in these cells. And then in their extended immunophenotypic analysis, they found that CD138 negative cells had less mature immunophenotype. Particularly, they had lower expression of CD27 and higher CD45, with a little bit of residual CD20 and surface immunoglobulin compared to the CD138 positive cells. In the literature, there are a few case reports of completely negative CD138 plasma cell neoplasms, and here are 5 of them that were reported between 2015 and 2020. And looking at these cases, they varied. Some of them were newly diagnosed, while others were post-autologous stem cell transplantation relapse. And one of them, interestingly, they claimed that the immunophenotype shifted from being 138 positive to 138 negative while on chemotherapy. And some of these cases reported the absence of 138 using both flow cytometry and immunohistochemistry, but the last 2 only by flow cytometry, with no mention of the immunohistochemistry result. And I should also mention that none of these case reports commented on the freshness of the sample except for the first one, and they specified that the sample was analyzed within 1 hour of collection. And then moving on to the presence of subpopulation of CD138 negative plasma cells in multiple myeloma, this was reported in many studies over the past 3 decades with variable results. This one was reported by Kawano and colleagues, I believe it was from 2012, and showed highly variable percentage of CD138 negative cells ranging from less than 1% to over 91%. And then they also showed that the percentage of CD138 negative subset to be higher in those with relapsed and progressive disease. They also sorted their newly diagnosed patients into CD138 low and 138 high, and found that those with lower CD138 expression to have worse overall survival, as shown here in the graph. And then they went further and used one of their multiple myeloma patients and that had decreased CD138 expression and created two cell lines, the first with CD138 low expression and the other with high CD138 expression. Comparing the two, they found that the low CD138 cell line to have plasmablastic morphology and less mature immunophenotype with higher CD45 expression. And then they also assessed the expression of CD138 gene using RT-PCR. And this time they found that, in this paper, they found concordant results in both cell lines with the phenotype. And their gene expression studies also showed that these CD138 low cell line had higher levels of B cell transcription factors, particularly PAX5 and BCL6, while plasma cell transcription factors, including IRF4, were low. So all in all, it all was in keeping with less mature characteristics of these 138 negative cells. They also compared response to anti-myeloma agents between the two cell lines, and while both had equal response to bortezomib, the low CD138 cell line had a less was less sensitive to lenalidomide, and they attributed that to the lower IRF4 expression in these cells, as it is a known target or a key target for lenalidomide. This is another study that basically showed the same thing with less mature with variable expression and less mature immunophenotype. But in this one, they found no relationship between the disease stage and the percentage of CD138 expression. And while not commenting on this study on the gene expression of CD138 or the viability of the cells, they reported the negative effect of freeze-thaw cycles and permeabilization on the expression of CD138. This is another study that also showed basically similar results, but also reported on the tumor-initiating capacity of these CD138 negative cells. And in fact, the role of CD138 negative cells in multiple myeloma disease initiation and propagation, or the clonogenicity, has been studied by multiple groups with conflicting results and controversial. So it remains controversial topic. But here I'll be talking about two studies. The first one is the Matsoy and colleagues from 2004 that I mentioned earlier, and the Hussens and colleagues from 2012. Both studies included in vitro and in vivo experiments with the in vivo xenografts had different SCID mice models, and then they both demonstrated that CD138 negative cells had higher capacity or greater capacity for colony formation in vitro and disease propagation in SCID mice. However, in the Matsoy study, these CD138 negative cells were shown to be 19 positive, 20 positive. So the conclusion of that study is that the stem cells of multiple myeloma are B cells that are 138 negative B cells with the ability to replicate and eventually differentiate to malignant 138 positive myeloma cells. While in Hussein's study, the CD138 negative cells were 19 negative and 38 bright. And in contrast to what was reported earlier, the CD19 positive cells in this study were unable to form colonies or engraft in SCID mice. So their conclusion was that the clonogenic cells in multiple myeloma are rather plasma cells and not B cells, at least in a subset of myeloma patients. So in summary, it seems what I gather from this literature is that CD138 negative cells seem to exist both in normal physiology and in multiple myeloma, but how common they are and their clinical significance is still unsettled. And it seems that the call for CD138 is method dependent with higher sensitivity to pre-analytical and analytical variables. So what appears as CD138 negative subset might actually reflect dying cells rather than truly biologically distinct subset. And then most of the studies were flow cytometry based with no comment on immunohistochemistry. So we don't really know how these results reflect or apply to immunohistochemistry. And lastly, regarding the clinical significance and the association of CD138 negative cells with relapsed or progressive disease or worse overall survival, I think that raises a question whether these are truly undifferentiated or stem cell like cells that behave differently and more aggressively, or they were just aggressive tumors to start with that ended up having more apoptotic cells and subsequent loss of artifactual loss of CD138. And these are my references. And thank you for listening.
Okay, so we will invite all the speakers, please, to join us for any questions from the audience. I don't know if Dr. Dua is still on the line.
Yes, I'm still on the line.
Okay. So it seems that like everybody's satisfied with the last session and nobody has any questions. We would like to thank you all for your participation and for staying out late this afternoon. Thank you.
Thank you. At the end of this beautiful and highly scientific session, I would like to thank many people. Some of them are behind the stage and many of them are here. I would like to thank all the attendees who stick to the end of at the end of this day. Today we had 191 plus attendees who physically attended this session, and there are many who joined the streaming on YouTube. And I would like to let you know that the sessions will be available next week. All the presentations, you can watch them again and you can share them with your colleagues. And if you are interested in any topic, you can go back to the sessions. I would like to thank all the speakers. We have 15 speakers today and 6 moderators who give their time to give this day its meaning. Thank you to all. I would like to thank Noor. Noor, thank you very much, and your team. Really, you make this day, 2 days, very possible and very successful. And we really, you really orchestrated many things, and you and your team, really very, very thankful. I would like to thank the audiovisual company who managed to, coordinate online and attend and on the spot. That was very good from all of you. At the end of this day, thank you very much, and we'll hope to see you next year, inshallah, in another city, maybe Dammam, or maybe Medina, or maybe Jeddah. Inshallah. Thank you all. Thank you very much. Thanks also to you. Thank you very much.